CONCLAVE. This gathering reflects our shared commitment to advancing collaborative research, promoting scientific innovations, advancing evidence-based medicine for children with neurological disorders. We are truly privileged to be joined by an illustrious panel of leaders whose vision and contribution have shaped the future of pediatric neurology. It is my honor to acknowledge the presence of Dr. J.S. Rao, sir, Managing Director and co-founder of Yashoda Hospitals, our esteemed past presidents of AOCN, Dr. Veena Kalra, Madam, Dr. Rekha Mittal, Madam, Dr. Shifali Gulati, Madam, and current president of AOCN, Dr. Lokesh Lingappa, sir, and President-elect, Dr. Mahesh Kamte, sir. Dr. Venkat Ramkola, sir, Medical Director, Yashoda Hospital, High-Tech City. Dr. Sunil, sir, Senior Vice President, Medical Services, Yashoda Hospital. Ms. Megha Chitkara, Madam, Chief Executive Officer, Yashoda Hospital, High-Tech City. We are deeply grateful for your presence and for your continued support in advancing child neurology, research, and academic excellence. May I now request the esteemed dignitaries to kindly come forward and grace the dais for the inaugural ceremony. Madam, Dr. Veena, Madam, please. Welcome, ma'am. To formally commence the inaugural session, I have the honor to invite the President and my mentor of Association Child Neurology, Dr. Lokesh Lingappa, sir, to deliver the presidential address.
Thank you very much, everyone, for accepting our invitation. I know initially there was hiccups. People were trying to understand why we are going, what are we going to do. A lot of discussions were there. And it's an initiative which everybody wanted to do, which we have just started. I think at the bottom of heart, when I spoke to lots of you people, everybody were thinking at some point or other we should initiate this, do something about it. So NHPI is only one part of it, but I think we'll have discussions over the next 12 hours as to what are the different aspects of pediatric neurology we are going to do the research on. And today, I wouldn't have been standing as a president if not for Professor Shifali Gulati, because she was the one who pushed me, actually. Almost called me 3 times on that last day of application that you should put in your paper, you should put in your paper. So thank you, Shifali. I think I'll make good use of it. Thank you. And I met Naveen last August in a meeting in Chennai, and I requested him, please be my secretary, we can do good work together. He kindly accepted. Thank you, Naveen, for that. And we are able to start something off. Hope we'll continue that. And it is a great honor to have all of you here. Hope we'll make a difference to the quality of pediatric neurological care for decades to come. Thank you.
Thank you so much, sir, for your inspiring address and for setting the vision for this landmark research conclave. It is now my privilege to invite Dr. Veena Kalra, Madam, past president of AOCN, to kindly address the gathering.
Hello, good afternoon. It's a great pleasure to be here this afternoon. To see the great hospital come up, that's a pleasure too. To meet our AOCN members, and once every year, but this time on a very new initiative, an initiative that was much required and I hope will unfold a new chapter in the history of AOCN. So to begin with, I must say that AOCN had very humble beginnings, starting from rooms in the All India Institute of Medical Sciences, connecting with neighboring medical colleges, other apex institutes, all of whom had a very great bonhomie to create this formal association. But what happened after that is that it catapulted to an amazing height with the multitudes of students that passed out, not only from AIIMS, PGI, from other places doing their DNB, doing fellowships, doing training at various levels. So there were formal degrees, there were formal diplomas, there was informal training, but everything culminated in everyone wanting to create a better tomorrow for children with neurological needs. And that's the story of AOCN. We've had past presidents, each of whom have done a wonderful job. Somebody has contributed towards international conferences. Others have contributed to creating research in various verticals, which is our past president. And the current president, Dr. Lokesh Lengappa, I must congratulate him for a new vision and a great vision. I hope this vision really, can I have the last slide of my presentation? Can you put on just the last slide? So the way I look at this initiative is that it's an off-track initiative. It's something that we lagged behind looking at the international context and content, where research was done at individual levels, individual colleges, individual peoples, small group of peoples, but never had an opportunity to gather the momentum of the country. We are a huge country. We are hugely trained. We are extremely well trained. We have a lot of energy. Like our country, we have the demographic advantage in child neurology. Our people are young, they are initiated, they are robust, they are willing to talk to each other, they are willing to collaborate with each other, and I think therein lies the strength. And we must, Lokesh, harness this strength to bring about greater bonhomie amongst everyone to produce a result from this. We must figure on the international scene in terms of research, which is what your vision is, and it's a great vision. We respect it strongly. I would say that research everywhere, I don't look at it as research, which means research whatever is already searched in the Indian context. That's no research. But when you do look at your own country's problems, you try to resolve them, you look at them in depth, you see what pains every child, every community, which is very unique in India compared to the rest of the world. Not only is it so economically, not only is it so geographically, it's also related to our family ethos, which bring about a very different kind of environment and a different disease set in children. And bringing all this together means that we have to do our own internal research to bring about family factors, geopolitical factors, economic factors, and realize the pain points in our population. So I think this research input should really focus on pain points. And we must aim to answer simple questions. And when you begin to answer simple questions, you begin to have great results. A research which is focused on answering a question is truly the one that is really a good research in our context. So like you've chosen NHBI, and I respect that as a great choice. Our young population, not only with HIE, is compounded very strongly and very innately with hypoglycemia at birth, often indistinguishable from each other, often compounding each other, yet at the same time, this aspect is an extremely low-lying fruit. It's highly preventable, and it's yet not prevented. It's not even listed in the discharge slips which the newborns carry. So therefore, there's a huge gap that happens, that they even fail to document whether the newborn went through a true hypoglycemia. Was that hypoglycemia for 5 minutes, 10 minutes, 10 hours? You never get to know in any of the discharge slips that you get. So therefore, your research will, I hope, really focus on getting data in terms of all the unanswered variables that produce disease. So I would look at this as the tree of the AOCN, which is yet to gain momentum. We have at the lower end a population, that's our country's population, which has very unique indigenous problems which are innate to our soil. Then is our next, at the extreme end, is our trained manpower. That is our extreme strength. We have people who are trained as pediatric neurologists. We have people who are, as pediatricians, have taken great interest in it. And we have people at grassroots levels who are now beginning to take interest. If you look at the national centers, district centers, there are people who raise a lot of issues at the district level and seek answers from at very higher levels. So I think there's a huge trained manpower from formal training to informal training and initiative. So I think that's the strength that the association has. So we have population's needs on one side. We have a hugely trained manpower at various sites. What we lack is a conglomeration of the manpower to look at each other and create messages for downstream. I think this is what our research should create. So therefore, the trained manpower should be used to alleviate, should be used to create downstream messages. Choosing NHBI as the first initiative, I think it's a very, very laudable choice. There will be many more seeds that can grow into a tree. So when you look at the tree, what do you look at? You look at what is the fruit it's going to bear. So I think when I look at research, it's not like what I'm going to do to grow, make the tree grow. It is what is the fruit that I expect out of that tree once it's fully grown. And that research should really bring about a change in the life of individual children, should bring about some change in the policy matter relating to governments, should bring about advocacy related to child health. So therefore, there are many things that happen. If we see the changed scenario of the country today, there are 813 medical colleges. So our trained manpower has the capacity to interact with them, to elevate their level, to reduce neuromorbidity in the community. By maybe just sending them messages, you don't need to go and individually train them, but I think sacrosanct messages that you derive out of your research and out of your efforts, you should link up with the new medical colleges that have come up to create a set of doctors who are better trained to handle the population. So that's where I look. Your intellectual input should go downstream to the various new medical colleges that have come up. The third aspect of this research I see is as creating regional centers of expertise. Every center cannot do everything. And there are different strengths in different centers. And I think it may be a good idea to collate your strengths at various centers together to see how do you create centers of regional expertise. That is how most West has advanced. Every place has not done research in everything. They have all created regional centers of expertise, and therefore you develop a system of referral to each other. You develop a system of elevating levels. So this is, I think, the third thing that I feel. What you've done well is to have international collaboration. There's a lot to learn. We don't need to make the same mistakes to learn and go on that path. So going through good international collaboration is a great effort. So with this, I congratulate you, and I wish all of you a great time ahead. And along the journey to produce a change in the lives of children. Thank you.
Thank you, ma'am, for your insightful reflections and practical vision for this conclave. May I now request Dr. Rekha Mittal, madam, past president of AOCN, to kindly address the gathering.
Where is the presentation?
This vision.
Okay. So, this came as a little bit of a surprise. So, good afternoon, everyone. I welcome you all on behalf of my mentor, friend, philosopher, guide in every way, and who has given her shoulder for me to climb up. So, so it is. Of course. No, I think you have given your shoulders to many people, and everybody has climbed on it, and still you stand strong. So I think Dr. Kalra has said many of the things, almost everything, and welcome everyone. I hope you have a great interactive session, and I think research is extremely important. This idea, I was just telling Lokesh, we thought about it for a long time, and then we said, nahi ho sakta, and gave it up. So congratulations, Lokesh, for having the courage and guts to take this subject up, because it is going to bring out a lot of controversies, as I see, and it can scare away many people, but not you. So I think with that, welcome everybody, and looking forward to a great interaction with everyone.
Thank you, ma'am, for wishing us all well. May I now request Dr. Shefali Gulati, madam, past president of AOCN, to kindly address the gathering.
Good afternoon, everyone. Welcome you all for this new initiative, which has been thought of for a very long time. Yes, Dr. Kalra is my official mentor too. So I don't know, there's no need to compete with her. She's mentor for many, but I mean, because she was this my teacher from AIMS, and when we started the, under her, we started the first DM Pediatric Neurology program, and half of you in the audience are from that tree, and the rest of them are second generation of that tree. So I think that is something really amazing. One thing I just want to tell you, that we sometimes collate research, and even we should inculcate in our residents that, everybody will come, they'll review articles and say, this has been done in the West, so we will do this like this in the thesis. That's not research. I mean, why do you think it will be different in our society, something which in our situation than the others? This is not research. I mean, this is just trying to do a normal thesis half-heartedly. Why cannot we generate ideas and do, and as ma'am pointed out, and even in that slide on epidemiology when I'll be talking about, we have so much socio-cultural sensitive and situations which are there, and the risk factors which are there. We should be the ones. Why don't we produce papers in Nature Medicine and all? Why are we only trying to replicate what is being done? So I mean, that is very good. And one thing is there, how AOCN will help, and I really appreciate that Lokesh is taking it forward. It's because we are very privileged to be in AIMS, New Delhi. So, and in many other hospitals where you have a research atmosphere. But in many of the smaller places, you do not have. So in this situation, like you have a spoke sort of wheel, so in every place, so that will be like PGI would be there, then PGI would be catering to everybody, around in that geographical region, and provide support, in that situation, and can do a collective, can be the hub for that. So it will be like a hub and spoke model, and so that everybody is empowered to research and contribute to research. That is where institutions fail. That is where associations will play a very important role, and you all are going to play an
important role. I wish everybody all the best, because everybody has to contribute, and it's only not, as Lokesh had written in the WhatsApp group, it is going to be the beginning only, and it is not going to be the end. So it is going to be beginning, and this NHBI actually was even discussed in the research vertical during Dr. Anayata's time, when myself and Lokesh were there in the research vertical, but it never could take place forward. So I think this is really good, and there are many more which have to be taken. But we should understand that we should be different. We should be answering definite research questions. You have to have research questions, then an hypothesis, and prove. You don't have to replicate something which has been done in the West. That is not research. As ma'am said, a research is not that, and duplication of something being done is not. So please think something novel about it. Thank you so much.
Thank you, ma'am, for your wise words and great insights. Now I call upon Dr. Venkatram Kola, sir, Medical Director, Yashoda Hospital, to just address the gathering.
Good afternoon, neuro colleagues and friends. I hail from the same kind of medical fraternity for the last 20 years, now into a SUS of medical admin and Director of Medical Services. I extend my warm welcome to all of you, and I thank OSN for actually choosing and giving us an opportunity to host this. And as we have already heard about the different hurdles and the way we progressed in research from our medical school days to till date, I think that has not been imbibed as a culture. It has been just given as a dissertation or a thesis topic to us to just complete for the sake of tick marks, but never been as a integral part of our training, moduling and all. I think I thank Dr. Lokesh sir and all the senior fraternity here actually bringing and this idea and starting this research registry. And real world, I think research is going and gaining the popularity more and over the different meta-analysis or systemic reviews, which can happen over a time with AI being involved, and they answering the question less than a day or less than few hours, which used to take years to gather. So now that is getting out, and this kind of registries and maybe real world question answers and research will gain more popularity over a time. And I congratulate all of them, and I wish my best wishes for this registry, which is the beginning, will actually seize more future and lights in the upcoming years. Thank you all for joining us.
Thank you, sir. It is now my distinct honor to invite Dr. J.S. Rao, sir, Managing Director and co-founder of Yashoda Group of Hospital, to deliver the inaugural service.
I thank the organizers of AOC and Research Conclave for giving me this opportunity to talk to you. I welcome all the guests who has come here, all the senior people and all the delegates. And I really respect this specialty after seeing Dr. Lokesh Lingappa. When we invited him, I thought it is another branch of neuro department. Generally, adult neurology is a very lucrative subject. I don't know whether I can tell this or not. You have plenty of money, plenty of patients, plenty of whole things are going on well. I thought calling this Lingappa is a another extension of it. That is only we thought of it. Never thought this is so much. Then he gave a list of things what he wants. We said, okay, hospital is a little financially well off, so then he did something like some training center. I don't know what he wanted. He did that also. Then I started observing what this Dr. Lingappa is doing. Arey boss, it is very stressful job, I tell you, please. I congratulate all of you for taking this. Somebody has to do. But till, though I was a pediatrician, because somewhere I went to Austria and somewhere in 1980s. And there I have some referral hospital I stayed for 1.5 years. Whatever I learned there, when I came to India, I saw that won't work out at all. Because they told about congenital abnormalities, cardiac problem, the pediatric cardiac. What? When I came here, there is only viral fever, diarrhea, dysentery, this and that. What I did is I went and worked in a government hospital for 1 year after getting trained there. What I learned here is much more useful than what I have. I really appreciate you people for taking this specialty. Please advise your junior not to take this specialty if they want. I am not joking. Only people who are passionate, people who really wanted to do some change to the society should take this job. I am not trying to praise you in this. I am telling you what I really think of it. I am 75 years old. I can't tell a lie. I tell only what comes to my mind. But having said this, it's a remarkable job, whatever you are doing. And combining all your research into one area definitely will bring up something better. 100%. 100 brains, I think more than 100 brains are there. If you bring it out, I was just asking them, madam, whether you are going to do the research in the treatment part or preventive part. She said upstream and downstream. So both you have to do it. You have to prevent, you have to also treat. So probably you are in a very different and very taxing, blessing from the God. I can tell you this much. Why I am also really a little emotionally connected to this department is, my daughter had a son who is ADH or something like that. And you should see her worry. If the boy is nice, he goes to the school, he studies well, he plays well, everything is good. But he has some ADH problem. But compared to that, what I have seen with Dr. Lingappa is something enormous. I think it is not only stressful for that, parents, it's also stressful for the staff, stressful for society, stressful for doctors also, stressful for organization also, sir. I wanted to tell you that.
But I'm sure revenue must have spiked.
No, madam, revenue doesn't work out in this. Please understand this. No. I tell you, there is no revenue for you, there is no revenue for hospital also. Forget about that revenue. But revenue in terms of blessings is there. God is giving blessing, children are giving. I am telling you, I have a grandson. No, it doesn't matter. Madam, corporate sectors, patients are paying your services. Government is paying for you for your services. So there is no difference. We are all treating a patient. You are not treating free. You are getting some for your livelihood from the government. So there is no much difference. In corporate sector, they are paid a little bit more because they have to take more stress and strain, madam. You don't have to take that much of strain in a government sector. So don't misunderstand. No, let us be frank enough. What is we should tell. Why people go and join government sector, I don't want stress. I also thought the same thing. I don't want to take the stress of running a hospital. I started a clinic, but I got bored and entered into this, and then I can't sleep well also because there are some 10,000 people working with us. There will be some 10,000 problems every day. What can we do? So it's a proportional. Anyway, all things put together, I really congratulate from my whole heart. And I also wish that this conclave will give something better for our society, either upstream or downstream, as madam said. Prevention and also cure. Both are very essential. Now, if prevention is also possible because nowadays I think deliveries are coming into the hospital sector. And sir, I tell you, there are some funds available with us. If you want to train the ayas, the bird boys in the village, there is some Asha workers are there. We can call all of them. Train them well. It will help a lot. Because madam, I don't know about this downstream, but this is very stressful stream. I cannot swim in this. See, if it is anything, even one patient can be saved or solved. I think we should do, sir. This is 100% we should do. We should do it in a scale. Don't do it for small scale. You should scale. And I am telling you, all ASHA workers of all this state you want to bring here, I will bring it. Or we can create a system where we will bloody go there, tell them, this is what, 1, 2, 3. So I am a practical person, we have to do whatever is possible. Writing papers is, but what is goes to the public is also very important. That is one. Second thing is research. As madam said, you should do it for our sake, not for copy somebody else. It is correct. Because when I was in 80s, when I was in Vienna, they had a big announcement. There is one case of measles, please come and see. Everybody doctors rushed in to see one measles case. I didn't go because every day I see measles in India. Why will I go there? So whatever we have learned there is of no use. In my 30 years, I never could utilize that. So probably we have to customize our thinking. You take care of ASHA, that's what I told. That will help more than any other thing in the world. So we have to customize our R&D to the requirement of our society. That's what I think. Thank you very much for giving this opportunity. I thank Dr. Lingappa bringing all the senior people here, and definitely this should bring some help to the society. Thank you, sir.
Thank you very much, sir, for your inspiring address. We are grateful for your leadership and unwavering support for academic excellence and research. May I now request all our esteemed dignitaries on the dais to kindly join us for the ceremonial lighting of the lamp.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः
Thank you, everyone. With the ceremonial lighting of the lamp, I'm delighted to declare the first AOCN Research Conclave formally inaugurated. I wish you all an enriching and a productive scientific program. Thank you. Dr. Vineet. Introduce yourself.
Very good afternoon, one and all. I'm Dr. Vineet. I'm a pediatric neurology resident under the mentorship of Ramesh sir and Lokesh sir. So, with the completion of the ceremonial lamp lighting, without further ado, we'll directly dive into the sessions. Before that, as a student, this is truly a dream come true to be under one roof with so many pioneers in pediatric neurology. This is truly a goosebump moment because all of you have truly shaped our lives as students and inspired us to be better clinicians. So truly hope that whatever we are going to learn, whatever discussions we have, whatever the knowledge we are sharing in the next 2 days is going to help us modulate our practice and really help improve the health of children in our nation. Beginning with session 1, this will be the inaugural vision session. I kindly request Dr. Shiji ma'am and Dr. Prashant Uttej sir to grace the dais. I also request our speakers, Dr. Rekha ma'am and Dr. Lokesh sir, to take the seats. So you'll be starting. I now request Lokesh sir to deliver the speech on the requirement of a robust national information collection system.
I think whatever the discussions we have already had, I was telling that this was the most very limited talk I have prepared because this is not very important. What we are going to do to make this registry process to go on is most important. So we being a country of 1.47 billion, we need to look at how we can harness our strength and work together. We are the most diverse in the world. But if we can show that we can work together, then we'll be able to do a great job. And we can do it at the very enthusiastic turnout of so many of the pediatric neurologists. The biggest thing is with every weekend there is a conference today. And despite that, seeing so many of you here is a testament that we are going to be able to make a change and make a difference to the data collection. So why do we need numbers? All policies, whatever in the government, are influenced by what percentage of population is affected and what is the impact to the society, shorter and longer term. What are the longer term financial implications for the same? So each child with autism or each child with hypoglycemic brain injury, drug refractory epilepsy is going to have a significant long-term financial implications to the society. So that is what we need to try and capture. So once you show the numbers, then we can talk to the policymakers. Otherwise, nobody is going to listen to us. So that is important. And what areas need research? We are going to have a long deliberations on that. Almost every area needs to be worked upon. I think there is a typing mistake. Common disorders are static encephalopathies like cerebral palsy and related disorders. Disorders with clear therapeutic implication. So something is already available. You need to know how many cases are there, where we can start the treatment and make a difference. Emerging therapies like gene therapies or other kinds of therapies where you have already lined up. Okay, I have around 250 children with Dravet syndrome. So gene therapy is coming up. So you showcase to the world that you have 250 patients. The centers or the areas where their patients are there and 50% of them are fulfilling the criteria. Automatically the world is going to come to you and say, yes, we want to get involved, and the gene therapy might come, is just starting in US, it might come here as well in the beginning, or any other kind of disorders. So disorders which can be prevented like SSP, NHP, rabies, etc. So we need to work on that so that if you say that these are the things which the preventable disorders and what needs to be done to prevent that. So all of these aspects have to be looked upon while working on it. So they can be looked at different areas of research, categories of research, and then work on that. And we have extensive deliberations on that with the expert working groups, looking at what are the different areas, next 3 areas of research which we are going to decide on. by tomorrow we'll have that clarity. After an HPI, what are the 3 areas of research we are going to take up? And it's time to join hands together and make ourselves proud with what we can do together as a nation. I think that is what we're here today. And work starts today and continue for decades. Thank you.
Thank you, sir, for your insights. Now I request Dr. Rekha ma'am to deliver the speech on AOCN Vision for the Future.
So, good afternoon, everyone. Here I am again. So, being just one of the many founders, past secretaries, and past presidents, it is indeed an honor that the organizers invited me to speak on what the vision for pediatric neurology should be. It is only fitting that I start with these 2 papers that came out from the Indian subcontinent, one from India and one from Pakistan. And according to these papers, it came out something that we already know, that pediatric neurology disorders are basically mostly chronic conditions like epilepsies, neurogenetic disorders, developmental disorders, and sequelae of acute disorders, as well as acute conditions, but many of these leave permanent sequelae and ultimately end up as chronic conditions. So child neurology, like the director before me said, it's an especially challenging field. There are very few happy endings, and especially the youngsters might feel a bit disappointed and apprehensive, or those who are not in the field may feel it's not, rewarding enough. But our happiness comes from shared difficulties that create lasting bonds, not only with the families and the children, their parents, etc., but also from our colleagues with whom we have to interact very often. So these bonds are so deep and so close that I think our reward comes a lot from this. So what are some of the characteristics of pediatric neurological disorders? One is that they're very chronic, and they're often associated with varying degrees of physical, intellectual impairment and disabilities, and often require assisted living, not only during childhood, but throughout adulthood. Very often they could be progressive, or they could be regression in many cases. There is always a possibility of early death. And you know what? This is often more devastating to the family than the sudden loss of a child in an acute illness. The comorbidities are often intellectual disabilities, behavior problems, communication problems. And these can impair interaction between the child and the family. And this can cause a cycle of detachment, neglect, guilt, and emotional distress, which may not be seen in disorders of other systems. And no matter how much we investigate, the etiology often remains unknown. And the parents are some of the parents are so occupied in finding a cause that they end up neglecting their child and forgetting that the child also needs care. So this fact was recognized by the Child Neurology Society in US way back in 2005. And they felt that the characteristics of practice of pediatric neurology is such that in the future we are going to have a shortage of pediatric neurologists, and this has been borne out by a 2024 workforce study analysis by the Child Neurology Society, again in the USA. Additionally, so what is it that makes it difficult? That one is that its characteristics are, complicated. And what has also happened that there are so many recent advances which have revolutionized the practice of pediatric neurology. We started understanding the pathogenesis better, we have better diagnostic capabilities, the treatment options are more sophisticated. But does it actually make practice easier? Are we doing more for our patients or less? And are we forgetting humanistic practice along the way? So all of these are factors which can sometimes bother people in the pediatric neurology world. Also, pediatric neurology is a teamwork specialty. There's so many people involved, and we'll be holding hands with many of them in our journeys when we treat the patients, sometimes right from birth till adulthood. And this may make some people feel that it's too messy, it's too complicated, how do I achieve it? And also, very often people forget that primary pediatricians, adult neurologists, intensivists, they're all part of our team as well. So what should our vision and mission be for all organizations working in pediatric neurology? It should be, like Dr. Kalra said, to ensure that every child in India has timely access to high quality, also affordable, and evidence-based neurological care. So is this mission accomplished? So let's see. There are some deliverables and some limitations. We would love to have early diagnosis for all, advanced treatment, multidisciplinary rehab, research innovation, equitable healthcare delivery. But like Dr. Shefali pointed out, they're almost like two dichotomized systems. One is the government system and one is the private system. Early diagnosis for all is limited in both sectors by the limited number of centers and pediatric neurologists in the country. Advanced treatment for all is easier in government setups because of low cost. In private systems, they often, if it's very expensive, crowdfunding may be the answer, or some NGO, or somebody gets special funding. Multidisciplinary rehabilitation, again difficult, whether it's a government sector or a private system. And research or innovation, like Dr. Shefali said, is much easier in the government setup than it is in a private setup. It may be a corporate hospital, it may be somebody working alone. It's very difficult to get past the ethics committees. It's so difficult that most of the times you end up doing KAP studies because it doesn't involve any intervention. And we have no funds in the corporate sector. Also, equitable health delivery is easier in the government setup, but difficult in the private systems. One way they could do it is camps, outreach, OPDs, or if some big company might come up with a corporate social responsibility. Some pediatric neurologists do some social work as well, and sometimes you have NGO supports. So the important thing to remember is that a vision is not accomplished by a single grand act, but by collective success of many small missions put together, each one of which is going to contribute to the same goal in different ways. We should take pride in how far we have come, but never lose sight of how far we still have to go. And like my mentor, I will also use the tree to explain what I mean. So what have we achieved? We are very good at academics. Like Lokesh said, we have CMEs every week almost. So we have regular academic conferences, CMEs, workshops, online webinars. We've done really well in that. So this is the big one. But other small things also have been going on. There have been some guideline formulations. The number of members of the associations has increased. There are public education and advocacy activities. And we have instituted awards to honor the doyens amongst us and also to encourage the youngsters. A big one was getting the DRNB in pediatric neurology introduced as a new subject for pediatric neurology training in the country. But I would call these low-lying fruit. We have already plucked them. We must keep plucking them. We must keep moving, continuing these activities. But there is some fruit which is higher up, that needs to be taken as well. And I will just touch upon each of them briefly. So research and research, mentorship, fellowships, palliative care, welfare of our own community. And on top of that, the highest fruit that we can get is humanism in the way we practice medicine. So firstly, research and registries, common or rare diseases. We should move from, whenever you listen to a talk, even from India, we often have to say, oh, we have no data from India, and to be able to say proudly, Indian figures are this. And the research and research should be by India, for India, and then for the world. And on this aspect, we have started with the Big Bang. You know, the Big Bang created the universe. We are creating today a great vision with endless possibilities, and best of luck to everyone who joins in and contributes. Then mentorship programs. So this is a study from 2025, again by the Child Neurology Society. They tried to see why people are not interested in pediatric neurology, even though there is a workforce shortage. So they found that mentorship is the most important thing that brings residents into pediatric neurology. So we really need to work hard on this, to improving exposure, creating support systems, and research infrastructure is essential to address workforce shortages. So what can we do? Senior pediatric neurologists need to mentor young pediatric neurologists. So that can easily happen in educational institutes, but in other institutes, like the private setups, corporate setups, there also the senior people must mentor the young pediatric neurologists. Let them come up, pull them up, push them up. And the duty of the young pediatric neurologist is to mentor the MD and DNB pediatric level residents to take up pediatric neurology. And let's encourage it. If any pediatric neurologist mentors somebody to take up pediatric neurology, you can inform the association. We can have mentor-mentee programs. And could we create a mentorship registry just to encourage people, you know, how many people, and help somebody get into pediatric neurology? Then fellowships and grants. Well, there are many, I've been talking a lot to the young pediatric neurologists. Many of them say they don't know how to go about doing further training or go into areas of special interest. So in India, we're beginning to have these centers now. So as an association, we could encourage some fellowships and grants and encourage training in some of the subspecialties like electrophysiology, epilepsy surgery, and so on. Palliative care and awareness program. Now, this is one area which we seem to have forgotten. Which field of pediatrics has the highest number of cases requiring palliative care? Anybody can guess? Well, most of the people think it's oncology, but no, that is not correct. This is another very interesting study from India, which analyzed 400 cases enrolled for pediatric palliative care. And the most complex was actually complex clinical conditions with neurological disorder. So this group of disorders constitutes the largest group of children receiving pediatric palliative care in India. So what should we do? We could have CMEs and workshops on palliative care in national conferences, and let's start working on having palliative care centers, could be hospitals, standalone centers, and even daycare centers, where for some time we can look after them. So is the time over?
Yes, ma'am.
So I will quickly just go through the headings. We need to look after the welfare of the pediatric neurology community. Can I take just 2 minutes? So all the neurology societies, whether it's ICNA, whether it's Child Neurology Society, BPNA, all of them do workforce studies, training to find out the training and education status, studies on professional satisfaction. So we should also be doing this. then this is the highest goal that we have to achieve, humanistic practice of medicine. So what makes us human? The difference between chimpanzees and us is only 1% of the genetic material, and this 1% gives us not only different looks, but also cognition, empathy, honor, anger, rage, and so on and so forth. Lots of different emotions. Humanism is just being able to decide how we behave towards others as well as ourselves, with principles that are generally similar and agreed upon on the basis of us being humans. Religion, race, geography is not a factor. It is the ethical life stance that stands for building a more humane society. So one of the challenges to humanism has been found to be recent advances. Is it making us less humanistic? So we conducted this survey, and it was published in Pediatric Neurology. So the results were heartening in one way and disappointing in another. We found that we had, some time back, you'd all have received a survey. So we found that 90% of respondents strongly agreed with the humanistic principles, but physicians in high resource settings more commonly were able to adhere to these principles. So I will skip this slide in interest of time. So the Child Neurology Society in its annual conference holds humanism workshop every time. I think we should be doing the same. Workshop and insights into how we can practice this challenging and difficult field of medicine in a kinder way. So the final words, the ideas are not a checklist, merely a direction. Some of these initiatives may begin today, but may take many years to mature. We'll see their impact in the next generation. Success is not measured by how many goals we complete in 1 or 2 years, but whether we are on the path. Sorry. If we can establish this roadmap and ensure continuity, it's a big thing. We should be able to achieve excellence and impact for children and the families that we serve. Thank you.
Thank you, ma'am, for a wonderful vision of AOC and summarizing beautifully, starting from few happy endings, but ending with happy ending. So she beautifully summarized the problem we are facing, the core reason for this collaboration and this meeting, so the lack of population data, as well as why there is a research problem happening in a private setup. So this collaboration will definitely help us. And the best part was having a high quality, affordable care for all children equally for Indian children. So that should be our motto with this meeting. Thank you. Thank you, ma'am.
Thank you, ma'am. Thank you, moderators. So session 1, quite fruitful. I'd really reminded of what all this is for. This is ultimately to add a touch of empathy and to improve the lives of the children we treat. So moving on to the session 2, a very interesting session addressing the elephant in the room, that is the critical evidence gaps in pediatric neurology, which is one of the most difficult situations we are facing now. For this, I would like to call the moderators, Dr. Khurshid sir and Dr. Anup sir, to the stage, please. Kindly grace the dais. I would also like to call upon the speakers, Dr. Shefali ma'am, Dr. Jai Shankar sir, and Dr. Sandeep sir as well, onto the stage. So we'll be starting with the epidemiology of pediatric neurological disorders. This talk will be delivered by Dr. Shefali ma'am.
Okay, this is front, no? This is forward, right? This is back on this one. Okay, thanks. I just want to add two things in the vision. One is transitional care, which should be our responsibility to hand over our patients, because many of these patients are across lifespan. So we should be, holding our hands forward and try to collaborate and have transition clinics. We established one transition clinic, which after years and years we'll be having this month end. We'll be starting now. So I just said that is very important because, otherwise patients you do get lost. And Dr. Rekha, pediatricians are more humanistic than adult neurologists. I'm sorry if anybody is from the adult neurology here. But I think that is why they tend to stick on with us. And I've had patients at 32 years old getting their wives along also sometimes. But I said legally cannot write for you. So, so that is why we have to do that. And second thing is, we don't have so much of social workers and counselors in our country, and especially in the government setting. So we need to teach, coping strategies to the parents and have good counseling with the parents at the different, from the breaking the bad news for all these chronic problems and in a staggered way. So these two aspects also would like to just flag. So why child neurology needs its own burden data? The global and Indian case for pediatric specific epidemiology, and this is the outline which I propose. And neurodevelopmental disorders, what is the global scale? What is the scale with respect to India? Obviously, Kaushik will be talking more about that. Epilepsies, although later on we're going to have a lot of discussion in the next course of the program, but the epilepsy, what is the burden? What is contextually important for Indian subcontinent? Neuromuscular disorders, neurodegenerative disorders, emerging we have to bring AI everywhere, and synthesis and takeaways. For this AI, I'll just like to just mention that, many people have started, one has to understand that whenever you are using anything in AI, if you want to use it for, when you need to have anything for diagnosis and all, we have to develop as a collaboration. We need total lot of data set before something can be good as a diagnostic tool, right? You need a lot of data set AI based. So in that way, also our collaborations, which now becoming as a registry, later on can collate the thing for, ultimately making some screening and diagnostic tools as well. So my God, this is reverse. Yeah. So I have nothing to disclose. Neurological disorders are now the leading cause of disability worldwide, affecting 3.4 billion people across the lifespan. And for the first time in the Global Burden Disease 2021 explicitly modeled neurodevelopmental disorders and pediatric neurological conditions together. And these conditions account for 18% of the neurological disability adjusted life years occurred in children. So this is 18% of the DLY is because of children. So that is something important. So this reframes pediatric neurology from a niche subspecialty to a central driver for the global burden of disease. This carries direct implications for the workforce planning, screening, policy, and resource allocation. And India's demographic weight, the largest pediatric population in the world, makes a very local epidemiological data is essential. And that's why it gives more importance to this initiative today. I put it into 4 domains. First domain is neurodevelopmental disorders. So a global scale, which is to be seen, GBD 2016 estimated that developmental disorders, according to, affected 52.9 million children under 5 years of age. 8.4% of that age group, with 95% living in LMICs. By 2019, UNICEF had said that the UNICEF and WHO placed the number of affected children and adolescents worldwide to 317 million. And GBD 2021 has shown that ASD and ID prevalence has been there. They had initially shown it was stable, but then the recognition has been risen sharply. Coming to autism, global versus the Indian estimates, global early onset of ASD prevalence is estimated right now around 1%. There has been a 384% increase in the prevalence of autism from the year 2000 to 2026 as per CDC USA figures, according for the CDC figures. And right now the global, the early onset ASD is around 1% according to the WHO estimates, and which means that roughly 78 million people are affected worldwide across all ages. India had lacked the national estimate until the INCLIN study, which we had done with Dr. Enkura being the team leader. I was the network coordinator for the entire study, with MKC Nair sir was the PI. So we had done by population proportionate by size sampling across hilly region of Kangra, rural region of Palwal, Hyderabad was the urban region, Dhenkal district in Orissa was the tribal, and coastal was Goa. So by population proportionate by size sampling, we did an estimate for all the neurodevelopmental disorders, and autism was one among those. And so pool prevalence was 1.12, that was comes around 1 in 89. But if you see in 2 to 6 years, it was 1 in 125, and 6 to 9 years was 1 in 80. Overall, 2 to 9 years, the study was in 2 to 9 years, that was 1 in 89. And in addition, around 22% of them had more than one neurodevelopmental disorder, that means they had comorbidities. So this is what was very important to be seen from this. ADHD is common and an under-recognized condition. There have been diagnostic thresholds, informant sources. You ask the parents, you forget the teacher. And you know, the screening tools which to be used, we had developed the diagnostic tool in the INCLIN study, and they have been the INCLIN study and also the subsequent regional cohorts of Kerala has confirmed that ADHD is more commonly diagnosed in Indian children, and there is a male predominance and school age concordance with academic underperformance. And there are actually 46.9 million ASD cases worldwide under the age of 20, and 4.1 million new cases come annually under 20. And so it's the reported prevalence in Indian studies, various studies, is 0.05 to 6.5%. Coming to SLD, which is something which has been generally hidden, the specific learning disability, dyslexia, dysgraphia, and dyscalculia are neurodevelopmental conditions and are not a reflection of intelligence or effort. So the India's pool SLD estimate closely tracks according to the global, which is around 1 in 7 school-age children affected by some form of learning issues. Dyslexia accounts to 80% of all of them, and frequently occurs comorbidities are ADHD, which also compounds the risk of school dropouts in this. So again, the holistically evaluation of all these children becoming important, keeping in mind that you have multiple coexistent comorbidities of neurodevelopmental disorders. So 8 to 15% is the pool prevalence of school-going children in India having SLD, and 10.4% is the weighted pool prevalence of dyslexia specifically in the various Indian meta-analysis. Dyslexia prevalence in boys has been seen as 14.5% versus girls in 6%. There has been a consistent sex gradient across studies. The intellectual disabilities are very commonly associated with many other conditions, so it becomes, that's why it's been there are a lot of comorbidities which may be there. So they may occur along with epilepsy, cerebral palsy, or any other sensory impairments. Our Northern India cohort found a high burden of neurological and medical comorbidities of children with ID. They found epilepsy in 23.7%, behavioral problems in 80.9%, enuresis in 10.3%, ADHD in 6.5%, autism 4.2%, and anxiety 2.7%. So that is one thing. In one district level Indian cohort, epilepsy co-occurred in approximately 1 in 4 children with ID, and behavioral problems were nearly universal. So ID diagnosis should trigger a specific structured multi-domain comorbidity screen, not a single axis workup. This is something important to remember. And basically the cerebral palsy has shown a two-fold gradient between the high income, which is around 1.6 per thousand, to LMIC setting, which is 3.4 per thousand. And a pooled meta-analysis of 8 Indian studies places national prevalence around 2.95 per thousand. Preterm births and perinatal asphyxia remain the dominant attributable causes in Indian scene, and they are distinct from the more heterogeneous there in the high income. So as very rightly pointed out, we have to look for our causes, our problems, and do research for our things which will be there. This will not be answered by that, because despite improvement in the neonatal care, the background prevalence of cerebral palsy in the high income countries is not reducing down because of they are because of the genetic reasons which are there. But ours, which are the modifiable ones, will have to be kept in mind, and we have to look at these. The INCLIN study, which I did mention to you about, so in that we found the overall 12% children had one or more neurodevelopmental disorders in that, and there were 4,000 children who were screened, and this we found between, if you say 2 to 6 years, this ranged from 2.9 to 18.7%, and 6 to 9 years, 6.5 to 18.5%. But otherwise, it was just overall, if you remember, it's 12%, and 1/5 had multiple comorbidities. Second domain was looking at epilepsies, because it's very common. 50 million people are living in the worldwide WHO figures at epilepsy. More than 60% of all the epilepsy begins under the age of 18, giving pediatric neurology something very important. It's it's a, and 80% of people with epilepsy live in low and middle income countries. So GBD 2021 modeling of childhood epilepsy documents a substantial burden in neurodevelopmental impairment, premature mortality, and the DALI. And high-income countries have seen incidence to plateau or decline. And many LMICs continue to carry disproportionate infection and perinatal acquired burden. Just winding up, epilepsy in India is wide-ranging, harbors around 12 million of, world's 70 million total children. There are around people with epilepsy. 12 million are in India, so it has 1/6 of the burden which is there. And so generally, poor prevalence, which has been shown around 0.8%, and rural prevalence consistently exceeds the urban prevalence. And that is to be kept in mind is because, that is because you have to keep in mind the perinatal factor, infection exposure, and lower vaccination and antenatal coverage. So etiology-wise, there may be, the neurocystic circus remains something which can be really preventive, and it is a symptomatic childhood seizures are because of that. Birth asphyxia, premature related structural malformation, the febrile seizure is a common symptomatic childhood seizures, and genetic and syndromic things have come up increasingly. So the treatment gap is there, which we have to keep in mind. And drug-resistant epilepsy, there are lots of drug-resistant epilepsy because 30% of them are drug-resistant. They need to be identified, and there are a lot of other, there are epilepsy surgery, and there's ketogenic diet, vagal nerve stimulation, TMS, and many more things which have come up. There's a lot of treatment gap, and 20% of Indian children with epilepsy meet the DRE criteria in a Delhi-based cohort. Third was neuromuscular disorders, and now we understand that, there is a we have around 1 in 3,500 children overall to have SMA. It's a global estimate. They have shown that they're ranging from 1 in 6,000 to 11,000. Indian figures are around 5,000, but there are only few studies. And the population, the important thing is the carrier frequency is very high in Indian population. It's 1 in 40 to 1 in 60. So that you have to keep in mind of giving, because we can't do a newborn screening till we are able to give them treatment. So at least a population carrier screening should be done. I'm just winding up. So newborn screening has started in certain states and certain places, but cannot be done till you are going to be able to treat these children in the sense. DMD is there, but again, we are neuromodifying drugs are there, but they are not as good and not, don't get that much benefit. But yes, we have to keep that in mind. Lastly is neurodegenerative. Many things like leukodystrophies and all have come up, more understanding with the diagnosis, coming with the genetic diagnosis coming up, lysosomal storage disease, Wilson's, very much important, treatable, which is very important. The India Wilson's registry was started with the hepatology thing. They wanted the pediatric hepatology people and gastroenterology wanted in collaboration with AOC, and they did start, but something, we did have a meeting. It was again in Hyderabad, but it didn't ultimately work out. So I think, Lokesh, we will need to look in that. SSP is something which is preventable, a vaccine preventable thing. We have to keep, this is totally perspective for ours. We can work on this area and that. So this has, and AI, I already mentioned to you, with the AI is coming up in a big way, but we'll have to see, we can have all these collations and they can develop screening stuff with a lot of data. So we have consanguinity issues, we have perinatal infectious causation, ascertainment gap, urban, rural, and socioeconomic status variant. Screening era, there's a transition between screening, so whether we can't do a newborn screening on a public health point of view because we can't give treatment, so maybe when population carrier screening for SMA at least, and yes, the registry deficit which is there. So the takeaways is that it is not, it is a problem which has to be there. It accounts for nearly 1/5 of the pediatric neurological disease, and neurodevelopmental disorders are single most important. And we have to focus on all these areas and have to have a country-specific thing what we'll do. And it should be all indigenous in India. Thinking about India, you can make it when sickle cell, CRISPR-9, CRISPR-Cas9, gene therapy has been developed indigenously in India. Why cannot somebody sitting here do something more for us? Thank you so much for the patient listening here. This is my institute in different forms,
Thank you very much, Professor Sefali, for an excellent talk. And the prevalence and incidence, what you have shown, is already a tertiary loads only, may not represent the national statistics.
Sir, some of them are.
Some of them.
Like that Inclin one was not.
Is there be a way to improve the Indian standard national statistics from tertiary to sentinel population-based study?
Yes, sir. That is what the Inclin study was done for the neurodevelopmental disorders, but it takes a lot of time because first review I wrote was in 2004, and ultimately this paper was published in 2018. We did the study in 2011. because for screening and diagnostic tools were not socio-culturally sensitive available. So first we had to develop them, and then we had to do the prevalence study. So it took us from 2004 to 2018. It took such a long time, so that neurodevelopmental disorders is not a tertiary care, it is actually a population-based study. So like this, we can provide areas we can develop, we can see, and we can do. So you don't have to go house to house, but like there are many other epidemiological techniques. This population proportional to size, like how do I remove a biases, they go to whichever place, and then you put the bottle is, you spin a bottle. So whichever direction the bottle's mouth points, you start walking towards that house. So like that, so you remove the biases, and you are trying to do. So like this, it can be done the population thing based, whatever you want to do population based. But whatever we want to do hospital based, we can do. So and the other ones are all meta-analysis. So they are small hospitals, big hospitals. I mean, that is why. Otherwise, the problem, that's why I said the association leading a research or circumvents all this, so we can have regional sites, and then we have spokes to the wheel. So you can have individual private practitioners also giving the input, as well as small hospitals and all. And that is how we think it can help.
There is always a tertiary referral bias, always. So how can it be prevented?
Sir, when you do a study in a tertiary hospital, you will have to do whichever patients you are seeing, so that will have a bias. So, but that is why I'm saying, that is why that classic inclines study is not a tertiary thing. It's a prevalence study. It's one and the only study of its kind in neurodevelopmental disorders in India. And that is why, and because it took so much time, and it took funding from NIH, Autism Speaks in USA, and National Trust. So there was very huge. I had to write R21, and it got rejected, and again. So I'm just saying, whenever we work, so that is a representative for Indian population. So if we identify as a group, sir, something which has to be done from door to door, we can do that. But others, with this registry, in which we can have regional centers being the hubs, and you can even have the private practitioner individually seeing, also providing patients. So that way that bias can go. So in that way, individuals we can't do as institutes, and association only can do in this institute, in this thing. So that is why the importance of today's registry and others, so that each and every, sir, otherwise when I'm doing study at AIMS, my colleagues who are working in BL Kapoor or Gangaram cannot send me patients, right? But in this situation, when we do it from the AOCN point of view, in that situation we can have a setting so that every, we get a representative.
Thank you, sir. Yeah. May I have a second? Thank you, sir.
Thank you, ma'am. Those numbers seem very overwhelming, and that shows that what a humongous task we have ahead of ourselves. Next talk will be by Jaishankar Kaushik, sir.
So, good afternoon, everyone. I'm sorry, a little bit of fever and cold, due to which my voice looks a little altered. I bring my greetings from the Northeast India, from the city of Guwahati, from AIMS Guwahati, and I'm going to in the next around 5 to 10 minutes, I'll be covering on neurodevelopmental disorders and the long-term outcomes. Shifali ma'am has already spoken long about the neurodevelopmental disorders being a disability is associated primarily with functioning of the neurological system and the brain, and it includes a wide spectrum of the conditions, including global developmental delay, intellectual disability, ADHD, autism, and learning disabilities also. So early identification is quite critical for well-being of their children, and early identification could actually lead to further evaluation and diagnosis and the treatment. And we conventionally know that the developmental surveillance ideally should be provided at every preventive visit, including a detailed history, observation, and documentation, but it becomes practically very, very difficult because the primary healthcare does not have an inbuilt system where developmental surveillance is a part of that particular primary care. Similarly, we are also aware of the developmental screening that should be done whenever there is a developmental surveillance concerns that are there. Rather, all children at 9 months, 18 months, and 30 months should have a developmental screening, and autism-specific screening, we are all aware that are definitely essential at 18 months and 24 months. we all know from the previous speaker, Shifali ma'am, that India has approximately 430 to 450 million children with neurodevelopmental disorders, and it is around 8 to 18%, and ma'am specifically pointed about 12% of the children having one or more of the neurodevelopmental disorder, and rather it is the this single study from Dr. N.K. Arora and Shifali ma'am, which is the sole study for showing the epidemiological burden of neurodevelopmental disorders to be approximately 9.2%, and ma'am also pointed out regarding prematurity, low birth weight, neonatal illnesses, malnutrition, all of them are some of the important risk factors which are there. So there are, as far as neurodevelopmental disorders are concerned, the public health initiatives and the public health facilities coming from a government sector, I can say that RBSK is one of the very, very robust system, and it is one of the best system which is primarily addressing children for neurodevelopmental disorder. And all you must be aware that just last month RBSK 2 was introduced, where even diabetes mellitus and global developmental delay from 32 conditions, it has increased to 38 conditions. So this is one of the great initiatives of Government of India for addressing the concerns of the neurodevelopmental disorders. And in addition, we are also aware of the abilities and the structure and the functions of the district early intervention centers, which are present in all the centers, all the districts which are primarily there, district hospitals which are there, but many of them are functioning suboptimally, and many of them do not have trained people at that point of the time. So we often rely on child developmental centers and early intervention centers at a tertiary hospitals like Institute, like AIMS, where you get a lot of children who get referred, and it becomes really very difficult to accommodate all of them. So we all are aware of the research gaps in the neurodevelopmental disorders, that there is very limited amount of studies that have come. So there is an insufficient data on the incidence and the long-term outcome. Majority of them have come from urban area and regional area. Even the single study has included hardly rural, 1 or 2 rural area, and none of them have included any of Northeast India as one of the part of the studies which are there. So we all understand that there is a lack of national registries for NDD, and thanks to Dr. Lingappa for taking this initiative to create this type of registry. So I would emphasize on neurodevelopmental disorders also as one of the important strategies which we can keep in the future. And we are all also aware that there are very, very few validated, culturally adapted developmental screening tools which are available in almost all multiple languages. It becomes really challenging for the primary healthcare worker to address everything in an English language or in the Hindi language. So you need multiple languages like Assamese language or multiple other languages which are also primarily required. Now, when it comes to the gaps in the interventional studies which are there, now when we come to interventional studies, there are hardly any interventional studies. You will see plenty of interventional studies on epilepsy, you will see plenty of interventional studies on other conditions, but you will hardly see any intervention studies as such, randomized control trials which are evaluating or comparing the interventions. And there is also very limited evidence on culturally adapted parent-mediated interventions, which are also very important. And there is very sparse research comparing the different rehabilitation models which have been created, and Trivandrum is one of Dr. Deepa is here, and they have created a very good low-cost, scalable community intervention, and we need to learn a lot from their model, from Dr. Nayar's model, and from the Trivandrum model on how we need to emphasize on research on neurodevelopmental disorders. So there is minimal evidence on optimal intensity and durations of the therapies. Now, when it comes to the long-term outcome, what happens to these children with autism spectrum disorder, you can actually make out that 20% of them will have a good outcome, and 31% of them will have a fair outcome, and 48% of them might have a poor outcome. So what I wanted to emphasize is that almost 9 to 20% of the children with ASD might also lose the diagnosis, and rather 67% of autistic children will have an age-appropriate cognitive skills, which is quite promising and which is quite encouraging to see that we need to invest on neurodevelopmental disorders. The research on long-term outcome of children with autism spectrum disorder is also very, very limited, but we all know that those who had a higher IQ, those who had an early language communication, who had a verbal speech by 5 to 6 years of age, had a very favorable long-term outcome in children with autism. But there are definitely persistent challenges which are important aspect, and we are also concerned about the employment aspects which are there. So we see children till 14 to 18 years, limited follow-up into adolescent, and ma'am pointed out on few of the transition of the care studies are there. There is very limited data on aging with neurodevelopmental disorders which are there. So definitely we are in the need of longitudinal birth cohorts. We are in the need of universal developmental surveillance strategies integrated into the primary care. We definitely need multidisciplinary models like child developmental early intervention centers. We need to invest on genomics and biomarkers. We need to invest on the digital India, and digital health India is one of the government promises, and digital health and tele-rehabilitation is taking a very, very big big role over the neurodevelopmental disorders. So just 1 minute which I will spend that as a representative from Northeast India, I wanted to emphasize that the specialized services are very hardly available. Diagnosis gets very delayed. Majority of the children in the 7 sister states of them, they are not able to reach the center, and majority of them till few years back had to travel all the way up to Chennai and to Bangalore and to Delhi and many other places, and there were lack of centers which were available. And it is the mother's journey and the pain that she keeps saying every time that I came from 2 districts away, I saw a neurologist, the psychologist booked, the appointment is booked for the next month, and my son keeps crying every time I drag him to a new doctor. There is always a scarcity of the doctors within, all of them are not available under a single sector. So before we came in at AIIMS Guwahati, there was a big gap in the care before it came. There were no dedicated neurodevelopmental center, multiple referrals were there, there were no coordination between them, and there was a severe shortage of trained professional, and Dibangna and me are the only one trained pediatric neurologist from the Northeast India. So we have developed in AIIMS Guwahati a very good developmental center where we have a developmental pediatrician, me being a pediatric neurologist, and a child psychiatrist, along with the speech therapist, physiotherapist, and occupational therapist, along with a special educator. We make a common assessment, and this is one of the model which I have hit and tried, and trust me, working with a psychiatrist along with you in the same team brings a wonderful thing. And I am telling you that even in children with epilepsy, developmental epileptic encephalopathy, a very, very good rewarding results are there. Everybody claims that I treat neurodevelopmental disorders, but we all need to come and we need to keep child as the center of it. So we created a child developmental center where we have everybody under a single umbrella, and we make a comprehensive single file for all the patients, and all of us put the notes, and we have also integrated the RBSK scheme as well as the Ayushman, providing a complete free of care, free of cost treatment at our center. So I wanted to use this opportunity to emphasize on the neurodevelopmental disorders and the comprehensive care which has been provided in the Northeast India. Thanks to my mentors from AIIMS Delhi, and thanks to my teachers, and thanks to all the people who have supported, and I would always thank my director who has been very supportive towards development of it in the Northeast India. And in the last 1 year, we have seen a massive decline in number of patients who had to go out of Northeast India from Guwahati. So thank you very much.
Thank you, sir. Thank you. Very elaborative speech. Seeing the data, we will be conquering infections and nutritional, possibly neurological problems will be the highest. So I have 2-3 suggestions if we could incorporate. One is that what Shipali madam told, hub and spoke model, yes, all over the country, that will be very helpful. Number 2, I think if we could make parent societies, like we have Thalassemia Society, that has been very helpful in Similarly, if we could have societies of different diseases. And third, if we could, we have to first have the data, then our postgraduate program, though we have the best undergraduate program, but I think our postgraduate program needs some research orientation, more of a research oriented program. Thank you. And this is a request. There are 8 minutes only for the speaker. So please take time into consideration. Thank you.
Thank you, sir. Thank you, Jai Shankar, sir, for showing us what teamwork could do. It could truly make miracles happen. Next talk is by Dr. Sandeep, sir, who will be talking on burden of drug-resistant epilepsy and what we can actually do to reduce it.
Good afternoon, everyone, and thank you, Dr. Lokesh, for giving this opportunity. The burden of drug-resistant epilepsy, and we are here for NHBI registry, and everybody knows that it is a major burden for drug-resistant epilepsy. Epilepsy affects 12 to 15 millions of Indians, as Dr. Shefali Madam had shown in her presentation, and India is one of the world's largest epilepsy population, and nearly 1/3 become drug-resistant. And not only they are drug refractory, but they actually adds to mortality, disability, school dropout, and unemployment, caregiver burden, healthcare expenditure. So there is a lot, many things attached to the definition of drug-resistant epilepsy for the family. So this is IGAP module by WHO, which says that around 50 million people are living with epilepsy globally, and 80% of them live in a low middle income countries, and 75% do not receive treatment. Again, like India is a very diverse country, and recently there was actually GDP survey, and I think 4 or 5 states were high income group and the others were in a low middle income group. So I think both the things actually addresses to us, like low middle income statistics also addresses to our country. And the cause of treatment gap is because of lack of trained staff, poor access to anti-epileptic medications, social misconception, poverty, and low prioritization for the treatment of epilepsy, which increases the risk of death, premature death, 3 to 6 times. So I want to emphasize that the drug-resistant epilepsy problem will start with a recognition of drug-resistant epilepsy. For a pediatric neurologist also, we need to recognize that this patient has drug-resistant epilepsy. Otherwise, we are not able to think differently, because we'll keep on adding the anti-seizure medication. And obviously, you all know this study by Dr. Brody et al., Patrick Kwan, which showed that adding a new drug is not a solution. Okay, and historically, this study was repeated after a decade with a new anti-seizure medication. Again, it has given that same conclusion, that adding new medications doesn't help. Okay, so the drug-resistant epilepsy is a different cohort altogether, and it requires different approach. We're talking about the epidemiology, and interestingly, I didn't find any study which actually gives us a statistic about drug-resistant epilepsy population in India. That's only one study from Northeast. Kaushik was talking about the region, and this was one study which is from Kolkata, which actually documented the worldwide drug-resistant epilepsy incidences, like around 70, it is around 25 to 30%. So you see that according to region it varies, but it is close to 25 to 30%. And what this study documented, that they have only 11.3 drug-resistant epilepsy cases, because we haven't documented, so that's why we don't know the real number. So there is a huge gap there as well to do the epidemiology survey of drug-resistant epilepsy. What they shown is most of these cases begin in an early age, 0 to 5 years, 6 to 10 years, and they go on to have epilepsy later in their teenage and adulthood. So as a pediatric neurologist, it's our duty to catch them. And there are different challenges we face to deal with them, because financial thing is there. Epilepsy surgery, though cost effective, it actually costs around years income. The study done by Ruta Yardi Nandan sir's daughter, and only 2 in 1,000 eligible patients in India undergo epilepsy surgery. There are lack of centers as well for epilepsy surgery and ketogenic diet. So these are the challenges in a developing world: availability of skilled manpower, availability of epilepsy centers dealing with the basic and advanced epilepsy care, delay in referral, and cost of treatment. So I'll just keep this. See, the burden of epilepsy, around 3/4 is in a low middle income countries, and only 12% of these countries conduct epilepsy surgery. So there is huge surgical gap as well. And there are different reasons why patients are not referred, like low seizure frequency, no assumed success of surgery, low seizure severity. But if you identify that someone is having drug-resistant epilepsy, then you will start referring this patient at a diagnosis itself. Patient reasons for rejecting referral is different, like fear of brain surgery, diffuse reasons, no assumed success of surgery. So these are the different reasons why patients themselves reject the surgeries. And the cost of surgery, though we are doing it in a very cheap way compared to US and Western world, but it is still considerable if the patient is paying out of their pocket. But there are a lot of government schemes also, like Rajiv Gandhi Yojana and all, which gives you the funding for the epilepsy surgery, so that we can utilize. So in nutshell, we have around 10 to 12 million people living with epilepsy, and around 2.2 to 3 million people are drug-resistant epilepsy. Out of that, only 60 to 80,000 reach epilepsy centers, and around 1,000 to 1,500 surgeries has been done yearly. So there is huge treatment surgical gap in our country. So what are the main causes of drug-resistant epilepsy? The neonatal hypoglycemic brain injury leads the way, with a malformation of cortical development, genetic epilepsy syndrome, tuberous sclerosis, progressive epilepsy syndrome, immune-mediated epilepsies. When we do the registry, we'll come to know the prevalence of this. But we had tried our bit, like we evaluated our NHBI patient who presented to us with a refractory epilepsy, and we presented this paper in epilepsy research, where we shown that this is a unique phenomenon where you have hypoglycemic brain injury, you have focal epilepsies, as well as you have kind of secondary generalized epilepsies. And these are all drug-resistant epilepsies. And surgery do work in this group. The main surgeries like resection, parieto-occipital, or temporo-parieto-occipital resection, the outcomes are fairly good, like 75%. And the group B, where there is a secondary epileptogenesis with a Lennox-Gastaut syndrome, drop attacks, we go for a palliative surgeries, and there also the drops goes away, reflex epilepsy goes away. Recently, we are actually these studies in a publication. We did another study with a neonatal hypoglycemic brain injury, and we looked at, like Veena Kalra madam was saying, that there are undocumented hypoglycemia. So we looked at our patient who presented with us with a documented hypoglycemia. So these were like around 59, and then MRI changes suggestive of NHBI, but no documented hypoglycemia. They were around almost 50% of them. So these all were neonatal hypoglycemic brain injury patients, and they were included in this study. And we found out that in this patient, why prevention is required? Because epilepsy is so severe that only you can afford prevention, palliation, not the curative surgeries. Okay, so the curative surgery was given only in 27% of patients, and rest of them were went ahead with the palliative surgeries. So to conclude, this was a conclusion from that paper. Neonatal hypoglycemia was a major contributor for drug-resistant epilepsy and neurodevelopmental impairment with predominantly posterior brain injury. The males were represented over the females, and prematurity was documented in 20% patients. EEG abnormalities and developmental delays include widespread network disruption. Not only epilepsy, it actually disrupts the network, and that's why it causes global developmental delay, behavioral issues, cognitive issues. And despite we are having surgical center, surgical like advanced scans and other options, the outcomes are very poor. Only few patients we can give curative options. And we required this early identification, targeted neuroimaging, and individualized long-term care for high-risk neonates, so that we can prevent the formation of epilepsy and drug-resistant epilepsy. So to identify neonatal hypoglycemic brain injury and to avoid subsequent impact of neonatal hypoglycemic brain injury, I think this will happen with this registry, and I am very hopeful for that. Thank you.
Thank you, Dr. Sandeep, for an excellent presentation. And I would like to call the next speaker. We will have a question answer after the whole of the lecture is finished. Dr. Mahesh Kamte, rare neurogenetic and neuromuscular disorder. Dr. Mahesh, please.
Good afternoon. At the outset, I'd like to thank Dr. Lokesh for innovating and giving this opportunity. I'll be speaking on rare neurogenic and neuromuscular disorders, the role of support services. What are these rare disorders? WHO defines rare disease or rare disorder as a debilitating lifelong disease or a disorder with a prevalence of 1 or less per 1,000 individuals. In India, the National Registry for Rare Diseases has been initiated by ICMR, and it defines rare disease as the disease, one which affects fewer than 1 in 2,500 individuals, with as many as 7,000 to 8,000 rare diseases described. Most neuromuscular disorders are rare, and then they qualify for a level of rare disorder. And among the rare disorders, neuromuscular diseases form a major chunk, with most of them having onset in childhood. When you look at these rare disorders, the epidemiology is usually based upon national registries and small cohorts on single disease or disease groups. India is unique because we have the largest population in the world, and as been told earlier also, there are more than 4,600 population groups, which is stratified into several tribes and castes based on the socio-cultural background and geographical location. There are strict inbreeding practices among certain communities that resulted in high prevalence of several rare genetic diseases and associated founder variants. An example is the Agarwal community, wherein many founder mutations have been described. The limited information on the prevalence of rare disease due to lack of centralized patient registry, diagnostic facility, affordable therapeutic interventions, and awareness. And in our country, we have both public and private healthcare facilities, and usually there's no much coordination between these two groups, and hence we don't have good quality data from India. Again, I'd like to quote this Incline study, which Shefali ma'am also told. The wonderful study, it was a community-based study done in 5 geographically diverse populations in India using cluster sampling. It represented both rural and urban population, Hindu and non-Hindus, and all castes were involved. They studied total 3,964 children between 2 to 9 years. And they used a standardized tool, like they used INDT NMI, that is Incline Diagnostic Tool for Neuromotor Impairment, to look at children with motor impairment. It had a good sensitivity and specificity. Total 62 cases out of this 4,000 had NMI CP, and in this 22% had neuromuscular disorders. That gives a prevalence of 0.5% in children between 2 to 6 years and 0.3% in children between 6 to 9 years of neuromuscular disorders. Another good paper published from Genetics Center Ahmedabad by Dr. Jayesh Seth, wherein data from 22 years was published. Total 7,481 patients were studied, out of which 60% had an IEM and 26% had neuromuscular and neurodegenerative disorders. Among the neuromuscular disorders, DMD was the most common, followed by SMA and myotonic dystrophy. This is a spectrum of neuromuscular disorders, what you can see. The disorders which affect the spinal cord, anti-horn cell, nerve roots and nerves, neuromuscular junction, and muscles. As you look at these disorders need a multidisciplinary treatment. Okay, no single person can manage these disorders, and you need to have a good multidisciplinary team to manage these children. And most of these children need a lot of support services. What are these support services? Support services are services that help patients and families navigate complex, low prevalence conditions like the rare disorders. The core components of support services include MDT, that is multidisciplinary clinic, which include specialists from neurology department, genetics, psychiatry, physiotherapy, occupational therapy, speech therapy, respiratory, cardiology, orthopedic and nutrition department. Facilities for genetic counseling, diagnosis, variant interpretation, family testing and reproductive options. Third would be care coordination, using case managers, nurse navigators to handle referrals, insurance, school IEPs and disability paperwork. Then diagnostic support in the form of whole exome or whole genome sequencing, muscle biopsy, EMG, NCV, advanced imaging and natural history studies. Next, treatment access to disease-modifying therapies, clinical trials, compassionate use drugs, gene therapy, ASOs, and enzyme replacement therapy. Then we need to have rehab and assistive technology in the form of motorized wheelchair, augmentative assisted communication devices, orthotics, home ventilation, and adaptive equipment. Mental and health psychosocial support, counseling for patients, families, caregiver support, and palliative care. Then, last but not the least, education advocacy, transition to adult care, school accommodations, financial aid, and community connection. So there are many international bodies which can afford these services. Like we have this National Organization for Rare Disorders, EuroDIS, that is Rare Disease Europe, Rare Disease International, Muscular Dystrophy Association, Genetic Alliance, Genetics and Rare Disease Information Center, World Muscle Society, and TREAT NMDs. These are various international bodies which give services for patient advocacy, treatment guidelines, and even clinical trials. Coming to India, we have this ORDI, which is based in Bangalore, which gives facility for patient advocacy, awareness programs, family support, information and access to treatment and government policies. We also have this Muscular Dystrophy Foundation of India and LHC Support Society. However, looking at the population of India, we need many more organizations and bodies which can provide services to these children with genetic and neuromuscular disorders. Coming to families, these support services can help in early diagnosis and reduce the diagnostic odyssey time. They can give access to trials, links to registries like NORD, QODMD, and QRSMA, home support in form of nursing, respiratory therapy and respite care, peer community, connect families with the same disorders, and financial navigation, help with insurance appeals, government schemes, and charity funds, etc. So these support services are very important to manage these neuromuscular disorders, and most medical colleges, I think, should start MDT services so that the students who get trained there can follow the same in their practice. To summarize, rare disorders are individually rare, but collectively not rare. Most of them need support services, and support services are very few in our country. We need to discuss and take steps in this regard so that we can give a proper comprehensive care to children with rare neurological disorders. Thank you.
Thank you, Dr. Mahesh, for your presentation. May I request the next speaker, Dr. Vijay Kund, on pediatric stroke.
I request Dr. Vaikuntraju sir to come to the dais.
So good afternoon to all. So I'll be talking on pediatric stroke Indian data. So this is the outline of my presentation. Basically, I'll be talking on Indian, what is exactly existing data over the last 10 years based on various subcategories of stroke like arterial, ischemic, and also hemorrhagic stroke, and importance of various sub type of strokes, especially in Indian contents, and also regarding the treatment like currently advisable and properly anything intervention is done currently like thrombectomy and thrombolysis also. So pediatric stroke is also unique and Indian data also unique because the infectious causes like vasculopathies are more common in Indian setup compared to Western countries. That is the reason you should study the more Indian data with regard to stroke. And this is a study done reported in Lancet Neurology. It shows that up to 1/3 of stroke happens in children only. So this is a data search. So this is a search include over the last 10 years. So you are included mainly the original studies reporting more than 4 core cases. So coming to arterial ischemic stroke, so in Indian setup usually arteriopathy, vasculopathy, especially infection origin is more common compared to prothrombotic condition in other countries. these are studies done various causes of stroke in northern India from PJ. It shows that the result shows that compared to Western countries, the etiology is different in Indian setup, like 77%, up to 3/4 of them are arteriopathies, and many of them are infectious origin also. And also study from Gora, it also shows again the arteriopathies are more common compared to other causes. And in this category, most common cause of arteriopathy is meningeal angiopathy, lenticular striatus is the most common, followed by myomeia and other cerebral vasculopathies. So this is a summary showing the differences of Western countries and Indian studies. So arteriopathies are more common compared to Western countries, and especially infection-associated arteriopathies are common in Indian setup compared to other countries, including myomeia is very common, and unique cause is meningeal angiopathy is very common. So coming to subcategory, that is meningeal angiopathy, especially in the toddler age group, this is the most common cause reported in Indian setup. This is one of the earliest study reported by Dr. Lokesh. It shows that one of the common cause of stroke in small baby, especially in the less than 3 years of age, it has unique parameters like early onset of stroke following insignificant fall, and they may present not only weakness with dystonia and extrapyramidal symptoms, and recurrence also noted. So we are also reported similar case studies, about 40 cases, and they were also noted almost similar pattern of weakness, and also recurrence is also noted following insignificant fall. And myomeia vasculopathy is one of the other common cause for recurrent stroke in children. So especially it is very common in northeastern states compared to other states. So this is a study shows from Yashoda Hospital, Mumbai. It shows that out of 40 patients are reported from that. So some of them may be syndromic, some of them are myomeia syndrome, some of them myomeia disease also. So those studies shows that the surgical intervention reduces the recurrence risk compared to medical management. That is the conclusion from the study. And especially it is common in Eastern India. Coming to the CSVT, so there are only a few studies, especially in context, especially in children. There is no isolated studies regarding the CSVT in children, especially from Indian continents. This is a study reported overall, including adults also. The median age is 29 years, so including small children also. So for CSVT, there is no India-specific pediatric only CSVT cohort or evaluating etiology and outcome of children with CSVT. Thrombophilia and prothrombotic states, this is a study from AIIMS Delhi. So this is only study almost done one decade back. It shows that prothrombotic condition can coexist in the same children. So more than one prothrombotic factor was noted up to 50% of children. In that, most common is hyperhomocystinuria, protein C deficiency and S deficiency. Coming to some other unique causes in the Indian setup is tuberculous vasculopathy. So you have noticed the vasculopathy in tuberculosis stroke is very common, and in most of the time is complicated various disability long term. So up to 1/3 of children have developed the stroke because of various mechanisms. There is a lack of data when these children should be intervened, a role of steroid, role of other anti-inflammatory like ecosprin. So there is a lack of proper studies and also outcome regarding the with treatment, without treatment also. So stroke determines usually the outcome in these children with tubercular vasculopathy. So you require long-term data of exactly what is the percentage of stroke in these children with TBM, and also long-term outcome with or without stroke, and what is the effect of intervention like anti-inflammatory agent, including non-steroidal anti-inflammatory agent like ecosprin. Some of the unique causes in Indian setup is infections, especially varicella. It is commonly seen. So exactly in Indian setup, we don't have proper data. When should we call post-varicella stroke? If somebody comes more than 1 year, and how to investigate like antibodies versus PCR? When should we given antiviral drugs or anti-inflammatory agents? And dengue is one of the infection. Many of the other infection also can present both ischemic and arterial, venous, and also hemorrhagic stroke also. Coming to neonatal stroke, again there is lack of data, especially Indian setup regarding the Indian prospective studies. Only observation studies are reported. So again, the etiology is very heterogeneous in this group. So again, the important is the stroke, the long-term outcome is not reported, especially Indian setup, what happens in the future. Only the few Western countries from years, it shows that the long-term outcome like epilepsy and hemiplegic CP is one of the most common complication with neonatal stroke. Coming to the hemorrhagic stroke, again, the hemorrhagic stroke rarely reported studies from Indian setup. So various causes, including vascular malformation, coagulopathy is reported. But isolated pediatric studies are not available to compare with other strokes. Thrombolysis and thrombectomy. So this is the 26 guidelines. So the 2019 guidelines was not advisable. They're heterogeneous. They're told there are no proper guidelines. But 2016 they are advised thrombolysis can be considered if they present less than 4.5 years from 28 days onwards. But the India is not yet prepared because a lot of limitation, because the diagnosis will be delayed, presentation will be delayed, availability of imaging. So there are lack of facilities, not only for treatment and also for diagnosis, and also the other lacunae that exist for the diagnosis of this condition. So this is a table showing the evidence of gaps in Indian pediatric stroke, arterial ischemic stroke. There is no multicentric Indian data. Regarding CSVT, there is no pediatric only CSVT data. Hemorrhagic data, stroke, again, complete evidence is lacking. Neonatal stroke, especially, there is no long-term outcomes of Indian children presenting neonatal stroke. Maya, again, the long-term data is missing. And thrombophilia, again, no updated publication over the last 1 decade. And we require a lot of data for post-infectious, like especially chickenpox, varicella, and also tuberculosis. Thank you.
Thank you, Dr. Vaikuntha Raju, for your excellent presentation. And now we are concluding the session as our all 5 speakers have spoken. Any questions from the audience? From any speaker? So hope all the 5 presentations were very excellent, and their input will definitely going to transform the registry of neurological disorder across the country. Over to you.
Thank you, sir. Thank you to the moderators and all the speakers of the session. This in the next session will be, that is session 3, will be addressing the question, is there a question of global credibility to Indian data which has been generated? A very important question again, and to address this, I request upon the moderators, Dr. Jitendra sir and Dr. Habib Patan sir, to come out to the dais. And I request our speaker, Dr. Murli Mohan sir, to come and address the gathering.
Sir, do I have your go-ahead? Yes. So good afternoon, everyone. A warm welcome to the city of Hyderabad. Thank you very much at the outset for AOCN for featuring us as evidence partners, especially to Dr. Lokesh Lingappa sir. So when we say data quality is sacrosanct for generating credible evidence, almost no one contests. We won't have any second opinion on this. But when we dwell further deep into it and try to understand what are the deeper dimensionalities of data quality, how to ensure them, and the level of commitment one is willing to take to ensure data quality, then we see huge amount of diversity there. First, let us understand, all of us are familiar with this story. I am just sort of, inviting your attention back to this story. I think in the midst of COVID-19 pandemic, May 22, 2020, the Lancet publishes a paper based on 96,000 patient data based on international registry. On hydroxychloroquine, concerns about rising the risk of mortality due to cardiac events. The impact was instant. Within days, WHO pauses the hydroxychloroquine arm of its global solidarity trial. 7 other national trials follow the path. Followed by an open letter by 100+ independent scientists requesting data audit of this particular registry-based study. And June 4th, 2020, 3 out of 4 authors, they write a letter to the journal withdrawing this particular publication. Again, the reason was we can no longer vouch for the veracity of the data. Within 13 days, this entire story unfolds, sort of raising so many doubts about the credibility of science itself, because the whole world was watching every scientific output probably which is coming out of the healthcare ecosystem at that time. A recent study which is published based on 50 years of data from the Retraction Watch database of 16,000 plus retracted articles, it shows data concerns as the #1 reason, contributing to almost 32% of the reasons for retraction. It is more than all the next combined reasons together, fraud, peer review issues, and referencing issues. All the next 3 causes combined together doesn't match with data concerns. So the most common cause of retraction. So the bad data is worse than no data. So a registry's entire value chain, it rests on the quality of the data. So starting from the data collection at the time of your delivery of your care, then at the time of entry and management into your electronic data systems, what kind of mechanisms you have there to ensure data quality. And of course, the analysis credence. At the time of analysis, what kind of diligence, what kind of transparency you are ensuring, so that you are producing credible and trustworthy outputs. So to translate your data into policy and practice, you cannot have any weak links in your entire data chain. So one weak link in the data chain, it breaks the entire chain before it reaches its intended objective of changing the practice or policy. So there is no dispute on this. It increases the research credibility, regulatory compliance, valid outputs, and also ensures patients' interest and safety. So what are the dimensionalities of data quality? Completeness, various levels of missingness due to various reasons can bring in a lot of bias into your estimates. Accuracy of the data, for example, how accurately we are classifying a particular disease condition, for example, in this case, NHBI. Consistency, when multiple centers are involved, especially in the registry situation, real world situation, how consistent are our definitions, how standardized are our entire processes so that we are collecting consistent data across all the centers. Timeliness is one thing which is very, very critical. At the time of, they say that the longer is the time between your data generation or your data entry and management, there is a higher probability of making an error. So how can you shorten that, and how can you enter the data as you are collecting? Validity of the data, and then data provenance. Every data point is traceable to the source documents, and then especially it is attached with the right kind of consent system backing it. So when we are envisaging to set up a real world registry, these are the problems we can anticipate. So missing or incomplete data is going to be inevitable in real world scenario. You will have a lot of patients probably not coming back for follow up. You have a lot of source data documents probably missing from your medical records. So how to minimize this and how to handle this in a real world scenario? I think we are having a detailed data charter in our registry protocol. Inaccurate data, lack of standardization of your operational definitions and data collection methods. Again, not ensuring data privacy and confidentiality can throw a lot of sort of credibility concerns on the registry data. Unstructured data, again, considerably declining the utility of the data for drawing the final evidence outputs. Selective reporting of the data, again, sort of because the entire fraternity is here, right? One of the fundamental, challenge in registries is many centers resort to selective reporting of, for example, let us say favorable outcomes. Then you go and you end up analyzing the data, let us say, drug refractory epilepsy, for example, right? If we are going for a selective reporting and the reported outcomes are not even matching with the global benchmarks, are way off the target, then the whole data credibility is at a question. So technology and integration challenges, again, tomorrow we might have to integrate a lot of your EMR systems into the registry workflow. Again, quite diverse technology solutions out there. Again, some of the integration challenges. And one of the fundamental problem with the real world registry is again dynamic scope. Today we start the registry with certain scope and it keeps on changing over a period of time. It will keep on expanding, new centers will come up, new diagnostic modalities may come up. So the scope of registry is never static as compared to a conventional research project. So what are the solutions? Your tool you are going to choose for your registry management is very, very critical instrument in ensuring data quality. So you have to build the quality into the tool itself. So a structured codified fields, limited free text, so automatic duplicate detection and then flagging, real-time range and logic checks, again sending a feedback about the data quality. Availability of complete data audit trial. So having a governance system in place. Tomorrow, for example, the example COVID-19 example I have taken, what the journal had asked the authors was to produce a data audit trial, which they could not produce. So that is why it had to be retracted. So again, ability to produce that kind of audit trial and version history of every document, every edit of the data. Mandatory field enforcements, again to minimize incomplete data. Again, creating interoperability standards. And also building data quality into the process is also very essential. Standardizing your SOPs, having a source data verification system in place, centralized data governance structure we are going to keep in place to ensure data quality monitoring. So defined query lifecycle and independent data audits will be conducting frequently. And then data quality committee will be there to ensure every data point entered is complying with the data standards. So data quality is very critical to generate quality evidence, but at the same time, another important dimension of data quality is data safety and data privacy, which is very, very critical to earn the trust. Again, we are standing at crossroads. Thanks to DPDP 2025, now we have a solid legal framework in India to govern the data safety, security, and privacy aspects. So consent is very, very critical, especially in NHBI, because we are dealing with pediatric population. They have a lot of special provisions in DPDP 2025. Some of the consents have to be very explicit. They have to be clearly verifiable parent and guardian consents, very granular and revocable consents, not like a general consent which is incorporated into your the practice consent. These are all very critical. And documented consent audit trial, again some of the children might pass the age of let us say from pediatrics to when they cross the 10 years, you have to bring in assent into place. And once they cross 18 years, you have to again have a dynamic consent process in place. Another important dimension of the platform you are choosing for the registry is compliance with this DPDP recommendations in terms of the data safety security. So encryption standards, both at rest and during transition. Role-based access controls is another very critical dimensionality which we need to take care of. As compared to regular data collection, registry data collection should have a system in place where you have role-based access controls. Data minimization by design, consent captured within the product itself, and breach detection workflows, and retention and erasure triggers whenever you are modifying any data. I'll just take a few seconds, sir. So credible evidence is combination of ensuring data quality and also maintaining data trust. So the data quality and safety is non-negotiable component of any registry, and it has to be incorporated by design into your registry establishment and operations. So the AOCN data credibility chapter, which we are planning to incorporate, one of the expert working group meetings, proceedings are going to dwell on this. It's going to set a benchmark for every registry which AOCN is going to undertake. Source data verification process is going to be there, and we are going to continuously monitor the registry for DPDP 2025 compliance. Every data point would be traceable, auditable, and clearly outlines the data governance framework. So the entire registry will be operated within this framework. So let the next case study on data credibility should be from AOCN for the good reasons. Thank you very much.
Thank you, Dr. Reddy, for talking about this very important aspect of data collection and producing data. As they say, data is gold. So we have to have a pure gold instead of a gold with impurities. We will not have questions right now. We'll have questions at the end. And I think next 2 lectures are going to be online.
So the online sessions have been postponed.
Okay.
Yes. If you have any comments, we can take it now.
So we don't have any further lectures. Anyone has questions for Dr. Reddy? If there are none, you want? Okay.
Some clarity not only on the data, but on the entry point at which they are entered. Because the entry of an NHBI may be at the level of hypoglycemia, maybe at the level of identifying an MRI which is abnormal, which we correlate as NHBI. And then we also have to know that how many blood sugar levels at what interval would we consider. I think we have to have some preconditions also in addition to just the DPDP for the data. Okay.
Thank you. I think this is the time for a tea break.
Yes,
I think
sir.
because
We have a refreshing tea break.
two speakers who are not available for some technical reasons. So we are closing the session. Over to you.
Thank you, sir. Thank you to the moderators. We'll have a short tea break of 10 minutes and we'll gather back before we begin our core sessions of the registry. Thank you.
వస్తుందా? Hmm?
Yeah? Yeah. We can, everybody come for the group photo first and then we can have this one. Is the photographer there? No, no. Then by the time you assemble here, he'll be there. No, please. There are enough cameras to take this one. We'll quickly have it and then because, yeah. क्या 5 और 3 कर दीजिए. For a group photo, please join.
डिस्कस कर लेते हैं.
लालों को बोलने का नहीं तुम और मैं. Yes.
not 3. Again, good evening. Welcoming you all back after that refreshing tea and a really good photo we had. Too much of aura in the photo, probably. So now we'll be beginning the session 4. This is kind of unexplored for a clinician, because in this session we'll be dealing with the registry. What is a registry? What goes on into making a registry, and how difficult it is, and how can we streamline this? So to comment on this particular topic, I would like to invite Dr. V.B. Gupta sir, Dr. Arjit Chattopadhyay sir, Dr. Gauri Pasi ma'am to chair the session. We also have an online moderator, Dr. Naveen sir, who will be joining us. And the speakers for this session will be starting with Dr. Murli Mohan sir, who will be addressing the global trends in the disease registry.
Good afternoon. So we have 3 speakers in this session of Design the National Pediatric Neurological Registry Ecosystem. So our first speaker is Dr. Reddy. Please carry on.
Thank you, sir. So again, so as AOCN is embarking on this exciting journey of establishing NHPA registry, so it is very critical for all the stakeholders to understand what are the global trends. Especially, I would be taking these 8 minutes of time to sort of bring to all your notice what are some of the global registry frameworks and what are the dimensionalities which are covered by these frameworks, so that we all are aware, and explicitly we'll attempt to sort of design and operate this entire registry in accordance with all these global frameworks. There's no sort of credible data available on the number of patient registries or disease-based registries globally. Like we have clinicaltrial.gov and then other Prospero, other databases for RCTs and systematic reviews. We don't. There were attempts to maintain a registry of patient registries, but the data is not very explicitly available in the public domain. But one of the analysis by a senior expert who had played pivotal role in designing some of these frameworks, they have mentioned that around 2068 active patient registries are available in this database, which we could not verify. And the same report also had mentioned that there is steep rise in the number of registries in the recent years. In the last 2-3 years or so, there is a 39% rise in the total number of registries which are available in this database. And also, one of the sort of other dimensionality is predominantly most of the registries are national coverage. They are limited to one country, with very few registries having international coverage, cutting across more than one continent. And then some of the registries are intra-continental, covering European region and then Southeast Asia region kind of thing. One of the important insight from this data was rare disease registries. There are 725 rare disease registries which were analyzed. This ARPANET report. 82% of all registries ever recorded are still operating today. That is a very strong message according to me. It is the initial inertia which is which we need to break, and once we break that initial inertia, establish the registry, operate for few years, there are a lot of sustainability mechanisms which can sort of help the registry to sustain for longer periods, because then you have the data asset providing very critical insights to various stakeholders, particularly industry partners, funding agencies, national governments. Definitely they will have interest in putting in resources to sustain your registry. So the investments have to be sort of pulled in for the initial maybe 3 to 5 years of your registry establishment and operations. So registries, again, when we observe the global trends, it was nice to have kind of asset for stakeholders, again, more particularly for professional bodies. But now it is transforming into regulatory infrastructure because of a lot of developments which have happened in the last few years. But if we look at the basic premise of this, RCTs are alone not enough to support the sort of regulatory approvals or even tracking of some of the pharmacological or non-pharmacological products which are in the healthcare ecosystem. Now law mandates it. Again, it is 21st Century Cures Act by US government. It is set up a legal mandate to FDA to come out with a very clear real world evidence framework to guide all the stakeholders to facilitate regulatory journey. That has created a lot of momentum in the ecosystem, which was very sort of, vague science. It has transformed it into a definitive science, registry science. Again, another premise is rare diseases, right? No single center can compile credible data to inform policy and practice. So it is inevitable, if you are really serious about addressing rare disease, rare diseases and build credible evidence around them, pooling data is indispensable. You cannot avoid it. And another important sort of transformation which is happening is in the EMR ecosystems, right? So the current EMR ecosystems are finally throwing out data. Otherwise, they were all one-way traffic. Especially the kind of EMR systems we have in countries like India, they're quite diverse, right? At last, they are at least throwing some data out, which can be integrated into your registry ecosystem. So these broad changes in one in the thought process, another one is some of the processes and systems improvements have led to an ecosystem where now registries can thrive. So there are many more agencies and guidelines, but I would like to bring your notice to these 5 global agencies and the corresponding documents. So AHRQ, Agency for Health Research Quality, is probably one of the most popular agency which is quoted across establishing and managing registries. So they have a user's guide that defines registry science, provides a fundamental scaffolding on how to establish, operate and then evaluate your registry. There is a 40 chapter clear guidance document. I think most of our from protocol writing to our evidence generation, we are basing this as a master document and we are designing every step of our registry based on this particular document. FDA RWE again had a lot of sort of documents have come out of FDA. I'll be sort of dwelling deep into that. ISPAR is another agency and they have good practice standards for generating credible evidence from observational registry data. Then SIOMS, this is again, it has brought in regulators from multiple countries to one table and they have come out with a report very recently, consensus on ethics and cross-border use of the data. CDISC again sets up the data quality standards, the common language which every registry should talk about. Tomorrow when we want to pool, for example, let us say our NHPA data with any global registry, if your data is built in accordance with CDISC standards, the pooling will become easy. So these are the some of the journey. AHRQ 2005 it started commissioning. Sort of started drafting the guide. So multiple editions of this guide have been drafted. So first edition was a very sort of fundamental document talking about registry, giving it some structure. Then second edition had added more sort of guidelines on how to report patient outcomes, especially patient reported outcome measures. Third edition had talked more about legislation and methodological advances because the registry methodology is quite unique as compared to our conventional research designs. And third edition talked about EHR data, reuse of the EHR data and registry interoperability frameworks it has provided. And the fourth edition is the current edition, which had dwelt very deeply into common data elements, the CDISC standards, everything have been recommended more categorically. And more importantly, it has added a very strong governance chapter. Again, we are going to have a very strong governance framework guiding our entire registry in accordance with AHRQ 4th edition guide. So FDA again, Cures Act had set up the legal scaffolding. From then FDA had produced multiple guidance documents, and then currently in 2023, again very interesting, the last point if we see, they have issued a guidelines on using registry data as a external control group for a sort of control design, right? So tomorrow if you want to compare effectiveness of two different interventions, your registry data which you are building can act as a control group, and there are very clear guidelines about how it can be used and clear methodologies, which might be very exciting thing for both the clinicians and also industry. Then ISPAR had produced a lot of guidance documents. Again, sort of very recently there is a landmark ISPAR and ISP Special Task Force guidance document. So good practices for RW treatment effectiveness studies, and it defines the nuances of methodological approach as compared to your CONSART and other guidelines. They issue similar guidelines for your RWD science. CIMOS is again it has produced this working group 13 had produced data. Again, regulators from multiple countries have come together to define these standards. Especially they talk about sharing the data. One is about the vocabulary data source expectations, and more importantly they talk about consent, cross-border data use and accountability aspects. Again, one of the important agenda of this conclave is to sort of come out with a roadmap for global collaborations. I think again keeping these guidelines in the backdrop will facilitate pooling of our data with the global registries. So CDISC standards are the data standards. I think my colleague Fanny would be talking more about these standards and how they are to be incorporated. So we are making every possible effort again to incorporate as many aspects as possible, practically possible, into the registry planning and execution. So these are the attributes which are covered by these guidelines. There has to be a clearly defined purpose and scope of registry, so that many people say that we have a registry. When we ask what is your clearly defined scope, they can't produce. There has to be a clear governance and oversight mechanism. There has to be a clearly defined data quality framework. Data collection and management manuals have to be very clear. Patient autonomy and safety, how are we addressing that aspect also has to be explicitly specified in the entire registry documentation. External validity and representativeness of the data is very critical. I think Dr. Lokesh has been, I think during expert working group proceedings also a lot of people are asking. So for example, we are individual practitioners, how are we going to be part of this particular registry? Yes, all those dimensionalities are being discussed, and today we'll take viewpoint of all the stakeholders and try to make it as representative as possible. And then how to avoid bias and confounding, outcome validation, again what kind of tools we are going to use, transparency and reporting, and what is your continuous enhancement and improvement plan. All of these things have to be there as a part of your registry planning exercise. So the 5 pillars which we are going to build our entire registry based on. So these frameworks, can we go to the yeah. So these frameworks, though they might appear a lot of bureaucratic constraints, but yeah, they provide a sort of a structured framework, and if we strive to sort of align with as many of those suggestions as possible, so we can claim that it is in accordance with the global frameworks, and it can definitely become a strategic data asset to facilitate AOCN's journey as a global thought leader. Thank you very much.
Thank you, Dr. Reddy. I think we'll have the questions at the end, if there are any.
Yes, sir. Thank you.
Right. So the second speaker is Dr. Srinivasan.
Sir, we have a slight change in that. So the next talk will be a demonstration and overview of the technological platform for registry development by Mr. Fani Chaitanya.
Okay. Right.
Okay. Hello all. I am a techie, right? I am working with Dr. Murli. So I'll bring technological perspective of maintaining a registry. So Dr. Murli has already explained about different pain points in maintaining, managing registry. I'll just reiterate some of them. So if you see, the major problem is data collection, right? With the burden in India of patients and the population, it contributes to a lot of fatigue for clinician to basically even involve in this data collection. That is one thing. Then data quality as consistency and having a very consistent data is very important. Otherwise, once during the process of data collection or during maintaining the registry, if a corrupt data is entered, there is a problem of corrupting the whole system. So we need to be very careful in terms of not having any corrupt data into the system. And a registry, you need to think like a living structure. It evolves with time. Basically registries are not like 6 months or 1 year things. They are like decades. So with time, you can see with AI, the changes it brought in. We need to think that it is a living structure which evolves with time, with the environment it has right around it. So we need to. That is one of the problem or pain point where when you are maintaining a registry. Complex governance, regulations. These are all the common things. And in India, I mean, there are so many EHR, CMRs. Getting all them into one place or having them talk in the same language is for me is next to impossible. Yeah, and because of all these problems, right? Like even analysis of data gets delayed, and a lot of insights are lost. And India being a powerhouse of data, we need to understand we are losing so much, so many insights, so many improvements that you guys can bring in. So modern registry, these are some of the features that I can think of. Yes, configurable data, forms and different ways to collect data offline, online, and with all this, keeping the authenticity of the data, right? Auditing and all is very important. Standardization again needs a lot of work in terms of softwares, right? Where a layer of like semantic layer we call it have to be built to basically map the local data, I can say, local variables, whatever you design yourself, what you think, you name it, right? And then if the same names have to be used outside, it's very difficult. So that's where standards come in. All the standards that we were talking, SMTP, OMOP, all of them, right? And then we have to again build. So you have to understand that these fields are exhaustive, right? Like I mean, you cannot quantify them. Even if I have to put it on a software and load it, it will take like it will slow down the system in a way. So we have to be careful with that data. We need to, like for example, this registry is NHBI, so we have to load only those data which are needed for NHBI, right? And then this terminology service is something which help users, help the doctors, or help the people who are designing the data collection layer, right? To basically build the forms or data collection mechanisms in the right way, wherein you can map them to some international standards like SNOMED and Lionic and other things. And interoperability, again, FHIR is something we all need it, but at the same time, it adds to a lot of overhead on all the systems, especially in India. I'll come to that. Then again, a system has to be, a registry system or a platform has to be having, dynamic, customizable rules, right? Rule engine which can basically avoid, data corruption, basically, right? So linkage means, again, whenever you are collecting data, the same patient is going to multiple places, multiple hospitals, he has multiple reports. How do you link all of them? And it's in itself is a big pain point, and we have to link them, right? And real-time dashboards are a must. The dashboards will throw out a lot of metrics that can be used in your day-to-day lives, day-to-day work that you basically use to treat the patients or even policy making. So, but are these pain points and solutions enough for Indian setting? So I say, it's a mixed feeling for me as a technologist, right? High volume, high pressure setting, right? With minimum infrastructure, it's very difficult for, to basically adopt to all these regulations or adopt to all these, authenticity activities, right? To make the registry authentic. So, and one more point is very low adoption of these standards, right? The standards that I spoke about before in the Indian ecosystem. Less than 30% of EMRs even try to adopt standards. So how do you, it is improving. It is improving definitely. From past 5 years, we have seen it has improved from very, very low to now. People are recognizing the importance with the ABHA and all. People are adopting, FHR, but again, partially. What government has asked, it has for some data of a patient, right? Very little data, and they have done it and then stopped. But revolutionizing the whole system with FHR is still low. So having all these problems, I feel mandating all this would again be a counterproductive thing to basically, you can never start a registry if you want to, set up all this and then only start a registry. So we thought about Dr. Murli, and we thought, what are the aims of these setups, right? So the intrinsic aim of these setups is, to achieve auditability, traceability, reproducibility, accountability. So these things are very important. If you see you can call them measures, and these are very important to, to build the trust, to make people depend on them, on this data or the registry to, even try for policy research, right? Whatever. So how can we achieve this? I mean, without, even completely, because interoperability is not possible. If we believe on that, only 30% of the data will come, 70% will not come. So how do we, we have to work around till the system evolves, till the system becomes, mature. So how do we do that, right? So that's where we, we are building our platform in to elevate all that, but having these intrinsic measures, right? That is one point. So if you see in this slide, registry governance, data collection and management, churning outputs, these are all part of a registry. We cannot see them, just data collection as a registry. Data collection is not enough. You have to have a governance. You have to have a structure behind, process proofs behind every activity that you do inside a registry, maintaining a registry. So how do you achieve them, right? So I'll just list some of the registry management aspects, right? So in governance, there is an event, right? Like this conclave is an event. A lot of outputs are coming out after this event. So we need to set up the process proof, right? Everything is captured. We are capturing everything, right? What speakers are talking, the working groups, what they are doing, what are the outputs of a working group, what were the both agreements and disagreements in that working group, everything, and then how do we come to a consensus? We have to build a consensus management system and create the process proofs of everything. So that's where COGUIDE comes in, right? That helps to do all of them. So, and again, EDC, right? Dynamic design. Again, as I said, it's a living structure. Registry is a living structure. It will evolve, and a lot of amendments have to be happening. But why an amendment has to happen, and how do we do it, right? The process proof. Who is responsible for even raising a question, and how the whole thought process went through, and how the decision was made to change the design of or enhance the design of a registry. So again, raw data, you can think raw data as a raw material for a factory, and the registry should become a factory floor which will keep on churning a lot of evidences out of it. So and a lot of all the process proofs for research life cycle management along with the data that comes in. So these are all the aspects that are needed in registry management. So these are technical modules. These are just names of technical modules that are needed to achieve all this. But we have to apply all this not just at a EDC level. EDC is just a small part. Maybe it is a foundational part, but it is at easier part where you just need to collect data. But again, around it, we need to have a ecosystem which, and all the audit trails are immutable, right? It has to be time-stamped, logged. Nothing should be, automatically, discarded. Every event, everything that happens in a registry, right? Maintaining a registry has to be recorded, and so some of the features, technical features that we need to add is, are just the the list that I have displayed here. But yeah. So this is my last slide. So if any of you are searching to select a software for building a registry on your terms, so these are few text perspective requirements, right? Data safety and security are as important, but that is a given now. Everyone, every software are coming with a lot of security features. Ease of use, right, and ease of collaboration. So a registry is not a one-person game or a one institute game. It's a lot of people are involved. So during the journey, a lot of people will come in, a lot of people will go out. We have to maintain and manage that, right? How do we manage a person coming in, or collaboration coming in, and they might after a while they might leave. So how to have those process proofs is important. Yeah, supporting dynamic needs of a registry, right? And then support structure around the registry. That's COGUIDE's facility where we bring a lot of support structure around the registry, and then process proofing all the activities. That is the most important thing in any registry. That, as per me, yes, basically to build the trust, to answer any questions that arise in the future, because that's where we get stuck. Yeah, along with these intrinsic measures that we spoke about, these are the basic needs of a registry. Thank you.
Thank you for a very excellent talk. We are going to have 2 online lectures now because they are speaking from the US and that time is already allotted to them. The first speaker is Dr. Ravindra Arya, and he's going to speak on how reviewers and journal editors evaluate clinical data, the volume, the scope, the quality, and the scientific rigor. It's a great pleasure to introduce Dr. Arya. He is an alumnus of All India Institute of Medical Sciences. Let me just get his very excellent CV. Ravindra Arya is now Professor of Neurology in the Comprehensive Epilepsy Center, Cincinnati Children's Hospital Medical Center. He's Professor of Neurology, Pediatrics, and Computer Science there. He completed his undergrad from Jabalpur and his MD in Pediatrics also from Jabalpur, and then he did his DM from the All India Institute of Medical Sciences. He is board certified, and we are very happy to listen to you, Dr. Arya. You can share your slides now. You're muted, so before you start, you need to unmute yourself.
Excuse me, can you see my slides?
Yes, you can make it full screen if you like.
Excellent.
Yes, that's fine.
So I was asked to speak how journal editors and reviewers assess data integrity in particular, and how does India compare with rest of the world when it comes to research data quality and integrity? So I will try to summarize a bird's eye view from a practical standpoint on this. So the first thing I'm going to give an overview of the peer review process. So as scientists, we are interested in creating this information hierarchy from raw data to usable information, which might offer insight into whatever system you are trying to study. As child neurologists, we are trying to understand the developing brain and its dysfunction. So at every level, we are asking questions like, how are these data generated, analyzed, and reported? And then at the more superficial layers, we ask the question, are these findings credible, reproducible, and appropriately interpreted? So let's drill down into these. So at the editorial level, there are several considerations. When a research paper or a research report lands on the editor's desk, we are interested in getting the right fit for the journal and its readership. In top-tier journals, there is a lot of emphasis on whether these findings are truly new, and the novelty can be conceptual and or methodological. And does it have implications for advancement of scientific thought, methodology, or clinical practice, or is it likely to inform policy? Another question that some of the more clinical journals ask is, yes, if this is so, what may be plausible timeline for such an advance? This was shown eminently during the COVID pandemic. But let's stick to data integrity. Even at the editorial level, we ask the question, are there any obvious problems? If there is an attempt from the authors, whether willingly or unwillingly, about sample description. If the effect sizes looks implausible, or the reporting appears to be hiding something, there are, editors are typically in a rush, and any attempt at conveying that, yes, there is less than completely transparent reporting doesn't bode good for the research report. One of the other things is the consideration, how easily is this data obtained? For example, some of the epidemiological studies or the kind of research I do with intracranial EEG data, we get one chance at obtaining our data when the stereo electrodes are implanted into the brain. So that's also a factor sometimes in assessing the data quality. As a reviewer, we are more deliberate, and we delve deep into different aspects of the data integrity. One of the key decision points is that given the description provided in this paper, could a colleague with required expertise reproduce this experiment and reasonably expect similar data patterns and eventually similar outcomes? So this, at every level, this is evaluated critically. So it starts with study design suitability, how you obtained your data. Is this design appropriate for the question that you are asking? Are the controls, randomization, and inclusion-exclusion criteria clearly described in a non-ambiguous manner and are justifiable? Power analysis is very important. Was there a formal sample size estimation? What was the sampling strategy? Was it adequate for the experimental design? Is there a sensitivity analysis? How was missing data handled? In science, one of the most important things is what is being measured and how is it being measured. So no matter what kind of computational model, to a wet lab, all the way to epidemiological study, we are always trying to measure something. And whether the instruments that you are using, are they valid? Or do they measure what they are intending to measure? Are they reliable? What is their reproducibility? And how are variables defined and coded? Finally, this is a little bit outside my wheelhouse today, but whether the proper consents and ethical approvals were reported when relevant. This also includes a rising concern about obvious fabrication or manipulation of the data. While it is getting increasingly easier to do so, it's also becoming increasingly easy to catch these things. There is another, I can only, in this talk, I can only give you a sort of a bird's eye view perspective on how to assess the statistical validity of the reported analysis. This is a whole field in itself of kind of forensic data analysis and quantification. But at a minimum, every reviewer looks at whether the statistical tests were chosen based on the study design and the measurements that you have conducted. Are the underlying assumptions fulfilled? So with increasing availability of AI coding support and open source software, it is anybody can be a statistician and perform these even very sophisticated analysis. But often the challenge is whether the underlying assumptions for these analyses fulfilled by the data that you are reporting. were all the plan analysis reported. And in fact, it is best sometimes in complicated studies to declare them a priori. Again, how are missing data, outliers, and multiple comparisons handled? It's very easy for reviewers to catch if there is an inconsistency in numbers. So if there was a difference in tables and figures versus text. Similarly, were there any robustness checks for the data that has been reported? Ideally, it is best to analyze the same data set using different models and to report consistent results. Finally, it comes to results reporting and interpretation, whether everything was reported with transparency and is easy for the reader to appreciate and to perhaps even reproduce in their own lab. If the data sets or methods are complex, are there supplementary protocols, additional raw or semi-processed data files or code repositories that are shared? There are reporting standards for most of the study designs now from the Equator Network that may or may not exactly apply to the work that you are doing, but it is always a good idea to look at them and to try to include those as supplementary material in your submissions. Finally, this is more of a broader aspect, whether there was alignment between results and inferences. As scientists, sometimes we may be led to overgeneralization, and I'm just as guilty of that as anybody else. One of my mentors used to say that there is no human study or human subject research that is perfect. So, and no matter how much you try, there might always be tweaks that you think about later, or you can potentially apply in an ideal scenario. So I think those weaknesses in study design and analytic methods should be acknowledged. And you'll be surprised, reviewers are willing to give a lot of leeway if those limitations are properly acknowledged. So next, after giving this overview of the peer review process, let's drill down a little bit into threats to the research data integrity, which arise primarily at two levels. One is the design itself, where the methodological choices are made by the investigators. And the system level threats stem from issues that are larger than a single investigator. So for example, institutional practices or technical errors, or sometimes deliberate policy decisions at a level above and beyond an individual investigator. So let's look at some of them. So I think the threats from study design are within the control of an individual investigator and are more important. Often the system level threats stem from political or bureaucratic decisions and are outside the control of an individual principal investigator. So a poor sampling, this is obvious one, that the study group does not represent the population that you want to draw conclusions about. And I try to offer some potential remedies. Again, once you have designed your sampling strategy, compare the sample characteristics to known population benchmarks, report response rates. Sometimes the intended population may be challenging to access, and in those cases, such requirements can be relaxed to some extent. Use probability based or any weighted sampling methods, again with transparent reporting of how weights were chosen. The next threat is if the groups were unbalanced. This occurs many times in clinical trials. One recent example was studies on hydroxychloroquine for COVID-19, where in the initial studies, the patients who received the drug were often more sick at baseline than those who did not receive it, which obviously introduces a bias. Later, properly randomized trials showed no meaningful benefit. And the best defense against this is randomization. And if that is not possible, the next best is to use matching based on regressions or propensity scores. Even in a rare disease scenario, the propensity score-based matching works very well and is statistically robust. Threats from study design also come from missing data. This cannot be avoided. So it's better to rectify this using either methods like complete case analysis, which can shrink your sample size significantly, or use imputation methods like chain equations. But in that case, report clearly how you performed imputation, what were the inputs to the imputation methods. It's always better to conduct sensitivity analysis using a best and a worst case scenario and report that. Measurement errors, can sometimes, I'm giving an example that is somewhat alarming, but indeed, measurement errors can, plague some of the best designed studies. So Mars Climate Orbiter mission failed because there were two teams and one used kilometers while other used miles. And there was a difference at the third point after decimal in the transformation. And that little mismatch actually led to the loss of the spacecraft. So again, use your variable definitions very clearly. By that, I mean there should be no ambiguity about how variables are coded. Use valid instruments, standardized protocols, which should be audited periodically. Finally, this is a threat that there is no easy protection against, which is p-hacking. So many times investigators, this is a cartoon showing how investigators can essentially fish for a p-value that they want, that serves their preconceived hypotheses and report those. Perhaps the best defense against this is to pre-register your study design and analysis plans, which is increasingly required, at least in interventional trials. It is okay to perform post hoc analysis. All of us gain insight into the problem once we look at the data. And my suggestion would be to limit them and clearly label them as post hoc or exploratory. If it is possible, report all tested outcomes and models. How were model selection performed? How was variable selection performed? And be transparent about these things. The systemic threats, they look similar, but again, I would say these, by and large, are stem from political, social, or institutional pressures. And I would actually not go into much of details in this. These are typically outside the control of the investigator, except for a few things. For example, in this day and age, your data storage with information leaks that can develop over time, or the metadata drift that can occur with changes in variable definitions, formats, including the file formats used for storage. So it's important to periodically review and audit them and try to be as updated as possible, creating equivalence transforms so that your longitudinal analyses are still valid no matter what the shift in variable definitions or data coding patterns might be. So finally, I would share this. There are guidelines for research data integrity which have been proposed, and this is a more recent one. And again, they are based on common sense principles of accuracy, completeness, reproducibility, understandability, interpretation, and transferability. So the strategy that I could extract from this this very long document is that you should plan your study data requirements, how you are going to collect the data and analyses together. Your data dictionary should be current, which means it should be created and then periodically reviewed and revised. The data should be saved in as much of a general purpose file format as possible. The wider use tools are always preferable than niche file formats, and always keep the raw data intact for several years, depending on the local guidelines. So next, I would just briefly try to present some data about where India stands in this compared to rest of the world. So India is doing very well and contributes roughly a third of the world's scientific literature. The recent impressive technological advancements, both at the time of COVID pandemic and recently with space missions, are being recognized as being the cutting edge across the globe. So in terms of scientific publications, India has been growing, and particularly since 2020, the growth rate has increased. India is now contributing above 1% of the most cited articles or total publications. This 1% is often considered an arbitrary benchmark, but is used by National Science Foundation as well as NIH. Publications with international co-authors have been less overwhelming, but again, have been stable. India also, in terms of clinical trials, again, India stands third in ranking with stringent controls and ease of performing clinical trials. Where things become a little concerning is if you look at the gross domestic expenditure on R&D. So India is not too bad, but when you look at this in relation to the GDP, that's where you see a significant gap. So the share of gross domestic expenditure compared to or normalized to the GDP has been increasing rapidly for China, has remained stable for most of the other developed economies, but for India it has remained around 1%. So these are some of the data that is well curated and kind of reflects where there is a scope for improvement. When it comes to biomedical sciences, there is definitely a little bit of room for improvement. India has done remarkably better in fields like chemistry and computer science compared to health sciences, and that includes your quality improvement initiatives or healthcare delivery research, as well as biomedical translational and fundamental research. Regarding medical research in India, there is a little bit of paucity of data, but I found this one interesting paper that reported that only 4% of the institutions kind of produced bulk of the research. So there is definitely an asymmetry in the distribution, and their contribution was 40% of the country's total research output. So 4% of institutions contribute to 40%, and more than half of the medical colleges did not have a single publication in last 10 years when this study came out. This is actually consistent with an ICMR report, which said that Out of 156 medical colleges, 27 published no paper, while 29 published only one paper in last 10 years. Just to compare, if you look at Mass General Brigham Network from Harvard, they publish more than 21,000 papers. The Mayo Clinic's campuses publish more than 10,000. So does the University of Cincinnati College of Medicine. And my hospital, which should be compared to a department of pediatrics, outputs more than 4,000 papers per year. So the same group of researchers have commented about a quality-quantity gap, saying that there is remarkable growth in biomedical research output, yet a little bit weaker citation impact. And some of the drivers of this QQ gap have been proposed. Again, anybody who has worked in the field and who trained or worked in India would acknowledge the lack of or severely limited protected research time, given the clinical demands. There is insufficient training in research methodology at most levels, and I may be completely wrong here. Things might have changed since I left India. There is also the issue of inadequate funding is often mentioned, but I have a take on it, which I'll present in one of the slides. I think what India needs is to leverage their strength, and their strength is in numbers. These numbers can hardly be matched anywhere in the world, with annual physician consultations of more than 4 billion, annual outpatient or daycare services of more than 1 billion. And this is a conservative estimate from the International Health Policy Center of the Commonwealth Fund. So the actual on-ground reality is even more than this. So I would present two somewhat out of context issues. One is that there is a plague of predatory journals. So there are, this term was, came up with Beale, who's a library scientist. So these are defined as exploitative or fraudulent publishing models. Essentially, they'll publish anything.
Hello, sir. So sorry to interrupt. We are running short of time, sir.
Okay, I will finish in 1 minute.
Sure, sir. Thank you.
So this was illustrated by an experiment where a fake medical paper was submitted. And when they looked at where the bank accounts of these, they were predominantly across two countries, India and Nigeria. Similarly, there was an experiment where they created a fake scientist with very subpar credentials who were accepted into editorial position by several journals. However, none are listed in Journal of Citation reports. So this is the comparison. This is, I think, important. So I will present this. So when it comes to annual funding for scientific research, yes, there is significant gap. This is just the comparison between US and India. So in terms of billions of US dollars adjusted for purchasing power parity. But when you look at the number of grants also, so across different bodies, so NIH and NSF, DOD, and so on, and this excludes training and fellowship and programmatic grants. Whereas when I was looking at Indian numbers, the data reported does include fellowship. So this is a little bit for investigators. This number should be smaller. So when it comes to available funding per investigator in millions of US dollars, there is not a significant gap. So there's more funding available in US, but the number of investigators that you are competing against is also higher, and that includes Nobel Prize winners and Presidential Medal of Science winners. So these are my messages. I'm sorry I overextended my time, but peer review evaluates data integrity in the context of the study. And editors and reviewers always assume good faith reporting. The threats to data integrity can stem from design choices made by investigators, as well as upstream challenges that are often beyond our control. And transparency in reporting data generation and analysis is the best policy. I think India has an impressive momentum in biomedical research, which should be harnessed by initiatives such as creation of this repository to improve its own healthcare delivery and public health. So try to solve problems that India has rather than competing with the other economies. With this, thank you so much, and I'm happy to answer any questions, comments, and stay back if the questions are for the end.
Thank you, Dr. Ravindra. That was a fantastic overview of a very difficult topic. And it was very heartening to hear that we are doing so well in publications, and albeit more in the computer sciences than the health sciences. We are going to defer the questions after the next talk, since we are running a little short of time. It is my absolute pleasure to introduce Dr. Samantha. I've read so many of his excellent reviews. It was a joy to hear that he'll be speaking to us. He will be speaking on the role of cenobamate in drug-refractory epilepsy in pediatric epilepsy. He comes from Arkansas. Is that the right pronunciation?
Yes,
probably not.
that's correct.
Where
Arkansas.
a slightly more famous person also comes. That is Bill Clinton. So he is an internationally renowned pediatric neurologist and epileptologist from the University of Arkansas for Medical Sciences. And he serves as the medical director of the Comprehensive Epilepsy Program and the MEG Laboratory, and the co-medical director of the Neurometabolic and Neurogenetic Clinic. He's a graduate of MAMC, and he then went on to the University of Virginia, and he has more than 200 scientific publications, which I'm sure all of us have often read. So we are very happy to listen to you, Dr. Samantha. Please go ahead.
Thank you. Can you hear me okay?
Yeah, we can. Yeah, we can hear you.
Thank you. So I was asked to talk about cenobamate in pediatric epilepsy and developmental and epileptic encephalopathy. So my understanding that it's still not readily available in India. We are in US, we are using in pediatric age group as off-label. So let me start with a clinical scenario. So this is a 15-year-old girl with Lennox-Gastaut syndrome, was referred to me because I'm a clinical trialist to enroll this patient to a bexicaserin trial, which is a serotonergic medication similar to fenfluramine. She previously failed multiple medications and she did not respond to bexicaserin. So I started her on cenobamate. At that time, she was having 5 to 10 seizures daily, and she responded really well. And right now she's having less than 1 seizure per month. She also has improvement in non-seizure, some of the non-seizure outcome with improved communication. She was also having gait difficulty before cenobamate, and that also improved. So now going into a little bit more discussion about mechanism of action. So cenobamate is an alkyl carbamate anti-seizure medication. It has a really novel, distinct dual mechanism of action. It does preferentially inhibit persistent non-inactivating sodium current. So most of the conventional anti-seizure medications that target transient or peak current, but this one does preferential inhibition of persistent sodium current. And it is also a positive allosteric modulator of GABA A receptor, and it acts on a non-benzodiazepine binding site. And though it is only approved in adult in United States and in 2021 European Union. Very recently, in 2023, approved also in Canada. The label is only for focal seizures in adults based on two phase 2 RCT that studied 200 and 400 patients in two studies, and there was a open label phase 3 safety study, mainly because there is some risk of DRESS that's similar to lamotrigine and other sodium channel blocker. So that's why they did a larger studies to see the safety. Let's see. Somehow I lose my video, so let me go back. Okay. So what they found in the phase 2 studies that the responder rate of this medicine is really high, 55 to 64%. So if you compare with other approved seizure medication, their usually responder rate is around 35%. So you can see the delta compared to other seizure medication. And also seizure freedom rate very high at 20 to 30%. So if you look at the other clinical trial, usually less than 5% for other seizure medication. That had been formally tested in more than one network meta-analysis to compare cenobamate with other anti-seizure medication. And it was noted that cenobamate definitely more effective compared to other currently available anti-seizure medication, both for responder rate 50% as well as seizure freedom rate. So based on this remarkable data, there is a growing interest to use cenobamate off-label in pediatric population as well as in any different DEEs because of the inherent intractable nature of epilepsy. Bring the slides. Slide moving for you.
If you can turn off the video and speak, maybe that might help. We can see your slides at this end.
Yeah, I think it is somehow maybe I need to stop sharing and then reshare because it's not moving. So,
yes, we can see the slides.
Sorry, can you see it now?
Yes, we can.
Okay. So let me briefly talk about the dosing and administration strategy. So definitely now it is approved in adults, and they have this 2-week titration regimen to mitigate the risk of DRESS. In kids, there are a lot of institutional variability. There is no standard dosing, but personally, I start with 0.3 milligram per kilogram per day, and then increase 0.5 milligram per kilogram per day every 2 weeks. Usually young kids, less than 6 years, they need much higher total dose at the end in the maintenance compared to adolescents or teenager. Cenobamate can be given once daily with or without food, and it has very long half-life. The one advantage of cenobamate, though it's only available in tablet form, it can be crushed and mixed with 25 ml of water for either using as a suspension or nasogastric tube. So that's the way I use for younger kid. And I have used child as young as 2 years old. So briefly talk about cenobamate in pediatric epilepsy. Definitely, we don't have high-level evidence. This had not been studied in a randomized clinical trial. When we looked at in a review late last year, we found 8 retrospective studies with 624 pediatric patients aged 16 months to 18 years. Again, the responder rate, in some of the studies, there's a mixed study comparing adolescent and adult, and they found the responder rate greater than 50% seizure reduction is similar to adult, 60 to 70%. There's one study from Spain that's the largest pediatric series to date. They had 169 patients, 93 of them had DEE, 74 focal epilepsy. Again, remarkable rate of responder, you can see 84%. And even this intractable patient, 20% patient became seizure-free. In these two groups, DEE and focal epilepsy, there is no difference. There was a nationwide claims database study in US that looked at 176 patients, and they noted after starting cenobamate, there is modest reduction in hospitalization as well as ER visits, but there is no change in rate of status epilepticus. So this one, this review we did in late last year. Recently, last week, I was looking at the data again, and in 2026 plus 6 months, we had again 6 other pediatric studies, again comparable responder rate and seizure freedom rate. Now, briefly talk about specifically for developmental and epileptic encephalopathy. We did a meta-analysis looking at this population, and we found 14 studies across 5 countries, and 7 of them single center and 7 multi-center. Total 368 patients, and they're highly intractable. Similar to the patient I described in the beginning. So they had on an average 8 to 15 prior anti-seizure medication trials, and we again found in this very high seizure responder rate of 56.8%. There are 4 influential studies in that meta-analysis. When we removed those studies, we found 63% responder rate, pretty consistent with adult focal intractable epilepsy data as well as pediatric epilepsy data. Seizure freedom was lower, 10% as expected in DEE population. Usually in the other population, we see 20-30% seizure freedom rate in intractable patient. There was no pediatric cases of DRES, so that's reassuring. So with slow titration and starting at a low dose, definitely you can mitigate the risk of DRES. Now, most of the treatment emergent side effects were sodium channel blocking effects like somnolence, dizziness, ataxia. In my practice, usually I see 20-40% of the time, but generally manageable with dose adjustment. You don't need to stop in most situations. We looked at with the meta-regression if there are any specific predictor of response of cenobamate. Unfortunately, we did not find any predictor, no age or longer duration of effect, prior ASM, number of ASMs or concomitant ASMs. They did not change or predict treatment response. Briefly want to talk about drug-drug interaction because that's, I think, different than other newer anti-seizure medication, that this medicine has a potent drug-drug interaction because it inhibits CYP2C19 and induces 3A4. So importantly, I want to briefly mention about N-desmethylclobazam. So it inhibits that, so it significantly increases clobazam level, desmethylclobazam level. So many of my patients, they are on clobazam. So I proactively, when I'm starting cenobamate, I reduce the dose by 25 to 50% because otherwise there would be significant sedation effect. It induces 3A4. Briefly want to mention that I see a lot of patients with tuberous sclerosis and they're already on afinitor or everolimus. So I need to closely monitor everolimus level because that level can drop precipitously. So I need to make sure that and many of these patients getting everolimus for SEGA. So I don't want to have a lower everolimus level with increasing size of subependymal giant cell astrocytoma. But in general, though there's a drug-drug interaction, proactive management can be helpful. And it is also because sodium channel blocker, after you reach maintenance dose, need to make sure the other sodium channel blocker dose potentially can be reduced and even weaned up. In my practice and usually in literature, I see maybe half of the patients, one or more anti-CGI medication can be reduced, and maybe 1/3 of patients, at least one or more anti-seizure medication can be stopped after starting cenobamate. Briefly, a couple minutes to touch upon different DEE. Lennox-Gastaut syndrome is the best studied DEE. And larger studies, they have 30 to 40 patients. And again, responder rate noted to be very high. There's one study that they noted responder rate up to 86%, even seizure freedom 12.5%. As you know, treating LGS, that type of number you don't see. Maybe close would be clobazam or filbamate, but still this would be beyond that you can expect in patients with LGS. Dravet syndrome. So as a sodium channel blocker, you would expect that this would be relatively contraindicated. But the first study actually came from adult population, and they described 4 patients. All 4 patients had greater than 80% seizure reduction. 3 of them actually had greater than 90% seizure reduction. And this is based on possibility that this is not a conventional sodium channel blocker that affect the transient or peak sodium current. Rather, it affects the persistent current and most probably can be used in Dravet syndrome. But there are many pediatric studies that showed that there may be some patients can have potential worsening of seizure. So personally, I'm not using this as a first-line medication in pediatric population. This is kind of a 4th or 5th line, really intractable patient, but still need to be mindfully monitor the potential worsening part. It is one of the first-line medicine for SCN8A DEE, especially gain of function. It can be effective. Tuberous sclerosis, there is one study of 54 patients. The efficacy is modest. There's also small case series of DOSA syndrome or epilepsy with myoclonic atonic seizure and infantile epileptic spasm. Efficacy is modest. Non-seizure outcome inadequately studied, but maybe 1/3 patients there can have improved alertness as well as reduced agitation. But there definitely is in specific subpopulation like SCN8A, up to 80% patient can have improved non-seizure outcome. There's limited data in the EEG as well as quality of life. There's some data in adult population, not here. So I would not touch that. So because of the time, I'll skip some of these. But limitation of the current evidence base that most of the data in pediatric and DEE is retrospective and observational and still pretty small number, maybe less than 1,000 patients had exposed to this, at least reported in the literature. And we don't know specific seizure type specific data. Like we know this is broadly effective based on different animal models, both for focal seizure and generalized seizure. But there is some report, maybe 1 to 2% of patients can have worsening of absence seizure, even absence status epilepticus. So if someone is building a database and including cenobamate, having this granular seizure type specific data can be helpful. Similarly, most of the patients exposed, they're much later in their treatment algorithm. It can be effective for earlier line therapy, maybe more effective. The downside is that the requirement of slow titration. So if someone having really explosive onset seizure, then it may not be effective. Also, for registry or database, definitely we need to capture better cognitive behavioral and EEG outcome. So this is my last slide. So cenobamate clinically achieves clinically meaningful seizure reduction 50 to 60% of the patients and seizure freedom in 10% of patients, even in the highly refractory DEE population. It has a generally manageable safety profile. Definitely we need to start low, go slow because to mitigate the risk of DRESS. There is some syndrome-specific selection is emerging, especially for LGS, SCN8A, DEE. This medicine can be used as early line therapy. Research priority is still lacking prospective control trials, standardized outcome measure. We need to know more about cognitive and quality of life endpoints. There is one ongoing pediatric trial. This is a pharmacokinetic study to understand a little bit more about that in the pediatric population. Thank you. Thank you for the opportunity to speak today.
Thank you very much, Dr. Samanta. I think now you'll have the questions. So I'll ask the first question because mic is in my hand, so I take the liberty. How slowly you want to increase the doses of cenobamate?
So this is a good question. Actually, in adult population, they have a starter pack and they increase every 2 weeks. So they start with 12.5 milligram and they go to 25. Like that. For pediatrics, we sometimes would wait even 2 to 3 weeks before increasing the dose. So very slow, and even after maintenance, for adult maintenance is usually 200 milligram daily, which I use teenager who are more than 50 kilogram. And then when I go from 200 milligram slowly every 2 weeks, increasing by 50 milligram, I'm very careful about the skin rash as well as sodium channel side effects. But if I go slowly every 2 weeks, I have good outcome in terms of ability to, in terms of tolerance and retention.
Right. Thank you.
Thank you.
What is the minimum tablet formulary? You said there's no other preparation that you have in the USA?
12.5 milligram. It is 12.5 milligram. So I usually, for really young patient, I usually use 6.25 milligram. So they break it, the 12.5 milligram tablet, they break it in half, and they can mix in, crush and mix in water to give it.
Thank you. Any questions for Dr. Samanta from the audience? If you can use the mic, please.
Am I audible? Yeah.
Yes.
So thank you, Dr. Samanta, for the wonderful talk. I had a question on drug refractory focal onset seizures. So after how many anti-epileptics would you prefer to add cenobamate? And the second question is it possible to have such a patient only on a monotherapy of cenobamate?
That's a good question. So right now, it is off-label, at least in it's nowhere approved for pediatric indication. So right now, we are using in highly refractory patients, like maybe 8 or 10 anti-seizure medication. In general, before epilepsy surgery, we are using it. Especially in adult population, they are seeing a huge percentage of patients, maybe up to quarter the surgical failure patients, they are becoming seizure free. So at least if the patient is not a really good candidate, like they have a lesion in near eloquent cortex, or the family is risk averse, we are using cenobamate before epilepsy surgery. Our personal the outcome is not as robust as 25%. Maybe those type of patients, maybe 10% patients becoming seizure free. But in general, we are using it in a really treatment refractory patients. Now, when it gets approved for pediatrics, there is expectation that after PK study, there would be the age range would come down to up to age 4 or up to age 2 years of age. Then we are going to use it cenobamate. In our kind of insurance situation, usually they ask step therapy. So if you have a brand name medication, usually they want the patient is failing at least 2 anti-seizure medication before using cenobamate. In terms of monotherapy, right now the indication is for adjunctive therapy. We have several patients that we are able to completely wean off other medication. In our practice, is around 15 to 20% patients that they are currently on monotherapy. There are some studies done from database, insurance database, and they noted maybe 10% of patients there on monotherapy. So there is definitely potential. Personally, I prefer to use either with clobazam because of possible synergy between this medicine. So I sometimes would keep the clobazam going with a smaller dose. Thank you.
Thank you. So can we have the last
Make a
question?
comment?
Yeah.
Last question
Can
from
I make a comment?
Ranjit.
Yeah. So thanks for an excellent overview of cenobamate. I have a quick question. Most of these patients were trialed after 8th or even said 15th drug. So how does it compare to a non-pharmacological option like a keto diet or a neuromodulation? The other one is as an add-on effect to, how does it contribute as an add-on effect to keto diet and neuromodulation?
Yeah, I have definitely many patients with neuromodulation. I have only a handful of patients that they are getting both keto diet and cenobamate. It's difficult to know in terms of drug and keto diet interaction. Usually, it is. I never had any issue with this interaction. Cenobamate, there are many studies coming because usually cenobamate is getting used in these intractable patients and it's noted to be very effective. I even had patients that they had used RNS that I can monitor how they're having daily seizure, and there is a precipitous drop as soon as I started them on cenobamate. In terms of the comparison of efficacy, definitely LGS population I have most experience. I find it definitely seizure freedom rate or close to like a super responder if they're having greater than 90% respond. Cenobamate is better in terms of efficacy. I think that the main reason I still feel like if you have intractable patients and you have option of cenobamate versus diet at least, maybe using diet would be helpful because of the non-seizure outcome. Because you most probably you may see some improvement in alertness or those type of things. So I usually, because it's a reversible nature of diet, for LGS patient, I would use diet first and see if that can be helpful. For definitely neuromodulation, right now, most of my patients, they are getting neuromodulation first before cenobamate because we have indication for LGS, at least for VNS. But over time, if we have a pediatric indication, I most probably would use at least a subset of patients cenobamate first before neuromodulation because of the surgery and cost associated with, like a one-time high cost associated with neuromodulation.
Thank you. I think Dr. Arya wanted to make a comment. Is that right, Dr. Arya? And any
Yes,
questions
please.
for him?
So,
carry on, please.
let me make a comment about what was being discussed. So this is excellent. Every patient with drug-resistant epilepsy is different. And if I have a clear surgical target after stereo-EEG evaluation, I think it's better to go for surgery first. However, that being said, I fully agree with Dr. Samanta that we are actually increasingly using cenobamate in our patients who have occasional seizures after surgery as well as clear surgical failures. Another use that I found, I have a rather large population of patients who, for the sake of better term, I will call super refractory generalized epilepsy. These are patients who have been on optimal VNS for over a year. Their duty cycle and current strength is optimized. They are still having tons of seizures in a day. We have implanted them with thalamic RNS, bilateral centromedian RNS. what happens is, at least at our center, we program centromedian thalamic RNS using 5 hertz stim. And it takes a while to build the charge density. And that's the situation where I found cenobamate a good temporizing measure. So that's another niche population where cenobamate can help you get to the neuromodulation target. Thank you so much.
Thank you, Dr. Arya.
In one of your slides, you had mentioned the use in infantile spasms. Is there significant data? Because
No,
that's
it
what-
is not significant. So the only case series, that's a small case series with 6 patients with infantile spasm, only published in an abstract form. So we don't have really detailed data. But what that abstract described that out of 6, 4 patients had clinical response, but we don't have a lot of good EEG data in that abstract. But there's a report maybe 2 patients also had EEG improvement, but we're not sure that's a hips arrhythmia resolution or just a change in the best score.
I'd like to thank both the speakers, online speakers, Dr. Arya and Dr. Samanta. And we have to move on in interest of time. Thank you very much, both of you. Our next speaker.
He has done before, no? Yeah, he was just. Yeah. So, I'd like to get back Dr. Srinivas Murki for the Indian experience with the disease registries, success stories and key lessons learned.
So good evening, everybody, and thank you, Lokesh and Team Neurology for inviting neonatologists. So we have a Indian National Neonatology Collaborative, and I'm trying to see how we have been able to establish and what can be done as far as neurology registry can be developed. So I'm not going into dwell into all these slides. I'll just show you directly the registry so that you understand what we have been doing. So I'll just so this is called Indian Neonatal Collaborative. So this collaborative has more than 40 centers now. And we have more than 70,000 newborns enrolled in this registry now. So I'm going to enter into my hospital data and also show you what we do for entering data into the registry. So this is the data which is there. Now these are the completed babies. So this is the data of the babies in this registry from one of the hospitals. And you enter, this is the dashboard. So you get the name of the place, the dashboard, how do you enroll a new baby into the registry, the completed babies in the registry, if there are any readmissions, the follow-up of those babies after discharge, and then the reporting. This reporting will be not only for the hospital which is doing registry, but it's a consolidated reporting. So this is just the enrollment form, how each baby gets enrolled in the registry and what is the criteria for enrollment. Then we have the basic data, which is place of birth, maternal data, delivery data, resuscitation. Then why this baby is at the admission into the hospital, what was the parameters and the severity score. Then the major morbidities which the baby has undergone through our NICU course, sepsis, culture positive sepsis, distress, PPHN, PDA, seizures, if seizures are as the cause for seizures, and what type of medications were used for seizures. And also even hypoglycemia is also in this morbidities. Then we have the investigations which the treatments which the babies have received, including antibiotics, the antibiotic courses, the duration of antibiotic courses, whether the baby received surfactant. For us, important is to know the duration of respiratory support, like oxygen days, CPAP days, invasive ventilation days, TPN days, and the other thing, and the disposition form. So this is the discharge, how the baby was discharged, what is the weight, what is the anthropometry of the baby at the time of discharge, type of feeding. And so after that, one more interesting thing is, apart from registry, we have created a discharge summary from the registry. I'll tell you why we have to do this. So this is the summary which will be auto-generated if somebody enters the data into the registry. So it's a PDF and a Word format. You can edit the summary which is generated by the registry. So while the summary is getting registered, sorry, it's not happening, but it is a very detailed summary which will get generated. Now this is the reporting of the entire registry. So this is a dashboard of the patient. So there are 76,000 babies enrolled in this registry from 2016 onwards. We started in 2016. 70,000 babies are discharged. That means 6,000 babies data is still yet to be entered. There are 9,000 very low birth weight, less than 1.5. 3,600 babies who are extremely low birth weight. So this data from one center is almost impossible, or from few centers almost impossible. And we can click on the year, and once you select the year, then the data for that year get displayed. And the overall mortality is in the registry is about 5.7%. And we can have the details of these babies who died in the collaborative, and the reasons for death also we can get to know. So this is the details, and these are the centers, and how many outborn babies, how many inborn babies, and you'll get the display of the babies by the units or center, how much each center is contributing, we'll get to know in this chart. And we can know year wise, and yeah, you can see the center 75 is producing the maximum number of babies, and center 60 is contributing to the next maximum. So we won't know which centers are this. These are all coded, and only the center themselves know what is the code for them, so that they can download the data for their center only. But you can see here there are more than 75 centers, but the active centers are only 24 now. So these are the morbidities in all our babies, in that 76,000 babies. Malformation rate, culture positive sepsis rate, RDS, and we can also filter by weights, we can filter by gestation, the morbidities. We also have the data of culture positive, and so you can see that we have the data 4,700 babies culture positive data, and the average duration of antibiotic days is 12. What organisms and their sensitivity pattern also is coming from this data. Necrotizing enterocolitis data. Then we have the intervention data, how many patients have received CPAP, NIV, mechanical ventilation. Then this is the discharge, average length of stay, and babies on feeding at the time of discharge, number of babies with cystic PVL, ROP, IVH. So most of this data is possible, and this is comparison of morbidities across the centers. So yeah, you can see center 2, number of babies enrolled, LAMA rate, culture positive rate. So this is a help in quality improvement. So why some center is doing better than the others in particular morbidities, we can try to look at that. Similarly, the interventions across the centers, which center is doing more interventions or what type of interventions they are doing. Maybe for neurology, you can think of more EEGs or more NCVs or whatever it is. You can try to compare and see. Then we also have, this is a dashboard, but you want to download the files, I can download the entire data in an Excel form for my center. So because based on the username and password which I used, I can download the data from my center from the starting date to end date, say from 1st of January till now. And I can also try to say what exactly I want to download, only the enrollment form or the morbidity form or the outcome forms. So based on that, I submit and I get a downloadable Excel sheet. So we also, after this, we created a follow-up also. And so I finished. Yeah, I'll just show you the data and then. So we also created a follow-up format where babies come for follow-up, and then it can link to email ID. This shows that all these babies are not followed up because most centers are not using the follow-up module. But I'll just try to summarize the problems which we faced and what we have done to improve the quality of our data. So this is the journey. 2016 we started, and today we have 70,000 babies enrolled in the data. And what we have to do is that obviously the institute which are going to become part of the registry have to be taken into confidence. Each of the institute have to give their ethics approval. So the ethics approval is not uniform for the complete registry. Every institute has to get ethics approval for enrolling their data into the registry. And we need to have the minimum data set. We, out of, I think more than 200 fields were there, out of which 70 fields are never used in the database. So we try to decrease and minimize the number of data fields so that entry becomes easier. And it took us for 3 to 4 months to build the database, and about 3 to 4 lakhs initially. And after that, there are a lot of changes which happened because some centers want some particular fields to be introduced and some particular methods to be followed. So it took us 4 months to come online. And this is how the workforce day to day, baby screen for a particular problem or entry criteria is fulfilled. Then data is entered, center coordinator reviews. They get a weekly email. The center coordinator gets a weekly email, how many babies got admitted, for how many babies data is complete. And we also share the data on a monthly basis. These are the challenges. So there is uneven engagement because most centers, they will come forward saying that data will be entered, but will not be done. And no dedicated data entry operator in most of the centers. So it's either done by residents or by sometimes even by the nurses. And most worrying problem is the EMR duplication because most hospitals do not want their data to be entered into another software. So we need to find a way to integrate the existing hospital EMR to the database. Another major problem is the data authenticity. How are we sure that whatever is entered is appropriate for that baby or not? So there are a lot of validation rules which are involved. While the data is entered, it doesn't take, suppose gestation is 45, it will not take because the validation says only from 24 to 40 weeks. So we need to have validation for each one of the fields and see that it highlights if there is a problem. And if the weight is entered in grams, it may not take because if the babies are recorded in kgs and somebody puts in grams, it will not take it. And platform downtime, this is again major issue because if something doesn't work, the entire workforce get disappointed. So there will be a lot of calls and a lot of messages saying that data is not working. How much time you will take to correct, because debugging also is a very huge challenge. And another major thing is funding. Although people will come forward to start the database, but for running the database, you need minimum 10,000 per month for a data of this nature. And unless you have constant source of funding, it is going to be a problem. So some of the solutions we found because of the duplication, we gave this idea of discharge summary module so that if people are wanting a summary from the database, they can get the auto-generated summary so that their workload can decrease. So people started entering into the database because the residents get the summary from this. And we also have weekly coordinator emails where automatically a mail will go to the coordinator of the center saying that how many babies were registered and how many forms are completed. We also have this Excel report module so that they can have their own unit-based database. And we created the Power BI dashboard for doing quality improvement initiatives and compare their unit with other units. This is the cost, running cost, and cost mainly requires for server hosting, database cost, SSL certification, debugging, and other support time. And we also had published some work from this database, and I'm going to show some of them. This is short-term outcome and predictors of survival among neonates with asphyxia, predictor of length of hospital stay among preterm infants. Very recently, we have come out with, NNF has come out with consensus guidelines, and we use the data of our extremely low birth weight data from the collaborative to make the consensus guidelines of NNF. So our aim is to improve the platform on a day-to-day basis, and probably some of them we need to go in depth about more about our quality checks. How do we automatize summarization and also get the because now with AI coming up, you can also have research papers being generated, and you can see that the data is appropriate for that research objective or not. EMR bridge is the biggest challenge. So I think most hospitals will not allow a parallel system running. Say they want the data to be automatically integrated into their software. This is the biggest bottleneck for most of us. And some of the center we started, we have to drop down because they didn't want their EMR to be breached. So predictive flags and then other things, if we incorporate, maybe they'll be better. Okay? So if you're starting your own register, get every stakeholders, sign up before finalizing the design, budget for dedicated data entry operator, build in visibility weekly compliance emails, define your data set to the minimum needed, capture raw values, not classified. Like if you have a scoring, write the score rather than categorizing at the beginning. Plan the ongoing maintenance initially and give centers something to get back, because they either a summary or an Excel sheet or some way they will benefit out of the data, then only they'll start doing it. So that's all. Thank you.
Thank you, Dr. Srinivas, for going through the Indian experience. Any one burning question for him?
I try to look at it, but I don't have access for the entire database. But symptomatic, asymptomatic hypoglycemia is captured. I can give you the data, because for everything, if you want data of the total centers, then we have to write. So we have a board, we have a chairman, and we have to write to the chairman that why I want the data, then only the data will come to me. And it is a encrypted data, and you have to give the research idea, you have to get the objective and the protocol ethics approved, then only the data will come. So I cannot take the data by myself. So anything I want, if you want some data on hypoglycemia, then there has to be a research question. There are at least 7 big public hospitals in the data. Most of the others are private. So I can name that JIPMER is part of it, ICH Chennai is part of it, PJ Chandigarh is part of it, GMC Chandigarh is also part of it.
Thanks, Dr. Murgi. I had one question. There are some international electronic databases like RedCap and all that. We can't use that?
RedCap is more for research. So it is like you want to collect the data, you can collect in RedCap. So that's very simple, it can be easily doable. This is more like WAN, CNN, Canadian Neonatal Network, or Vermont Oxford Network. So it is similar to that, where we are capturing all the neonatal data. But if it is going to be neurology, I think you have to think whether you want to collect all the neurological morbidity data or only specific. If you are going only for specific, then it becomes more like a research question, and where RedCap will be useful to collect the data. But if you're thinking of a generalized continuous activity, because in research there is an endpoint, but here there is no endpoint. We continue to do it, and it has to be done on a regular go-to-go.
So like RCTs nowadays have become adaptive RCTs, that after some time you keep reassessing your data and then change the RCT. So these registries also keep on adapting?
Yeah, that's what actually now we are trying to, because of the AI which has come into this. This was made almost 2016. Now we are redoing the entire module so that we can integrate more AI into the database. So probably we'll be able to get more authentic data. Maybe data entry will become much more easier, and maybe the analysis will become much more easier. So we need to make it as simple as possible and as easy for the people to enter, because most of the time data is entered by the registrars or the residents. So we need to see how they get benefited. So what we do is every year in our units, we give one thesis for one student so that he enters the data and he gets the data from the registry.
I'd like to thank all the speakers for this session. We come to the end of session 4. I'd like to hand you back to the organizers. Thank you very much.
A big thanks to the moderators for such a comprehensive session we have had. Since we are running short of time, we are not going to be able to have a tea break, but we have running coffee and tea stations. Please feel free to utilize it anytime you want. So coming to the next session, this is the focus of the conclave. This is regarding the AOC and NHBI registry. What is the vision and what is the road ahead? For this, to chair, I would like to call upon the moderators, Dr. Biswarup Chakravarti and Dr. Sirisha ma'am to the stage. And to speak on the topic, NHBI, data and evidence in India, I would like to call Dr. Naveed Sankyan sir to address the gathering.
Good evening, everyone. So, thank you, Dr. Lokesh, for this idea and really bringing it to this final conclusion where we all meet and discuss this. And I'll just carry on from what was discussed in the last proposal. I think what we thought of is that it will be a defined endpoint. We'll collect the data. And so it's more in the research mode rather than a whole encompassing collecting all kinds of data and having different endpoints decided later on. So I think my objective is very clear. In a few minutes, I have to tell you what data is available. I've not done a systematic review, but because the studies are so far and few, I just want to give you a flavor of why we need to do this study or why we need to have this collaborative work and how it will benefit science, how it will benefit us in terms of our knowledge in this field. So you have got a glimpse of how this data would be collected. One way of collecting this data would be that we begin with the neonates. We have, like, the ideal would be a registry like what was discussed by Dr. Murki, that we have that registry. We have already data recorded in the neonatal period that this and this patient had hypoglycemia, symptomatic, asymptomatic. We know the duration of hypoglycemia. We know the interventions in hypoglycemia. And we then follow these patients up and preferably at least few years of follow-up so that we know their developmental status. We know how many develop epilepsy, how many develop autism, developmental issues, ADHD. So we have a very robust data in terms of what is the outcome of neonatal hypoglycemia. Now the problem with this is that this is prospective, or it has to be a very rigorous retrospective cohort study, and all cohort studies are very expensive. They are long duration. It takes years to get the answers. And I mean, their registry is a very good starting point, but I have to really ask them whether they are really collecting the follow-up data, because after the neonatologists finish, whether there is a continuity of data collection in terms of what later happens to the child. So that is one challenge. But there has been some effort in collecting this data. I have not looked at this aspect because we as neurologists are not going to look at data like this. But this is a small study from PGI where you had 72 hypoglycemic children, and it was described that at 12 months, 8% of them had cerebral palsy. And of course, those who had symptomatic hypoglycemia had more developmental delay rather than asymptomatic hypoglycemia. But we'll see how data differs across centers. Cerebral palsy, as at least neurologists we know, it's not a very important consequence of neonatal hypoglycemia. There are other features which are much more prominent, and diagnosing cerebral palsy at 1 year again is very challenging. Another study, this is from Kashmir, I think, yes, from Srinagar, prospective cohort of 259 neonates, and they are prospectively evaluated, but data of only 85 is available. So 15% had 17.6% had developmental delay. Now, and those who were imaged, out of these 15, 6 had the typical changes of neonatal hypoglycemia. Now, just compare this data with what the systematic review shows. Now, this is a systematic review involving 12 publications and close to 1,657 infants. And what they say is that neonatal hypoglycemia was not associated with neurodevelopmental impairment in early childhood. So, this is data from the West. And only in later childhood that there is a odd of 3.62 of developing neurodevelopmental impairment. So that is a mild developmental impairment which manifests later in childhood. So, we will be shocked, at least the neurologists will be shocked that, oh, neonatal hypoglycemia not causing it, we can't believe this data. But if you look at Western studies, this is what they show. It is just the way in which you collect the data. Okay, so let's look at how we look at NHBI. So we sit in the clinic and we see children coming with epilepsy. We image patients who come with developmental delay. We see patients who have microcephaly, visual impairment, and we image them. Many of them, in fact, most of them would have history of hypoglycemia. And then when you look at the typical pattern, you diagnose, okay, this is NHBI and this is a sequelae of NHBI. So this is what we are looking at. We retrospectively obtain what happened in the newborn period. Sometimes you get the digital records, sometimes you get paper records, sometimes you don't get anything except for some sketchy notes and a little bit of history. So we do have studies which really look at this. And there are so few studies that I'll narrate each of them. Now, you just see from where the population which is being studied, it varies a little bit. So this is one of the first studies done by Dr. Udani and his group. So they looked at infantile onset remote symptomatic epilepsy, 100 children. And so they were of different etiologies. And 83% had some kind of established etiology, out of which 50 children out of 100 had perinatal insult. And out of these 50, 23 children had neonatal hypoglycemia. So in a way, among those with perinatal insult, 50% had NHBI as the insult, and they later developed infantile onset epilepsy. And they also, all of them had microcephaly, and 60% had autism, 50% had cortical visual impairment. So we really see that they are significantly affected. And you can see that one of the discriminating features is they don't have much spasticity or dystonia, quite distinct from what the other report was showing. And we know that when you have a cohort of epilepsies coming early in childhood, you would see infantile spasms as the most common. And importantly, the drug refractory epilepsy is seen in more than half of these children. So it is very similar to what you would find in other studies. Study from Indore. Dr. Gauri is sitting in the audience, and this was a retrospective audit. Again, now here the group changes. Now you pick up children who have infantile spasms, and then you have at least 3 months of follow-up. So they reported 56 infants, and 20 of them, somewhat around the same figure, had NHBI as the insult. And they went on to compare those with NHBI as the insult and those who had HI as the insult. So microcephaly was more common. Visual problems were more common, not surprising. And spasticity and dystonia were more common in HI, something which was shown by others as well. And we know the posterior gliosis would be common in hypoglycemia, but frontal gliosis was more common in the HI. Importantly, treatment response did not vary, but this was a very small number. We know that treatment of NHBI related seizures is very challenging. One other point was that the onset of spasms was later compared to the HI group, 9 months versus 4.3 months. But this was a small set of patients. This is study from Lady Harding, retrospective data encompassing 10 years, 11 years of data, 170 children. They start with children with epilepsy now. We are moving forward from infants. This is children with epilepsy who have documented NHBI. So this is a select group. This is not all kinds of epilepsy. This is just those who have documented hypoglycemia and also have epilepsy and come to a neurologist. So most of them have those typical changes. And I'll just give the figure of drug refractory epilepsy, 68%. And global delay, 90%. Vision impairment, 50%. Cerebral palsy, 44%. Microcephaly, 38%. Then you have this data from rural Maharashtra. This is a descriptive study of 60 children with documented hypoglycemia, and seizures on follow-up is seen in 51%. So again, they compare HI and NHBI, and greater proportion of seizures later in life is seen more with NHBI. And this is the latest published study, again from Dr. Udani. And this looks at those who have, so this starts with imaging. As Madam Kalra had pointed out, you have to decide as to what is the entry point. Here the entry point was that they have those typical imaging changes, and then you enroll these patients. And they had a very long follow-up of 11 years. Look at the seizure freedom rate, only 20%. 80% continue to have seizures. 70 to 80% meet the criteria for drug refractory epilepsy. And a sizable proportion has intellectual disability, autism, cerebral visual impairment. So very similar findings if you start the other way around. This is our own data, and we had a start point of 3 kinds of enrollment criteria. One, where it was clearly NHBI. You had a documented low glucose and you had the changes. Second was you had history clearly suggestive. Parents said that the glucose was low, but you don't have a clear value of glucose, and you have the imaging changes. And third group was possible NHBI, where you had lethargy and the setting for hypoglycemia, and you had the imaging changes. So among these 3 groups, we had 195 children, and 170 of them underwent a imaging. So males were dominantly having this insult. In fact, it is in 2 studies it is shown 4 times male babies are affected by NHBI injury rather than female babies. High incidence of epilepsy in this group, high incidence of microcephaly, very similar findings to what the other studies are showing. And you have these typical posterior dominant changes as well as involvement of the pulvinar, and sometimes the involvement of the posterior limboventral capsule. Sometimes it is known as the boomerang sign or the L sign, bilateral, symmetrical changes. So finally, the last slide, most studies in India have less than 150 children. Inclusion, exclusion, how they are looking at data really differs across centers. If you look at research centers, if you look at centers which start with newborns, you will have very few sequelae, because most of the babies are cared well. You will not have sequelae. But most of the sequelae are happening in the low resource areas where the delivery happens, insult happens, and the patients then reach to pediatric neurologists. So you will see more sequelae. So this is basically from which angle you're looking at data. So we will argue with the neonatologists that this has a lot of sequelae. Neonatologists say, I've never seen a sequelae, particularly those practicing in high resource setting or, in corporate hospitals. So what do we need to really answer this question? So we need to identify, as Madam said, clear entry points, have a very large data set, and really representative of the low resource limited settings, good quality data, clear endpoints, clear definition of enrollment. And we need to really also focus on, though there will be a lot of recall bias, as to what was the root cause of hypoglycemia in individual patients, so that some kind of preventive policy decisions can be taken at the end of collection of this data. Thank you.
So thank you, Naveen sir, for that excellent presentation and a review of all the reports from the various parts of the country. In view of constraint of the time, we would just go ahead with the next session. We invite Dr. Siddharth Shah to give his talk on the vision, objectives, and the scope of the NHBI registry.
Good evening, everyone. So, in the interest of time, we'll move on quickly. So basically, from morning, what we've been hearing in different sessions, what is our vision? And really looking at Naveen's talk, so what is the scope within NHBI? or what is that we are collectively all looking for in terms of data. So couple of things. So for the vision for NHBI registry, we were going to divide it into individual center level, regional level, sorry, should I just make it? National level, international level. In terms of even approaching government and looking at policy revisions or changes in policies, we can also, our data can help immensely with that. And lastly, support system and employment provision for children who have been affected and have disability or cerebral palsy due to NHBI. So at the individual level or regional level, we're looking at streamlining of data entry. We're looking at maintenance of data. So as collaborators or as people helping with it, this is going to be some of your responsibilities. Effective retrieval systems in place. So if somebody gets back to you regarding a particular case or particular more data, then there should be that in place as well. And we want to look at improved scientific work for regional and local teams as a collaborative effort. At the national level, we've been hearing that we have strength in terms of numbers, but we looked at Naveen's research and saw that there's a dearth of research because it's an Indian problem and nobody else wants to look at it other than us. So we need to showcase our collaborative work across the nation as an example, harness the numbers, look at high quality research publications if this can come out of this, and we want to learn from each other and learn from leaders in their own fields. Internationally, again, we want to showcase the data on larger platform to gain scientific traction, influence policies in similar demographic countries. So we would be looked at as a low and middle income country, but there would be countries who would like to learn from our approach and maybe might not have the infrastructure and the funding to do what we are going to do. Preventive measures can be implemented at an international level using all our data and our suggestions, and funding agencies to notice the number, effort, and collaboration that we have done through this project. In terms of policy revision and change, and we all understand that newborn feeding guidelines need to be looked at because NHBI is actually going to be one of those preventive causes we would like to prevent rather than treat. Strict implementation at all levels, make maybe NHBI a reportable condition, and that would help enforce our data. Root cause analysis at grassroots level. We were hearing about ASHA workers earlier, and Sir had earlier mentioned, and such a commitment at the grassroots level would make it even more meaningful and eventually reduce the burden of NHBI in our country. So in terms of support system and employment provision, our country lacks in multidisciplinary support for multiple disability at one center. Again, we heard earlier how patients need to travel a lot. I think Kaushik was saying, Jaishankar Kaushik was saying how in Assam they have made an effort to bring multidisciplinary care under one roof and at one center. We need to look at the visual handicap and visuomotor handicap. So as Naveen showed again in one of his data that it might not be an obvious cerebral palsy, but it might be just visuomotor handicap, and that might need to be recognized. Other features including cognitive delay, epilepsy, behavioral issues need to be looked at, and set up centers to deal with multiple abilities. So not only recognize the problem, but also come with a solution. In the end, vocational rehabilitation and employment provision in liaison with PPF model might be a solution as well. Now, I've split the whole problem of NHBI into certain areas, and I'll just finish quickly by going through one of them, by going through all of them one by one. And there might be unanswered questions that come to your mind whilst you look at these slides. So, first of all, the threshold of hypoglycemia and NHBI. So there seems to be an unanswered question of how much low glucose is problematic. And I'm sure there is not one figure. So there are certain figures available, and in the first 24 hours it's different. It's different in after 24 hours. It's different for full term, it's different for preterm, and I still think we don't know how much sugar, how much of an hypoglycemia or low sugar is actually a low sugar in terms of causing neonatal hypoglycemic brain injury. In general, some studies seem to suggest that 0.7 to 1.5 millimoles, so that's, I think, multiplied by 17 for our figures, led to occipital change in neonates. But that's only occipital changes again. We don't know about long-term disability and whether, a slightly milder hypoglycemia might lead to a different problem. It's not just the severity, so the duration also is going to have a larger impact. So a slightly low hypoglycemia which is corrected quickly versus a lower hypoglycemia which has lasted a bit longer is going to have a different impact. And again, comorbidities. Now, a lot of papers and a lot of chapters talk about associated hypoxia and hypoglycemia. And a child who's already hypoxiated, hypoglycemia will lead to a larger impact. In terms of pathology and neuroimaging changes, we all know that the severe acute phase will cause parieto-occipital cortex edema, and in chronic phase that will ultimately transform into gliosis or atrophy. But it's not just the parieto-occipital cortex. Of course, number one, we all don't understand why it's always the parieto-occipital cortex, but also the splenium of corpus callosum and corona radiata, which can be reversible as well, has been documented. It very rarely involves the basal ganglia, but bleeding in the basal ganglia has been reported in studies using neuroimaging in patients with hypoglycemia. Of course, diffusion-weighted imaging and ADC on MRI brain early after hypoglycemia can be very, very careful. And of course, the use of MR spectroscopy to understand the biochemical changes happening immediately or later on after hypoglycemia can be looked at. In terms of pathophysiology and pathogenesis, it's unclear. It's unclear why the occipital lobe. There are a couple of mechanisms suggested. One of them involves an MDA receptor activation, which ultimately leads to cytotoxic edema. Other than that, oxygen-free radical injury has also been implicated. In terms of clinical manifestations and risk factors, we all understand the clinical manifestations. Early on in neonatal period, the floppy lethargic baby, and maybe seizures on the 3rd day of life after in neonatal period. And we understand the implications later on. There are a number of risk factors, and I'm glad Naveen mentioned the male risk factor, because we've all noticed this, and especially in preterm babies who are twins, we've noticed that the male sibling is always the one who suffers as compared to the female sibling. But along with that, so small for gestational age, 3rd percentile, infants of diabetic mothers, asphyxia and hypoglycemia, septicemia, some metabolic problems can all predispose a neonate to have hypoglycemia and hypoglycemic injury. In terms of outcome, last couple of slides and I'll finish. So outcome of NHBI, a prompt diagnosis and treatment can certainly warrant a good prognosis. So that could be at the neonatal period, it could be early in infancy along with early intervention. So all of these babies need to be labeled as high risk and need neurodevelopmental assessment. How frequently, when to do the neurodevelopmental assessment, when to do an MRI, all are questions that might need to be answered. We all know about the list of sequelae, and this includes hearing as well, so it's not just vision always. In terms of prevention and intervention, so should it be blood glucose testing in first 72 hours, at least in high-risk infants? Early feeding practices need to be looked at. Of course, we can look at neonatal brain plasticity because early intervention is key and fundamental to those children whom we know are at risk of developing sequelae. And EEG early and treatment of seizures, so just like we understand in tuberous sclerosis and infantile spasms, is there a role of doing an early EEG and identifying those children and trying to prevent autism in these children? And ultimately, sitting in those clinics, we all deal with drug refractory epilepsy in these children and are quite frustrated. So we don't know what the best medicine is. We don't know when epilepsy surgery is applicable. So basically, as a clinician, just as a summary, these are the possible questions we can all think of and try and collaborate and work towards. Thank you.
Thank you, Dr. Siddharth, for that very crisp review of the entire, as a clinician, about the NHBI. So we now go on to the next topic. This is about the participation in the registry. What are the eligibility, what are the roles and obligations? We invite Dr. Murli Mohan Reddy. Yeah. To speak about that. We request Dr. Naveen, sir. Yeah, we request Dr. Naveen, sir, to come onto the stage and co-chair the session so that we can all participate in the discussion.
So Dr. Murli will give an idea about what has already been done in terms of preparation for this, but this is all fluid and still under discussion, and we were waiting for the gathering here to give their inputs to really modify this, but there was a framework built on which further discussion can happen. I'm sure there will be a lot of ideas, and that is the whole exercise of having everyone here. So broadly we will outline what the small group has put in place, but everything is open to discussion.
Thank you, sir. So I think the session is sort of intended to achieve two purposes. One, again, just summarizing what has been done so far by the small group, and then putting it across to the larger group for discuss, deliberate, and then come out with their suggestions to improve. And then maybe once that exercise is done, then we'll have a demonstration of the workflow on the platform, so that everybody can get a glimpse of how the entire registry is going to look like. And there is also start of trial stations put outside. If anybody would like to just try it hands on and see how the the look and feel, the user experience part of it, you can experience that too. Today and tomorrow, both the days it will be available. So we have started the sort of I hope the screen is visible. So we have started the discussions in the month of July 1st onwards. So initially we have started with the protocol drafting exercise after a few rounds of initial discussions about what should be the scope. So we have drafted the protocol. It has gone 4 to 5 rounds of iterations, and then I'll be sort of quickly taking you through what is the finalized scope of the registry in terms of objectives. And also we have deliberated on what should be the research governance structure of the registry, how many committees should be there, what should be their roles and responsibilities, who should be part of those, what kind of profile should be part of those committees. But we did not discuss about exact what is going to be the composition of the committee. That I think again the larger group can finalize that. We have also sort of finalized the list of variables, case report forms. Again has gone 2-3 rounds with the CRF, and I would say very preliminary CRF is ready along with the data dictionary, and the same thing has been created as electronic data workflow for the sort of trial purpose. Initially we are intended to sort of obtain ethical committee approval from Index Center, but again since the protocol is still evolving, we have not we thought of postponing it to sort of once the protocol approval comes in with the scientific committee, then only we'll go for ethics committee approval. And then now the sort of the intended purpose of this session is to put it all across to the group, and then try to get the group consensus and try to sort of in a way consolidate, zero in on some of these things. So first I'll take you through the registry governance architecture. So again, so we are sort of, again, the small group had suggested that it would be better to have sort of, very, I would say, very simple governance structure rather than having too many committees and, creating a lot of, complexities in sort of, defining the roles and then sort of lot of whatever, conflicting and overlapping kind of roles. So the registry governance architecture, yeah, I'll just. So we are, what the small group had proposed is 2 committees. One would be executive steering committee, which would be the overarching, governance structure, which will have the final authority on every decision about the registry in terms of the scope, in terms of obligation, defining the obligations and rights of each center, and handling any potential questions and conflicts in future. That would be the final decision-making body. It would comprise of about sort of 9 to 11 people, again to facilitate voting, odd number of people. They can be predominantly comprised by senior sort of consultants from AOC and fraternity, and also some of the members can be from outside AOC and fraternity, which can be an epidemiologist, which can be a legal person, or which can be an international representative with an experience of being part of a registry, so that they can bring all that wisdom and insights to the table. So that is the first committee which is proposed, and second committee which is proposed is more like an operational committee, which is a scientific advisory committee, which will comprise again predominantly fraternity from AOC and the clinical specialists. Along with that, there can be methodology experts from sort of again epidemiology background or biostatistics background or data science background to sort of again facilitate the day-to-day operational implementation. Again, scientific advisory committee is going to be vested with the responsibility of sort of reviewing all the scientific protocols, finalizing them, reviewing all the CRFs, data dictionaries, and finalizing them. And also it will lay down the publication, evidence generation publication pathway for the registry. And all the matters related to the scientific aspects and technical aspects of the registry would be handled by the scientific advisory committee. Yeah, all the site PIs by default would be part of the scientific advisory committee, and depending on the sort of number of sites and different categories of sites, again the expert sort of executive steering committee can decide on the voting rights and other things as we sort of once we embark on the journey. So so we have drafted a mutual non-disclosure agreement format. Again, we have made it a mutual non-disclosure agreement because initially, whenever a site is expressing interest to be part of the registry, the sort of registry, again secretariat has to share the protocol document, maybe CRF, data dictionary, and other things, for them to take a look at it. And also, the center would be sending some data regarding probably their patient volume, the kind of facilities which are available, and maybe some other, maybe even the aggregate numbers about the, some of the clinical data. So since the data is exchanged, both ways, it is going to be a mutual NDA which will be signed at the initial expression of interest. So once both the sites go through the provided data and then decide that yes, this particular center can be part of the registry, there is a detailed set of site level terms and conditions which are drafted. So these are the site level terms and conditions which are drafted, which will again sort of clearly outline what are the rights of each center and what are the obligations of each center and what are the entitlements in terms of the scientific outputs and also the data asset. So these are some of the key sections I would like to probably take you through. So in terms of the site eligibility criteria, we have prepare a site assessment checklist based on this availability of so what level of center, whether the specialty pediatric OPD services are available or not, and then site PI profile, then access to MRI, access to EEG, and then access to institutional ethical committee, and other basic operational things like internet and devices available to host the electronic data capture system, annual case load. These are the criteria which will be applied to every site, and each site will be classified as a site which is capable of providing data to the core registry, a site which is capable of providing data to the expanded registry. And we are now in the process of further expanding the scope to establish some of the centers as sentinel sites, which can provide even the denominator data also, where there is a coexisting neonatology unit also, right? And the obligations of each center, I would like to just take your attention to few critical points in terms of data protection and data monitoring. Yes, I think most of them, most of the questions would be around data ownership. Yes, data belongs to the center, right? So that the center is the ultimate owner of your center's data. But whatever the pool data which is going into the registry, AOCN would be custodian of the pool data. So anybody who would like to produce scientific outputs, want to utilize the pool data asset, there will be a clearly outlined mechanism in place where each site will write to the scientific advisory committee and executive steering committee about the intended purpose, what kind of outputs they are going to produce, and then how it is going to be published. And the approval would be defined by a clearly outlined framework, which is ratified by AOCN already, which is a very transparent process. And data protection and confidentiality, again, AOCN would ensure that whatever data which is coming into the registry, it is utilized in an anonymized manner, de-identified manner. All the safeguards with respect to data safety security will be taken care at the product level and also at the process level once the data comes into the registry. But before data comes into the registry, there are certain obligations from the center complying with the consent and other rules as per DPDP 2025. Those obligations will fall onto the site. So governance, publication and authorship, which I have already highlighted. Intellectual property again would be belonging to the AOCN. From any intellectual property, any outputs coming out of the pooled data asset. Funding, right now there are no obligations, but I think going forward there would be some mechanisms to will be put in place probably to support some of the centers with high volume data in terms of one of the important suggestion given by Dr. Naveen was to have a central data secretariat kind of thing where there will be certain number of data entry operators will be employed, and if any center is if they require any support with respect to data entry and other things can be extended. So these are the practical operational challenges which we will try to provide solutions on the go. So I think I've covered most of the dimensions. Anything you would like to add on?
I think it's just to give you a viewpoint of, it's a simple cross-sectional data collection, but look at the complexity, look at the way things are planned, look at the way things are documented. So that's how, good data is generated. Each step is documented, each change is documented, each data is verified, and that is how you produce good quality data. And that is how you, bring out evidence which is respected worldwide. So I think that is why the rigor is there. Any questions? We'll be happy to take. Funding aspect I'll leave to Dr. Lokesh. He's the expert on that.
Get enough funding for every conference. So currently, whatever we have raised the funds, we are trying to share. The CIPLA has given a certain amount of fund. So we all traveled here, you are staying here. But I'm trying to save part of that fund. I'm going to give it to the co-guide to help us run this one, and also save part of it to give the secretaries who are going to help us in entering the data. So this probably for next 2 years we are fine. So we have gathered enough amount. So by the time Mahesh takes over, I think by the time there will be more people who will be, once we show that we are doing it successfully, we'll be probably able to show other companies to be participating and helping us in the funding. And any conference, national conference, probably we can save something which can be routed for this purpose. Yeah, that I didn't commit to because I had not taken permission from everybody. Yeah.
Yes, I think that should be done because after all, why should it be in FD forever and ever? So I think not unlimited funds, but a certain amount to show AOCN's involvement. Like yes, that we personally did fund. You know, that funds are coming from the registrations that are made in the conferences, and also when people join, they gave a certain amount of subscription. So it would be nice to do something so good out of those funds. So, you know, so that we get a stamp that we also funded.
Actually, this has been routed through AOCN, ma'am. All the funds, what has been given, has been deposited to AOCN account, and we are routing through AOCN only. So it is not through any company directly. It is routed through AOCN funds. Thank you.
So we clearly have a set of patients who have the clear, stigma of neonatal hypoglycemic brain injury, like cerebral palsy, early onset, drug refractory epilepsy, autistic features. Now we also have a group of patients, like say at the later half of first decade, they may just come with poor scholastic performance, features of ADHD, and we go back and we see that there is some history of, say, asymptomatic hypoglycemia or hypoglycemia. So how are we going to capture these two sets of data? One, which clearly shows hypoglycemia in the neonatal period, and then the obvious stigma that we know. And the ones which show these kind of stigma, and hypoglycemia is associated, but we don't know whether it is actually causing that or it's just an association.
So I think there will be some categories of certainty, as you pointed out, because we are looking at retrospective neonatal history. So there will be some group of patients, as I said, who are definite hypoglycemia, clearly neurological imaging, neurological evaluation showing compatible clinical syndrome, imaging data, and also the typical drug refractors. Those will be the clear cases. Then there will be some probable cases in which you are almost certain, but you don't have a definite value, you don't have a definite history, and there will be a possible group. So there will always be that diagnostic certainty categories. And all of them will have some neurological issues. That's why they will come to the pediatric neurologist. So they may have mild ADHD, and you detect, that this may be related to neonatal hypoglycemia, or they could have, the severe variety of the insult. So the whole we are trying to capture the whole spectrum, but we are open to ideas. The protocol is still fluid. If anybody has better ideas, we could always amend the protocol in that sense. Yes. This is a cross-sectional study in the true sense, because if it all depends on how long we can pull it. If we can pull it for say few years, say 4-5 years, then it makes sense to have it prospective. Otherwise, it is one-time data collection in which you gather the data. If you have say 1 year or 2 year follow-up, the only advantage is that you may be able to better define the epilepsy. Or somebody who does not have epilepsy initially may develop epilepsy later. So some of the prevalence figures may change, but incidence figures cannot be got from 2 or 3 years of follow-up. Yes, everything will be reference based. Yeah, yeah. Operational aspects, yeah. Yeah, yeah. No, so but this data will be available right on the first visit. Yeah, yeah. Yeah, so all that will be in the manual of operations, which will have clear definitions for each data point. Inclusion criteria will clearly define this will be taken and this will not be taken. And the important thing is there will be a large screening population. That these many babies were, or children were screened, so many did not meet this criteria and so were left out. So you will have a denominator out of which this particular group was chosen. So there has to be a screening group also, like you said, ambiguous history, imaging not clear, imaging not available. They'll all be the screening group. No, they are not included. So there will be very clear criteria of inclusion, exclusion. We can't have ambiguity with that. Yes, please. Yeah, so I'll give you an example how that is corrected. So you will have some kind of common figures like date of birth and their PIN code of their residence, father's initial, something which is difficult to match in two children. It will be very improbable. So that kind of safeguards will be there in the software. So moment that two or three things match, immediately it will be flagged that these three things are matching for this child. So please check their data. Are they the so we can contact the centers, we can look at their imaging, there's a lot of ways to find out whether it's the same patient or not. We can always call back the patient.
One of the idea given was that any patient, if they are being enrolled into the registry, that initial enrolling center can write certain numeric code, the center code which is given on top of it, so that it is an indicative sort of sequence, where the other center, when they are trying to enroll, they already know that this sequence means that the patient has been enrolled somewhere else, right? So then they can check with the registry secretary. Yeah. That is one mechanism.
Yeah, there may be a small sticker which you put on top of every enrolled patient or something.
Otherwise, like Dr. Naveen mentioned, within the product we can have certain variables which are mapped to identify a particular patient, and try to identify the duplicate, flag them, and then try to sort of reconcile them.
Yeah, so there'll be a criteria for screening patients. That patients coming with development delay, perinatal insult, possible hypoglycemia or lethargy, and then we looked at whether they had any documented hypoglycemia, whether the imaging is compatible, and also will be patients who will have dual insults, hypoglycemia with hypoxia, hypoglycemia with hemorrhage. Those also need exclusion.
Sir.
No, that's not possible. That's not possible. That's what I discussed initially, that that would be the ideal what you're saying, but we don't have the resources, neither the time to really follow them up for several years. We are just looking at cross-sectional collection, maybe a little bit of prospective component just to capture all the data. But so yeah, I think we will require our neurology colleagues to help us with that. If they can help us with the, we write a protocol and send to their registry. They already have data collected from last 15 years, by 10 years. Why should we duplicate and start a registry of our own for getting that data? The best thing would be to look at their cohort, contact all their patients, and find out what happened after neonatal hypoglycemia. That will give us that figure.
Sir, actually, that is what I was also coming. So we may have hypoglycemia which is not coming with any complaint.
Yeah.
So if we go back to the neonatologist, then we can actually get the denominator of the ones who had hypoglycemia, and then subsequently many would be not having the problem. So we may actually have the true denominator, I mean more near the true, if we go to the neonatologist in the beginning and see how their patients are doing.
Yes. Possible.
Yeah, you should have definite, possible, probable. First
So,
thing is we
yeah,
should
so
do that.
I'll tell you what we did in our study. We used categories. So the definite ones are those with a documented hypoglycemia. We based on those criteria, one of the international criteria we followed. So there was something documented. We didn't base it on whether it was based on glucometer or but then it becomes very difficult. You don't get that data. But there was a figure written that hypoglycemia written less than 25 or very low, below 30 or whatever. We had the imaging change and we had some kind of neurological symptom because of that. Or even asymptomatic, if somebody got imaged for some other reason, you can.
I think we should make AOC and criteria for NHBI, just like
Study criteria. This will be more like research criteria.
Like
because we know patients will be there who, like Dr. Ramesh was sharing a case, in which there was neonatal hypoglycemia, there were diffusion changes, imaging 3 years down the lane is normal. And then he develops epilepsy, imaging is normal. So, you know, structural imaging will not always show that very mild insult which may still lead to epilepsy.
Discharge summary which is mentioned hypoglycemia.
Yeah. So
the patient is from some other center.
So that will form probable then, because you have documented hypoglycemia, but you have not documented the value.
Exactly. So that has to be mentioned.
Yeah. So that has to be mentioned. That then there will be patients in which parent will tell, "बहुत सुस्त था, you know, नीर खा पी रहा था, sepsis था, whatever ना," and they have the imaging change.
Where discharge summary mentions hypoglycemia means a symptomatic hypoglycemia comes under probable.
Yeah. And possible is where you have the clinical symptom, you have the setting, and you have the imaging change. But you're not certain that, you know, because there the problem is that you could have dual, triple insults also which went missing, because some of the insults like hypotension may be very difficult to make out. You know, if they have hypotension and hypoglycemia, how do you make out in retrospect whether they had both or one? Or mild hypoxia, desaturation, how do you make out? Very difficult. So there'll be some contamination in that sense. But the important thing is that we follow the criteria, we stick to the criteria, and we exclude anyone who does not meet the criteria, just so that the data is robust.
Sir, in your study, it was a neuroradiological criteria which was mandatory, and then you put forward those all three sections. Will that be like that it has to be there, a neuroradiological?
So, I mean, that is open for discussion. If you have somebody with definite hypoglycemia and has a neurological syndrome, even without imaging, I'll use it. Somebody is hospital born and you document hypoglycemia and he has some neurological complaint or does not have neurological complaint, imaging is normal, you should include it, I think.
You said since they have come to us, there is going to be some neurological issue, and we have meant that the document says there is a hypoglycemia.
Clear hypoglycemia.
So why can't we
take it?
We
We'll
should
take
take
those.
them.
So for definite, it is more serum or blood glucose. For rest of the two categories, imaging is must.
Sir, are we going to put a age limit for the entry?
So if we put age limit,
So
number
how
of patients
much?
get reduced.
So 8 months, 2 years, 10 years, 1 year?
Up to 18 years.
Up to 18 years. Sir, can we, if we are planning a study for 1 year or 2 year, can we do a mandatory follow-ups for children below 2 years, though they are telephonic?
So what happens is there is
So
a larger registry which will have the data which you will give in cross section. Then we want to look at centers who want to do this kind of, so if you want to do this kind of work, there can be a sub-study inbuilt. Okay, like for example, your center has the facility for say neurodevelopmental assessment. So if we enroll 1500 patients, maybe 250 or 300 will undergo detailed neurodevelopmental assessment. You know, out of the 20 centers, say 5 centers volunteer, they do all the detailed neurodevelopmental assessment, so that forms a sub-study of the larger study. Right, so that option is always available. You want to do neuroimaging, you have 3 Tesla MRI, you can do a sub-study on 100 patients within the larger registry and produce that data of 3 Tesla MRI findings at say 1 year, 2 year, 3 year of neonatal hypoglycemia. So that is inbuilt into the registry, a lot of sub-studies, but not with the full data set, but with a small subgroup, which is pre-decided, protocol written, and as was mentioned, analysis plan written. So it should be a priori, and nothing can be post hoc. Collect कर लिया data, फिर ढूंढ रहे हैं कि इसमें क्या है. You know, that is frowned upon by reviewers. On day one itself, we decide what we are going to analyze. Yes, they should be included. In fact, if you can share some of the snap, because thankfully, neonatal hypoglycemic brain is not difficult to identify in the MRI. Plus, you don't need too many sequences. If you have a good flare and a T2, that is enough. So all the centers need to share is maybe a snapshot, or you don't need the complete DICOM image of. Maybe those who share DICOM, you can have a separate sub-study of MRI. Look at volumetric studies, look at corpus callosum volumes and several other things. Incidentally, the L sign which I showed has just been described by Barkovic in 2023. So when we were doing this study, we identified that sign and we just looked up the literature and it had just published it.
Sir, parental consent,
Of course, consent is integral. You can't include without consent. But if there is a patient whose data you are keeping in the EMR and your ethics committee gives you waiver of consent for recorded data, you can share anonymized data.
Anything that you do with him has to be paid for by the institute. At least that's what our experience has been. So any kind of follow-up involvement will be very difficult for the private setups, because then they say, उसके बाद एक बार आपने कर लिया उसको enroll, उसके बाद आप EEG करोगे तो भी free करोगे, MRI करोगे तो भी free करोगे, हर चीज़ free करनी पड़ती है. At least that's the experience we've had.
So that's a bit odd, because any additional investigation, additional visit meant for the purpose of the study should be covered. So it should not be an additional. If it is standard of care, ethics committee will not say anything. If it is standard of care, you say we are just passively recording data, it is standard of care. They have to come after 6 months or 1 year for a follow-up, and after 2 years we always do a EEG. If that is standard of care, there is generally not a mandate to give money.
We've had a lot of difficulties on these issues.
I think it's the issue of how ethics committee perceive things, but it's not required actually.
Sir, good evening, sir. Sir, as you said, it is a cross-sectional study. So what is the purpose for our this registry if it is a cross-sectional study? We will get to know the burden and the outcomes.
Yeah.
Apart from that, preventive aspect, we can't
do
much.
Yeah. So see, there is, we can't do everything within, there are some limitations to this. So one limitation is that for identifying root causes, you need to rely on history and some sketchy data. If you start from neonatal periodicis, then you will have a clear listing of what all risk factors were there, right? So the design entirely is different.
Two designs.
There are entirely two designs. So we have to find out what we can do. So if there is a better idea, we will adopt it.
Yes, we can involve centers where neonatology and pediatric neurology services were there. So they can do prospective study.
Why not?
From newborn itself.
So what can happen is, suppose in your center you have a set of patients who had neonatal hypoglycemia and other factors risk factor documented. You enter it in the registry, right? And that subgroup can be separately analyzed. That subgroup analysis can be done. But because that data will not be available with most of the neurologists. So you will lose out on a lot of data. So on one hand is the accuracy of data, on the other hand is the amount of data. You have to find a marriage.
But that's why better we can have two data entry points. One goes into prospective handle, one retrospective. Like as you said, one child comes to our neurology OPD. All the data, whatever we are getting, is a retrospective insult.
See, for prospective, you have to follow for years together. And you have to follow up thousands to get one outcome measure. How will we do that? You look at the data I showed. In the West, if you're a good center and you have all the neonatal data collected, those are the patients who will not develop sequelae. That is the problem. If he's born in this hospital and he had hypoglycemia, and in half an hour somebody detected and treated, he is not going to develop the sequelae.
So
And those who develop sequelae will not have neonatal data. So that is the problem. You have to look at the problem from a low resource setting.
So for interest of time, we will like to, conclude the session, and we can continue the discussion, even after the session is over.
I think
Sir
dinner
is not
time would
going
be a good
anywhere.
time.
The AOCN team is not going anywhere. So we'll continue the discussion even after the timed session is over.
Yeah.
So we would like to thank the, entire AOCN team for this wonderful initiative and an overview of the registry. Thank you so much.
So just 5 minutes, I'll be taking everybody through the platform quickly, and I'll be explaining some of the critical features which are again mandated by the data protection rules, and also some of the global frameworks which we have mentioned quickly. And then, like I've mentioned, there are trial stations available. You can visit the trial station, try your hands on. And any of the extended questions, we would be very happy to answer there. Can I have the screen displayed, please? Yeah. So this is the platform. This is a web application which is hosted on a cloud platform, a secure cloud platform. The servers stay within India, so the entire data stays within India. So any center which is going to be part of the registry would be invited, using their whatever the specific email ID which they provide, which can be either institutional email ID or the PI's institution provided email ID, and they will be logging into the system. I'm logging in through the master email ID, and there is a two-factor authentication. Again, this is one of the specific requirement in terms of data safety security. Every time you are logging in, an OTP will be sent to your email ID, and you have to enter the OTP. So I am entering my OTP, and then it will be logged in. So as Funny had mentioned, this is not a simple electronic data capture solution where like RedCap or like other data capture solution. The predominant purpose is just go there and capture the data. But this is much more comprehensive solution than this. As you can see, to create that kind of traceability of the entire process, we have created the entire governance framework here. So tomorrow when the committees meet and then they try to formulate the committees, the entire committee members' names, their roles and responsibilities, everything will be captured. So every governance committee meeting minutes will be captured within the system. It has got a speech-to-text functionality where all the conversations, minutes of the meeting, everything will be captured live. So everything would be extremely transparent, documented, amenable for a data audit trial in the future if somebody wants to go through the entire process. So the entire documentation, for example, all the initial versions of the documents which I have shown here, they are also hosted within the system. So all the versioning also is done fairly within the system itself. So again, we have a sort of immutable proof of the process. So now coming to this registry, the trial version, we have created, so there will be a data entry option. So you need to click in, and then the entire data collection workflow will be visible to you. We have added some, synthetic data just to sort of, demonstrate how the system looks like. So, for example, any center. So, for example, let us say I'm starting with, let us say, Yashoda Hospital, high-tech city. So there is a certain center code is already given, their state, their site PA name, everything has been already provided here. The details are already there in the system. So now whenever a new participant is walking in to the sort of the corresponding center, they can start entering the data. So center codes are already generated. For example, let us say 9003 is the center code. So any center level MRN, you can put in here. For example, I am saying, okay, 6789 is my center level MRN. And you can start with the date of enrollment. So for example, let us say we are enrolling a participant today. Again, this is sort of, a retrospective and prospective cohort. Anybody who is already there, a diagnosed NHBI case within our hospital records, we'll be documenting them as retrospective record. Or if it is a new patient which is walking in, we are going to document it as a prospective cohort. Then informed consent obtained or not, assent and consent obtained or not. Then date of consent, let us say date of enrollment and date of consent are same. Signed consent form filed and uploaded into the system. So we are going to give a provision to upload all the assent and consent forms here itself. And then this is the eligibility criteria, the definition which Dr. Naveen was mentioning about. So documented neonatal hypoglycemia, yes. And then compatible clinical syndrome of NHBI, compatible neuroimaging is yes, and definitive knowledge about blood sugar levels, yes. And then alternative cause is ruled out and meet the NHBI case definition. Then automatically the system will take it as a confirmed case of NHBI, right? If we go back and change some of those criteria, it automatically switches to either probable or possible case definition. Again, the group can discuss over these definitions and then they can arrive at a final conclusion. So this is where the patient is enrolled. Like that, the journey continues. Then you can put in participant identifiers. Again, to reconcile, for example, the scenario which one of the colleague had mentioned. So then a participant UID is generated, tagging the center UID with the MRN number, and then you can go on and you can fill in the identifier details. So I would like to, rather than going through the entire process, I would like to demonstrate, some of the important functionalities. For example, one of the question can be, yes, we are collecting participant identifiers. Are we not compromising the confidentiality? So there are three level data access controls which are available within the system. For example, any sort of collaborator which is invited to the for example, DRMMR is my name, so I am invited as a collaborator. At the project level, as you can see, I am forbidden from doing anything in the system. So I can go and I can allow only data entry part to that particular collaborating center. Collaborating center cannot touch the data entered by other centers, cannot see the data entered by other centers. You can see only your data and you can work with only your data. So each center's data is completely protected from even viewing by other people. Second, even within the system, for example, tomorrow you have multiple users within your system itself, but you want to again keep the personal data very confidential. Again, when you go to the data collection system, when you go to this personal identifier details, so there within the form itself, again, you can invite multiple people from within your institution also to be part of it. You can define the roles and they can perform their roles. For example, data entry operator can enter the data. And then you can again forbid them from seeing this particular form, right? So any of the collaborator, I'll say that, okay, this particular personal identifier form cannot be seen by them. Even variable level, we have a access control like that. So it's a very unique 3-level, access control system, again, protecting your data which is coming into the system. So another important mechanism is the data encryption. For example, you might ask, can CoGuide team have an access to our data? No, we cannot access your data. Only if you are inviting us as a collaborator, for example, as an evidence partner, we have signed a legal agreement and we are entitled to work on certain aspects of the project. So if you are inviting as a collaborator to create forms or to do some modifications in the forms, only to the extent which the center is allowing us to do, we can do, nothing beyond that. So entire data, the moment you are entering, it is encrypted. In transit, when it is going into the servers, it is traveling in an encrypted language. And even at rest, when it is saved in the backend database, it is encrypted. So the 2-level encryption, in transit, at rest encryption is also in place to, again, as per the both global and national data safety security rules. So you can enter the data like this continuously. Every form is tagged by the unique ID which you have created. And the beauty of the application is, though the data collection is spread across multiple forms, you can collate the whole data into one single Excel sheet. It comes in a single row. The entire data of that particular patient, how many ever visits you are collecting, it comes into a single row. And you can create this kind of cumulative data and then you can work on it. So as you can see, this is a complete cumulative Excel sheet. You can again, like Dr. Murki had mentioned, you can download this data. Your center's data will always be accessible to you. Whatever you would like to do with your data, it is, each center will have that, leeway to work with the data. Second important thing is, again, tomorrow, for example, let us say we are having a subset of, studies where, for example, we are having a neuroimaging subset or neurodevelopmental outcome subset. When we are creating those forms, let us say neurodevelopmental outcomes, for example, here we have created VSMS and other scales. And tomorrow only some of the subcenters have that particular data. I can collate, for example, I can take, enrollment form, and I can go to this particular form, and I can create cumulative just based on these two centers alone. Then I can give it a name as neuroimaging substudy, and I can collate data of only those particular subcenters. So in a way, the master registry will have the overall data of all the centers and also have specific data from different substudies as different data sets, nicely organized, analysis ready, almost real time available to the registry team. And the application has got more than that. You have data analysis functionality which is inbuilt into the system. Completely configurable analysis system as compared to the fixed dashboards. So you can go and you can perform descriptive analysis of your data. You can configure, you can create the analysis. All the variables are at your disposal. You can perform your descriptive analysis, inferential analysis within the system itself. So again, many sort of registries suffer from producing outputs very effectively, right? Data goes and sits into the system. Digging out the data, analysis and other things at times, is not done very efficiently. Having these kind of real-time analysis systems in place. For example, I have set up an inferential analysis. I'll just show you. So for example, we have set up, just to compare various factors between people with drug refractory epilepsy and no DRE. And as you can see, system can perform statistical analysis, everything real time. Since the small number of events, the analysis is not very robust, but again, this is real time. Once I am setting up this dashboard, as you are entering more data, all you need to click one merge button. The new data gets uploaded, and then you can sort of, almost real time analysis is also updated. More importantly, I think Dr. Naveen had suggested one important measure where you can have OCR kind of functionality. We call it as optical character reading functionality, where if your CRF is prepared in a structured manner, for example, we have prepared a CRF. Imagine this is a CRF which is prepared in a structured manner, and you are collecting all the data just by ticking in a high volume center. And you are passing on this particular sheet in a scanned copy of this particular sheet to a data sort of central registry, right, which is available. The data governance team which are sitting at the center, you can directly upload the data into the system. So I have a functionality, for example, there is a project level OCR functionality which is called optical character reading functionality. You can click this, you can browse the file, so you can select a concerned form. Of course, you need to follow certain naming conventions and other things to label these sheets properly. So then I can say, okay, these are my target forms. I can say, okay, I need to extract demographic data. I can select all the forms. And then all I need to do is page mapping. This can be done by the trained teams. For example, I'm putting in this page 4 to 5. And I'm mentioning it is a handwritten blurry data. So the system recognizes that kind of data, and then I click save. So it automatically extracts the data and push it into that particular form. Right, so this kind of functionality again will help the centers to sort of now I can see my demographics data goes up by another. The corresponding data would have been added into my this one, right? This is the data which has been. So also tomorrow when we want to expand the registry scope, again. It is very easy. Again, like we have discussed, registry is a live structure. It is a dynamic structure. Today we are finalizing one minimum set of variables. Tomorrow we want to expand the scope. All we need to do is go to create and create any number of add-on forms into the registry, and then you can add on to the existing core registry. And also, for example, schooling related data, you want to collect it directly from the parents through a survey form. The same form can also be converted just by a single functionality into a survey form. You can copy it as a survey link. You can send it across to the parents. You can directly email to their database from within the system itself. So it decentralizes the data collection burden, right? Many of the follow-up data, right, which parents can fill in their from their homes, you can send it across through email or through WhatsApp communication also. And more importantly, it has got a multilinguistic capability. Tomorrow, for example, if we are conducting a study in, let us say, Telugu-speaking states, and we want to prepare a form in Telugu, or some structured assessment tool is there in local language, we can also build in that thing into this and then collect the data and transfer it back to our English language backend database, right? So this is a sort of glimpse of the capabilities of the solution, how it looks like. I would be very happy to take any questions. Otherwise, I welcome all of you to just try it out and please provide insights, feedback. Most welcome. Yes, doctor, please.
It happens sometimes that the same patient will go to 3 pediatric neurologists. So how will you confirm?
Yes, doctor. That is, we have provided 2 solutions. One is the process level solution, where at the time of enrollment, for example, if the patient is coming to your clinic first, you will be having some sticker or some labeling sort of thing. The convention every center will follow, which is part of NHBA registry. And other center, which when they are planning to recruit that particular patient, because they are also trained in that particular process, they know that this patient is already registered somewhere.
Giving some code to
yeah, for every center we'll be giving some code, and that will be pasted onto the form.
Yeah, and confirmation of your the case of NHBI has got very few points, so there are points have not been added as visual acuity.
I think that this is only a trial version, like Dr. Naveen said. It is still fluid.
Want more details to find out. Yeah.
So
we need more. Yeah.
Yeah.
Microcephaly and all those. Yeah. Yeah. Yeah.
So once the protocol operational definitions are finalized, we'll add them.
Can we have the detailed entries of, like suppose if I want to do the radiological study of NHBA, so can we design that in a way like epilepsy format, everything? Yeah.
On the scores, MRI scores in hypoglycemic brain injury, the same form we are going to use it. And as Naveen said, if you have a DICOM, we can have all the information. Yeah. If you don't have DICOM, you have limited information as a diagnostic marker.
What will happen if the just MRI says NHBA or bilateral pyogliosis?
Yeah, so
what will happen to that case?
So that will form the larger data. As I said, if you want to look at more granular things, then you need to have a subset of the larger data in which you have the DICOM image and, as you said, 40 points. All that will be added is, can you show us that dashboard at the corner, Dr. Murli? Dashboard at the corner. So there are various headings, schooling, cognitive. Only one more heading would MRI sub-study.
Yes. Okay.
So that will be open to only centers who have that data. You click on that and you upload the DICOM and you have a different form to fill up.
Some patient with DICOM data, some without DICOM data.
So you can enter in that.
And again, like for epilepsy, we don't have uniformity. Like some will write seizure disorder.
Yeah.
So then what will happen?
So there'll be some basic data which will be required. So the center has to enter that basic data, because we can't have just epilepsy, yes or no. We need to have at least center competent enough to tell focal seizure, generalized seizure, seizure
Can
frequency,
we incorporate
drugs.
like standard ILE?
Yes. That is.
Yeah.
That is.
Yes, sir. Classification is ILA classification is included in epilepsy form.
Modification of 2017 version has been.
In fact, drug refractory epilepsy is the primary outcome, proposed primary outcome, and looking at factors which cause drug refractory epilepsy in these patients.
So all these things we can see.
Yeah, so the seizure type is included, and then an entire ASM details, everything is included. The DRE status, everything.
Have a documented hypoglycemia, but along with that, they also written down he has got sepsis. So that would fall into the probable thing, or it will be in a confirmatory thing.
Yeah, if you have a diagnosed hypoglycemia and you have bilateral perioccipital gliosis, So
Yeah,
yeah,
it's there, but along with that, they also wrote that hypoglycemia and probable sepsis, because most of the hospital give up
yeah,
this
that
data
that
as
diagnosis will be there, but your brain injury is likely related to hypoglycemic brain injury rather than the neonatal sepsis, based on the hypoglycemia and the perioccipital gliosis.
So see, that is one of the drawbacks, because if you have that sepsis associated, say, hypotension, and that has contributed to the injury, it's no way to tell. There is no way to tell. Yeah. That can only be answered by animal studies. Because definitely the hypotension is contributing, because one of the mechanisms for hypoglycemic brain injury is lack of autoregulation in the posterior cortex. So the hypotensive patient will have even more of those insults.
So they will fall in the category of probable.
Probable or possible. So then
So the number of the
what
data,
is done
you
is
know that the exact number will really fall down, because most of this is like they have this hash hypoglycemia, along with that you have sepsis.
So
Sepsis is
yeah, so one could deal with it statistically also. You could do a sensitivity analysis. You could check your 3 cohorts separately, see if the numbers are varying too much or not. Is the definite too much different from possible and probable? Then you know that probably your data collection or the criteria were not so robust.
Maybe Tejo can answer a little better.
This will be the issue in any of the prospective cohorts when we did it also previously. Even for the simple jaundice cohort, and then we had one hypoglycemia cohort also, which almost 100 patients when we followed it up, even late preterm and term also. This is the problem. But what we can do is that we need to again capture maximum data as much as possible with the comorbidities, and then see the clean hypoglycemia, how much it is there, and then with sepsis, whether it is influencing the outcome or not, that we need to look at it. That's the way we can try to look at it. As you said that it is possible or probable, again, we are backhand, we are trying to capture the data, it should not be a problem. Other thing we can try to look at is that if you are really looking at the hypotension, you can add whether the child had required any inotropes if the data is available, that's all.
So again, one of the thing is that the important thing is that when you have this kind of data, you document everything. If you're uncertain, you document. If you're less certain, you document. If you are very certain, you document. So the documentation is what is differentiates this from otherwise small quantity or not so robust study. Yes.
Going to be a comment box for uncertain things as well?
Comment box for yes, there's always there will be free remarks.
Yeah.
Yeah, so you could always enter free remarks. Those statisticians really frown about free remarks, but they will be option to have free remarks because we have AI to read the free remarks now. Because people will use different terminologies, you know.
Most of the same.
And there is a documentation where we had a seizure or where we had a hypoglycemia. He was admitted to some small NICU, given antibiotics for 5 days. A return at sepsis. So not able to verify whether it was a simple hypoglycemia or what.
Yeah. See, we have to ultimately accept that this is going to be pragmatic data. We are not looking at the science of what brain injury is caused by a pure hypoglycemia. We are looking at hypoglycemia plus what happens naturally when babies are being reared for in a resource limited setting. So there is going to be combination of insults.
Yeah, I think MRI is going to be mandatory in all of them, 1.5 Tesla. That is one of the gold standard. We probably are going to use it along with history of hypoglycemia. But many of the times, as already said, Veena Kalra madam also said the same thing in the morning. There is no documentation. The child has gone to phototherapy. They come back after 3 months. They have a seizure. And when you do MRI, there is perioccipital gliosis. So you'll have to take that as one of the important marker for us if there are no other alternative explanation for that.
Yeah, probable. Yeah.
Plan to tease out that a baby had hypoglycemia. Subsequent damage, we are seeing him years later. We don't know how much of the subsequent damage is secondary to the seizures he encountered or the epileptic spasms he encountered in those years. And was it all contributed by the hypoglycemia at birth, or were there factors that happened? Do we build in something to that effect in this study?
And that can be tested retrospectively by looking at those kind of patients who had a lot of seizures. Do their imaging changes really show something specific? So it can be handled statistically.
Thank you.
In majority of these prospective studies, especially 1 to 1 point, when you are looking at it, what we usually keep the data is that how many times the child required an admission. Suppose how many were ICU admissions, how many were the ward admissions. So at least that will give a little surrogate marker how sick the baby was in between from the onset to at the outcome assessment. So if those were more, we do not know whether it is an exact hypoglycemia or a subsequent some diarrhea or some sepsis might have aggravated.
Yeah, so I mean, there will be patients who will be very sick, cerebral palsy. They'll be admitted, 5-10 times, and you are not sure whether they had additional hypoxic insult later on. So they will be, finally in the some of the exclusion criteria. So somebody develops a head trauma after a neonatal hypoglycemic brain injury, we are not going to include those patients. It will be forming the part of exclusion criteria, that they should not have any other documented additional possible or probable brain insult.
Just one comment that maybe over a period we can sensitize the hospitals, we can send a message mentioning that such and such registry has been started, so that they'll be little more vigilant when they're writing the discharge summaries, and when the patient is coming to us, we'll get little more idea about hypoglycemia, and that can be very much possible in private setups. So as you correctly said, the discussion can go on long and long. There won't be an end point. We'll start something. Maybe over a period we can
it will be in a dynamic
formulate.
phase. Yeah, we will keep modulating that, but the entry criteria will be clear.
We have to start somewhere.
Is there going to be a
Hypoglycemia is measured with a prick.
Yeah.
And a lot of times patients have said that the baby had low sugar, but you don't find it anywhere on the discharge slip. So there is, on the part of the hospital, it's been a kind of a hiding event, and yet you know very clearly that something happened. So I think that's another thing that's going to be a red herring in the study.
Ma'am, so that will be captured in the probable hypoglycemia, in which parents either know that there was low sugar, or there is documented written hypoglycemia value not written. But we have a compatible imaging and compatible clinical.
Maybe day 3 seizures would be one of the important landmark for us. Day 3 seizures as a.
is there a imaging exclusion criteria?
Malformations, those kind of things which can be additionally epileptogenic.
Significant frontally dominant cystic changes, gliosis, those kind of things where it is BAND or HIE. So those kind of things probably will exclude.
So the third criteria is reasonable exclusion of alternative diagnosis. It will be in that.
Like parieto-occipital extent of the gliosis or something.
Yeah.
Like.
So the extent of gliosis can be very varying, right? From you can get, those with cystic changes, and with as I said, plic involvement, thalamic involvement, and those who have only little bit of unilateral mild gliosis. You must have seen all the spectrum. So they can be, and plus normal imaging can also be there.
That will exclude everything, right?
Yeah. So we're planning to exclude those who have a additional cause or probable cause as determined by you as cause of epilepsy. So as I said, head trauma, somebody has a small focal cortical dysplasia, along with, so dual insults or dual pathology will exclude. Yeah, so it's not a registry in the true sense. Yeah.
But if it's a registry for NHBI, then it's a different affair, because then you don't exclude patients. For example, if this was with HIE, and you don't exclude it, because we can have a subset of research question and data coming out of that. For example, what happens when you have both HIE and hypoxic ischemic injury and NHBI? What happens to that subset of patients? So I think fundamentally you need to define whether this is a registry for NHBI and then you have subsequent research questions, or whether this is a specific research question which you are addressing.
Thank you. I think there will be endless, this one will go on. We'll have this discussion going on. Two minor changes. The installation of new IOCN office bearers will be done tomorrow around 10 o'clock, along with the official launch of registry. So that is one change. And because we are already running quite late, so we can actually start the expert working group registry parallelly now, and then the roundtable discussion also will go on in this hall parallelly. So those who are involved in the expert working groups can go to their tables arranged in the right hand side of the hall. So you can go there and start the expert working group discussions, and the rest of them will remain here for the roundtable discussion led by Dr. Ramesh Konanke and Vineet Vankade. Thank you.
For the roundtable, I would like to invite Dr. Ramesh Konanke sir, Dr. Vineet Vankade sir, and Dr. Murali sir to chair the session. And among the panel, we have Dr. Deepa Bhaskaran ma'am, who is a developmental pediatrician. We have Dr. G. Vijay Kumar, who is a superintendent Nilofer Hospital. We have Dr. Tejo Pratap Oleti sir, who is our neonatologist. And we also have a parent, Mrs. Bharati, along with Mohan Rao, who is the senior advocate in Supreme Court. So kindly come on the dais.
That's okay. Nothing much on the screen. Anyway. No, that's okay. There's nothing much on the screen. Good evening, everyone. So, this is a short kind of panel discussion of important stakeholders in the continuum of care for children with hypoglycemic brain injury. So starting from fetal life, then neonatal period, childhood, neurology, developmental pediatric, and into adolescence. So we have this eminent panel, so which have already been introduced. So we know that NHBI is one reason why all of us have gathered here. I think there's no single day passes without seeing a case of hypoglycemic brain injury. So it can be called as a pervasive neonatal childhood disorder. So because it has impact on so many aspects of child development. So these are all the complications or consequences of NHBI. I'll not go into that, but very important perspective is the family, what family goes through. So always it is good to anticipate in which babies hypoglycemia can happen, act on it and prevent certain complications. So although there are a lot of guidelines on management of hypoglycemia are there, there are some ICMR guidelines are there and various neonatal federation guidelines are there. but lot of it fails in implementation. So the main agenda of this meeting is to see are we doing enough for these children, and what are the actionable points that we can take away which can change our practice, help to change the policy, or the way we manage these cases, or even generate questions for possible research. That is the whole point of this panel discussion today. So aim is to develop a better comprehensive care, both the preventive as well as treatment aspect for children with NHBI, and obviously improving the quality of life. So objective is to identify the evidence gaps and research priorities in this particular field. So these are the different care points across the lifespan, starting from antenatal to adolescent, young adult, and then later. So as family is going to be the center of all that we wanted to do, so we'll start with the parent perspective. So we have parent here, Bharti Garu. So what are the challenges you face as a parent in your child's management? One is the medical aspect, like medical care for your child, and the social aspects.
See, earlier, when he was detected about this hypoxia and hypoglycemia, I was not aware, because I was not even known like what exactly happened at the time of the birth. Later, third day, I realized he was not reacting after vaccination also. Then I thought something went wrong. Then we shifted to some other hospital. Then the milestones started. They were delaying the milestones. Then we went to Kalavati Saran Hospital, which is in Delhi. So medically, what I feel like, I did not find the rehabilitation center. There was a honest communication gap was missing from doctor to the mother. And the second thing is, there should be, one clinic, NHBI should be there, where the patient, the mother and the patient should get the opportunity of, rehabilitation, speech therapist, and the employment, because my son is now 20 years old. So I feel like now, inclusive education is also very important. He's missing that also. And apart from that, the social life. See, he is visually impaired, and apart from that, there is a speech disability is there, and there is no friends for him. Nobody wants to play with him actually. And as a mother, I always fight for him for his rights everywhere, even to open a bank account also. And now he has got friends. He's an all-rounder. He plays cricket, and he's a determined son. My son is very clever. With the help of Dr. Lokesh Garu, he has achieved many milestones. So I'm so happy as a mother. My son, lot of improvement is there, even though if you keep the education apart, but there, I request the NHBI to build a shelter for not only the family like me, which has been affected, but other families who children, definitely has gone through all these things,
Right. So, thank you. So, if I have to just summarize what you said, in terms of medical challenges that you faced, one is in the initial management during the newborn period, and then subsequently the availability of rehabilitation facilities.
Correct.
Is that right?
Yeah.
So that
agreed.
has been one challenge.
Yeah.
Okay. Then socially, I think the need to increase the awareness in maybe schools,
Correct.
and society at large about children with NHBA or even other neurological disabilities.
Correct.
Is that
Right,
correct?
doctor. Yeah.
Okay. Thank you. So the other question is, do you think most of the parents are aware of why we need to monitor blood sugar in the newborn babies? And will it help that if
Awareness,
more parents are aware about it?
No. Awareness is not there at all. Even speaking for myself, when this actually happened about 20 years ago, when this has happened, actually what has happened is that he was born about 28 days premature, and I was informed about his premature delivery, and I took about 48 hours to reach Hyderabad. Incidentally, the moment I reached the Hyderabad and I went to the hospital, I was told the boy was crying like anything for almost 45 hours. He said just before I reached, he stopped crying. They said, oh, he was so happy, father has come and all that. Yes. And then at midnight, Bharati called me to say, you see, just an hour before you came, he stopped crying, and there is absolutely no response from him. So I told her it was about 1:30 midnight. I said that you are in a hospital. Why are you calling me? Call the doctor. In any case, I am coming. So I went to the hospital. By the time I went there, the doctor has already come, seen, and said, oh, he's sleeping very peacefully, such a nice boy, and left. The next day morning around 9 o'clock, the pediatrician came, looked at him, and gone back. Then the nurse came and gave him a vaccination or something on the third day, whatever vaccination has to be given. He did not respond. At that time, suddenly there was panic, and the pediatrician by that time left this hospital and gone to some other hospital. He was called back. He came and they said, rush him to a children's hospital. So he was rushed to the children's hospital. That was on 18th of September in 2022. And he was in the hospital for about, I think he was discharged on 23rd or 24th of September. So at that time also when he was being discharged, we were given a prescription and said that had he been under my care, I would not have told you these things. But now that you are taking him to a different place, show this to the doctor or pediatrician who is going to take care of him. So we went, and in Delhi we have taken him to our pediatrician. And he said that, okay, you come every week so that I can follow the development. Then after third week or fourth week, he said he was not opening the fists. Then he suggested that we should go to Dr. Kalavati Saran Hospital. We took him there, and I had some connections and all that. We went straight to the director of this thing. He looked at him and said that, you know, it's very difficult. You people are going to have a difficult time for the rest of your life. And very frankly, because, you know, he was a friend's uncle or something.
So do you think if the parents are aware that, okay, these things should be looked for, if they're more aware, more like public is aware, it will change anything?
You see, at that time I was so disturbed. I bought that textbook on gynecology and started reading it. Then I realized that there is a chapter in which it is said that, you know, if the trauma that baby suffered at that time, you have to take these things, and if these conditions are there, immediately you should put the baby on oxygen, at least minimum. That is what I think, that I read, whatever I understood. Maybe I'm right or I'm wrong. But what has happened is nothing has been done for 48 hours, more than 48 hours. So I think that, I mean, I don't have, as a layman, I don't have any knowledge about it. Hypoxia is something that I came to know much later. Hypoxia is something I came to know much later. But what about the caregivers?
Right.
I think even awareness among them is not much.
Right.
So
I think parents definitely, probably if they are aware, probably maybe at least forcing the healthcare team to check sugars. But definitely, as you said, I think healthcare system need to be much more sensitive and be aware of these things, definitely.
I think
so we
will
come to that.
The gynecologists and obstetricians should have a deeper knowledge about this. I mean, parents certainly they don't have.
Yes.
And even if they have, they should not interfere with the professionals.
Yes.
Who are there to tell anything to anybody? It is the professional discretion they have to take.
True.
So a patient having a knowledge is absolutely immaterial.
Correct.
But they should have the knowledge and they should take care of it.
Absolutely agreed. So coming to that, so a lot of times there is a skepticism or criticism that do we need to prick the baby so many times to is it so essential? So, but I think it's most of us understand, those who are in neurology practice, that what it can cause if the neonatal hypoglycemia is missed. So that momentary hesitation to do sugar can cause a lifelong disability to a child.
You have to prick 30 times, you have to do it.
Yes.
But otherwise he will be suffering for the rest of the life.
Yes, absolutely. So I think that hesitation has to go away.
Yes.
So if in doubt, just check sugar. There's nothing wrong in one prick at least. So do we have obstetrician online? Dr. Sushila is there. So maybe we'll come back to this once. Okay, Dr. Sushila, can you hear us?
Evening all. Yes, sir. I am able to hear.
Okay, okay. Thank you. So, how much is the awareness of hypoglycemia in the newborns among obstetricians? is this perceived as important by most obstetricians? What do you think?
Thank you for the question. Yes, sir, it is, obstetricians are aware of hypo. Sometimes what is being missed is the monitoring of blood sugars in the small for gestational age or growth restricted babies.
Okay, so just one thought, like tertiary care center, it is understandable where the obstetrician will get in touch with the pediatrician, they will attend the delivery, then they will take over. But there are a lot of centers where there are no pediatrician available to attend delivery. So in such cases, antenatally, is there an effort to risk stratify these mothers where okay, there are certain risk factors already, baby may be at risk for low sugar, so we need to monitor or we need to communicate this to the next person in the care chain. So is there any attempt to do that?
Absolutely, yes. Because what happens most of the times is, as you correctly said, not all births are attended by the pediatrician bar neonatologist. Not many obstetricians have the luxury who are working in their periphery. So these are the women, if mother has any risk factors, like as I have said, either gestational diabetes or diabetes complicating pregnancy, or if the growth restriction is identified, then that birth will be attended by the pediatrician bar neonatologist. But these kind of neonatal challenges can occur even in otherwise supposedly low risk women. So I'm afraid, that is the sector which may be missed in those cases.
Correct, ma'am. So my question is specifically where there is no neonatologist or pediatrician attending delivery, do you think there is enough sensitization among the obstetricians that this is a very important thing to monitor, or at least to tell the family that okay, this is what is needed. If there is no facility, please go there and get admitted and get monitoring. Do you think that awareness is there?
I don't think that awareness is there, because as we have discussed, if it is a high risk pregnancy, definitely the birth is attended by one of the professionals, neonatal bar pediatrician. Whereas if it is a low risk, I don't think people are sensitized to have every baby to be identified or checked by the neonatologist bar pediatrician soon after the birth. Maybe they would do within 24 hours, but not immediately.
Right. So we have Dr. Vijay Kumar, who is a pediatrician by training, but he has vast experience in first-hand experience of government health setup, starting from primary health centers, SNCUs, and medical colleges. So can you, would you like to throw some light on this? How much is the obstetricians in that sector, government sector, or remote places? Do you think they are aware?
Yes, sir. I thought it was a very, very absorbing discussion before this panel discussion, sir. In public sector, why pediatrician? When a baby is there, there is setting, there are SNCUs are everywhere. And 5-7 years back, the NSSK trainings and FBNC trainings were in peak. Now these trainings have come down a little. When a baby is born with mother in postnatal ward or in SNCU, in a neonatal care setting, there is a staff nurse, there is a birth attendant who can identify when the baby is dull. And we need not wait for a pediatrician. There is a birth attendant, and there are definitions of who is a birth attendant. Okay. And hours that later, these people can attend. A staff nurse in SNCU is still good to identify a baby who has can have problem, and to identify hypoglycemia.
So do they identify hypoglycemia once it happens, or do they have knowledge of whom to monitor?
Sir, I say few places, Srikakulam, Vijayanagaram, and down Chittoor, Adilabad district, when these initial trainings that have happened in of NSSK, and again I say these two.
Some places,
yes, there are good number of these young girls, staff nurses, and even ANMs. They identify, sir. They identify. They know when to prick, and they are very key persons. And sir, I cannot say that, but if there is a sampling and then you can go down to an SNCU for your sample. I thought that would be a very, very raw data that would give a lot of information.
So, as
Can
Dr.
I
Vijay
can I ask a question, sir?
Yes, please.
Well, the entity I wish to ask was that, is it a checklist? Is it a part of the checklist to check the glucose level, blood sugar levels of the neonate?
It is for certain high risk babies, ma'am. So there is a very standard guidelines now, including ICMR guidelines, which say these are the newborns at risk for hypoglycemia, and they need to be monitored. And how long to monitor, how frequently monitor, there are standard set of guidelines in place already. Only challenge that I think lot of us perceive is, there is nobody to take that responsibility to say, okay, this baby is at risk, we need to monitor this baby. So the one is the obstetrician, obviously. So to be aware that, okay, this is at risk, let it be hand over to somebody, pediatric or neonatologist. So I think that's a huge gap.
Yeah, because certainly I think so. Because high risk women, we are all motivated that, high risk women with monitoring may become low risk. Yes. But the thing is that sometimes these kind of emergencies may happen in the low risk women as well. So, yes. Is there what is the routine checklist? Is maybe if we have to put some strategy or whatever, yes. The checklist should include apart from Apgar score or whatever, sometime later the hypoglycemia episode also. Thank you.
So as a group of neurologists who know the burden of it, so what is it that we can do? Any suggestions so that more obstetricians are aware to identify antenatally and then at least pick up those cases early? Maybe quick 2-3 solutions. Or
neonatal hypoglycemia, right? That's the one thing. So when we are in a system where 80% of the deliveries occur in a government center, that too in sub-centers or primary health centers, right? The first thing which can sustain this is NHM, National Health Mission, captures every data. So we were talking about the neonatal initiative, there's a registry. NHM captures every data antenatally, natally, and postnatally. And NHM mandates it that in India, almost every antenatal data and the neonatal data should be entered into the system, right? So we need to actually tap that data because that's a very dynamic and alive data. So you can get everything which is enrolled antenatally into that system. So you can pick up high risk people. You can, when the delivery is actually, when the patient is in the labor room, you already have, they are screened because the data is already captured for high risk data, right? This can happen, this can percolate into the private system as well. So, and government mandates it actually, but I don't know why is it not being followed. The second thing is, in a team, as sir had very rightly said, it is the nursing, and unfortunately in this country, I don't see any continuing medical education for the nurses. We are not focusing because this is where things have to be improved. So I believe AOCN can play a big role in number one, especially in the neonatal neurology part, the neurological morbidity, is through NHM, collaborate with them, and you'll have all data, everything is captured in there, number one. Number two, nursing, we need to actually have them into a kind of program where they can be trained. That's one suggestion.
Checklist. So I think it is more about educating and yes, sir.
1 point. Today is the World Breastfeeding Day inaugural, and many places have done that.
Okay.
Right. High risk babies are already there, but the breastfeeding practices, again, it is through the nurses and the staff. Much we take that we are neonatology pediatricians, okay. And these practices, if they come, I thought that spectrum of high risk neonates, they need anyhow special care. Okay. But these which are what the parents here said, probably if these improve, I think that will make a difference, sir. That should be quantitated, and that's thank you.
Yes.
The question which was asked online, I mean, for low risk pregnancies, at least the obstetricians, when they are on rounds, they can ask whether the baby is feeding.
Yes.
You know, at least every 2 to 3 hours. If the baby has not fed for 4 hours, is the baby lethargic? You know, simple questions. It can always make detection of hypoglycemia easier and intervention.
See, in case of Madhav, it's absolutely normal. You know, all the child.
No risk factors when he
no
was
risk
born.
factors, nothing.
So feeding.
And there was, I mean, not even by cesarean, there was a delay of nearly 1 hour during labor. And I think that is something, you know, there was some complication at that stage. So they should have taken, and I think basically it is not having enough knowledge or, you know, awareness.
So in this aspect, like in just prenatal identifying risk, is there any question of research which can help bridge this gap? Any just research question? Yes. Anas can pass on mic.
This stems out of the fact about what parents are feeling right now. I think they're feeling that maybe the child could have been taken care of better if somebody would have recognized. But I would like to put a point here. We are sitting here in an NHBI symposium and we are talking about this. But the neonate can have 100 other problems. An endocrinologist may feel why CAH should not be recognized. A pediatric surgeon may feel why congenital diaphragmatic hernia should not be recognized. A pediatric surgeon may also feel why imperforate anus got missed. So what happens is it's hard to give a checklist. I know that there is some common sense that has to be prevailed. Like Naveen sir said, if it's a baby who's not sucking well for a long time. But again, there's a lot of physiological stuff going on there. How do you recognize a baby who just sleeps physiologically longer and latches less, especially if it's a primary mother? So there are a lot of problems there. And coming to nurses, we don't have specialist nurses in every sector. They are not pediatric trained nurses, especially in CHCs and PHCs. It's hard. And then coming to obstetricians being oriented, they are having their own problems. They're worried about the mother's PPH. They're worried about other problems of the mother. So it's very hard. Just for the parents, please don't beat yourself up that something could have been done. Because I know that things should have been better. You're seeing the micromanaging of what we are talking here. So let's not blame anybody because it may have been in the best interest. In your case, because BCG vaccine was given and then child didn't cry, then you got alarmed. Otherwise, the child would still have continued to be like that maybe. But then everybody tries their best. Sometimes there are lapses, especially when pediatrician comes for a short rounds and goes. It's very hard to pick up a child who has been
I think
lethargic.
That's a valid point. Yeah. I think only concern is things that could be avoided should be avoided. That's the only point, I think.
Ma'am, so I'm not blaming anyone. I'm not saying anything. All that I said is that actually whatever has happened, and incidentally when this is what has happened, I'll just tell about 2 minutes. I have a friend whose father was earlier, he just about in February he passed away after 100 years. He was former principal of Armed Forces Medical College, Dr. J.C. Sindhi. When I told about Madhav these things, he said exactly the same thing my friend suffered. He said at that time they were posted in Jabalpur, and when they realized the baby suffered hypoxia, he said that he sat there the whole of night with an oxygen cylinder and cut the funnel, kerosene funnel, and then put, and it's ultimately it's the knowledge they have. That is what made the difference. Here, good, bad, indifferent. Simply, despite the baby showing some symptoms, I'm not blaming anybody. I have not done anything, but I'm saying this. I'm simply putting the facts.
Yeah, the main objective is to see how we can improve these things. That's what all of us are trying to see. Correct.
One comment. Recently, we did the study in NHBI with 125 patients with documented and non-documented hypoglycemia, and what we found was the term babies were more affected. And probably they are getting ignored because they are term and healthy babies, and probably that could be a research question where we can look into whether we are missing them.
Correct. I think so. One is the prenatal identifying the risk factors who can go into hypoglycemia, but equally important is who are born absolutely well, but inadequate feeding or poor feeding techniques for some reason that they go into hypoglycemia. I think those are two large subsets of patients. So we'll move on to the neonatal part. Yes, ma'am. Correct.
That practice itself needs to be reviewed.
Yes.
Because if a child is not feeding, he needs energy.
Correct. Correct.
Whatever be the source.
Yes,
Whether it's the mother's milk or it's drop or whatever. But I think a very purist attitude is also a bit detrimental. Murky.
True, ma'am. I think it is same as pulse polio vaccination, where so much emphasis was given on polio vaccination, and other vaccines were left out for a certain period of time. I think all of us agree with that. So coming to neonatal.
If you allow me just, ma'am, the classical teaching has been the baby once born within it is not in minutes, as early as possible. The sac, which is the sac, is the strongest stimulus, and then baby goes into that 18 hours of somnolence, and that is causing all the problems, and not really sticking to breastfeeding. I thought the problem is the period, the first half an hour, or I cannot say that half an hour,
Initiating.
the first few minutes initiation of breastfeeding, that has to improve somehow. It is through either neonatologist, pediatrician, or a staff nurse, or even a person below that, or a family and community. That has to come.
I think only thing.
G, ma'am.
Only thing ma'am was trying to highlight is, with so much emphasis on exclusive breastfeeding, some babies may be suffering more. Just so some liberal use of formula feeds or some fortifiers should be considered.
We cannot use the word liberal, but optimal use, that will be better.
Judicious.
That
Judicious
when we are
use.
sitting on a World Breastfeeding Week day celebrations or anything.
Judicious use. Yeah. So, question to Dr. Tejo Prathan, neonatologist: are blood sugar monitoring protocols followed across different levels of healthcare? We know tertiary care center, most of you followed,
Again, the same problem, Ramesh, what sir told. So we have the guidelines. FBNC also has given the clear-cut guidelines on how to monitor a at-risk neonate for the first 48 to 72 hours, and then you have to do it. But the compliance is the major issue, and then those timelines, whether the people are following it or not. So this could be.
So what are the challenges? Yes. Why do you think these are not being followed or implemented?
So I'm not saying that completely not followed, but many of them are following it up. But again, there are challenges in the implementation. So when we look at the challenges, first is that whether we are classifying the at-risk neonate at the time of birth or not properly, that we need to look at it. So whenever the birth weight is measured, at least status of SGA and LGA, we have to document it immediately. So that will, first of all, will make the people alert. Second thing is that low birth weight, we all clearly know, late preterm, and only problem that can come is the borderline where the morphological AUGR or something like that. So that constituency, that composition might be a little lesser. Second thing comes is that perinatal aspects, whether the skin-to-skin contact, because these are all the things that can try to help the baby to regulate the sugars better.
Correct.
So third thing, what you are saying is the monitoring part when you are looking at it. So monitoring, again, cutoffs and the timelines which are there.
So
for
on
that,
paper, we have all those things beautifully written in the guidelines. So can you tell 1, 2, 3 challenges why this is not being followed in many centers?
so you have to see
Maybe
any implementation protocol. First is the knowledge. Knowledge might have been there, but sensitization periodically is not happening. That we need to look at it. Second one is that whether the equipment is functional or not, and whether it is calibrated properly or not. That's the second one. Third one obviously is the personnel available to handle that load. Basically, when you are having only 10 deliveries per day, that still is okay, where 2 babies will be at risk. But when you have 40 deliveries per day, how many are there in the postnatal and immediate postnatal wards? How many nurses are there? How many have the knowledge? How many glucometers you have?
So you are saying one is the problem with availability of infrastructure. Second is the motivation to do, correct? So which
More
means
than motivation, I think knowledge sensitization, that we need to look at it.
okay.
And third one is the personnel number, how
Okay.
many we have. Suppose that fellow has to do some 20 screenings in 6 hours. Is it feasible or not? That we need to look at it.
Right. So the other important question, many times we tend to think this when we see children with NHBI. For those babies who have already had hypoglycemia in the NICU, when they are discharging, is there any anticipatory guidance given to them? Okay, that you baby had this, so you may develop these things. Please look for these things and come back early. Is there any guidance
Yes,
provided?
I think for the symptomatic hypoglycemia, I can say that many of them are giving it, at least for the neurodevelopmental assessment.
Do we document it that
Yes.
okay, your baby had hypoglycemic injury, so please we have explained that this baby may develop vision problems, may develop epilepsy, spasms, delay.
At least vision screening and hearing screening, people are writing it.
That's
I'm
a
not
universal
saying,
screening.
Yeah, neurodevelopmental assessment and other things people are doing, but the amount of sensitization you want to make them, that I am not sure.
Why I am saying this is, lot of times parents know baby has suffered hypoglycemia, and unless something very obvious happens, they don't actually come back to for developmental surveillance or follow-up. So usually that happens when they have a seizures, or when there is no vision fixation, they come back. So if we can document it in the discharge summary that baby had hypoglycemia, please look for these things very explicitly. Do you think that will help? So that parents are aware, I need to look for these things.
So you want to say that for like what we give it for a simple premature baby,
Correct.
these are the things.
Yes.
For a symptomatic hypoglycemia, you need to do these things.
Correct. I'm
so
just thinking.
as of now, I think it's going as a generalized guidelines, but maybe a separate brochure and other things. If we can start implementing with this NHBA, then maybe it will be of help.
Because for something which can have a lifelong impact, so why don't we just mention it in the summary? Many times we find no mention of hypoglycemia in the discharge diagnosis itself.
Now that might be a little overkill.
No, not
but
at not in a tertiary center. This is there in the record somewhere we will see, but in the diagnosis it is missing. So what happens is, if there is nothing in the diagnosis, nobody knows what to follow.
Got it. At least.
Do neurologists agree? Okay.
Yeah, please.
No, I'm not saying they may develop. At least say, look for these things. Look for any
Monitor
delay in development, visual fixation. Give something, and say, okay, come back at 3 months of age for developmental assessment or surveillance. Something, so that I think I'm going to come at the end to legal professional.
Can I have a word
yeah.
here, please?
Correct. What red flag milestones?
It's a neurodevelopmental follow. The issue is whether anything specific strategy for NHBI has to be put in on the discharge cards or as a follow-up, because it is presumed that every baby will have a neurodevelopmental follow-up visit, and the immunization sessions are designed in such a way by NHM and Government of India and every stakeholder to actually screen for neurodevelopment and then
Correct.
send it for the detailed neurodevelopmental
Correct.
assessment.
Yeah.
So
May
I think
add, please?
that has to be strengthened. probably.
Pediatrician or a
Yeah.
gynecologist at the time when they are discharging the baby, I think they have to take a call depending on the parent's ability and their understanding. It is possible that some of the parents may not be able to understand anything, and some parents may be able to understand, and they may question that what. In my case, I did ask them, but I was not informed. And in other cases, parents may not ask. So doctors have to take a call. I mean,
So I think
unnecessarily
it is-
putting them on, you know.
I think
they may
at
feel
least
that
it is
just
good
now this
to-
doctor said,
Yeah.
it is difficult. You know, the children, they may take that it is, something bad has happened, they themselves may be responsible. They have to take a call.
I think maybe you can think about it. The neonatologists also maybe think about it, discuss probably. So how much to tell them? Sometimes telling so many things about complications may also make the parents very scared. So Dr. Deepa, you want to add something?
If I may add, to add to what has been said already, there are certain areas where we have to monitor the glucose of a child. Late preterms, term STAs, infant of diabetic mother, which should be done everywhere. And like somebody said, we don't have to tell, NNF has clearly put down guidelines where a child who has got hypoglycemia can come under the moderate risk category and the severe risk category. Prolonged hypoglycemia comes in the severe risk, moderate hypoglycemia comes in the moderate risk. So if you have a very strict screening protocol where you're not actually waiting for a delay to occur, if a child has a recorded hypoglycemia in the newborn period, the child is going to have a strict moderate risk follow-up. If the child has a prolonged hypoglycemia, he or she goes to the severe risk follow-up. So we are not actually telling the child that your child may have a developmental delay. You are not even going to give the child a chance to have a developmental delay. You're going to screen them right from the word go, and the earliest delay that you pick up, or even a tone abnormality that you pick up, you're going to intervene there itself. You're not even going to wait for a delay to occur. One thing. Second thing is that all these children with neonatal hypoglycemia, meningitis and all that are prone for cerebral visual impairment. So we have to, it is not just a routine checkup alone which is needed for them. Cerebral visual impairment needs expertise, and these are children who are prone for that. So we don't have to wait for them to have a poor fixation. Right from beginning itself, you can screen them. Very simple exercises are there which can be taught to the parents, which they can do at home. The baby may or may not develop cerebral visual impairment. We're not going to wait for that. These children are already at risk, so we start intervention right from the way they are discharged. Even when they are discharged, we have to give them the stimulation. We have to categorize them. Categorization is very important, especially in a center where we have, resource-limited centers. I work in a very resource-limited center. So the neonatologists there do a wonderful job. As soon as the child is discharged, the child is already, risk is already categorized for us. And a lot of counseling goes, as was said earlier. It is not like you give them a card and say, you come on such and such a date. No. Somebody has to sit with the mother, and that really goes on. And since it's a resource-limited setting, health education is given to a group of mothers. They all sit together in the SNCU outside when they are there. These students go over there and give group health education to the mothers, sensitizing them to the need for neurodevelopmental follow-up. Only then will they really come back to us. And our follow-up is actually quite good. They do come back. Even if they're really far off, they really do come back because a lot of talking goes on. They are sensitized at each visit that they have to come. So if we can do this, without waiting for a delay itself, if the risk is categorized and we do it in a systematic way, to a great extent, we can prevent a developmental delay from occurring.
Right. So there are so many levels where things can improve. So I think there are multiple players involved. So it is not for one specialty or one.
There is one MCP card, Mother and Child Protection Card. It's a 28-page one. It is everywhere available. And except that 3 pages of immunization, people, even pediatricians, do not see it.
So I think that's
I thought it from house surgeon, MCP card, I thought everyone should see today. All of us know in this room. And mothers can recognize, and they can actually pick up the delay. Not just by history. That typically PGs we teach the developmental history and the neck holding and all that. All that mother can do using that MCP card, sir. MC card must become more and more famous, more useful, sir.
Yes, sir. Thank you very much, sir. I
think
think
Ramesh, I just wanted to add is that when we are saying that at risk already antenatally diagnosed, so when the baby delivers, there will be a hurry to discharge by 24 hours. Okay. So if it is a 3 kilo baby, you have the risk factors, but nobody will listen to you when you are telling that, no, this fellow, okay, till 24 hours sugars are okay. But that can happen at 36 hours. That can happen at 48 hours. So we need to sensitize whole of the department, including the administrations, whether it's a government or a private, that these neonates should be inside the hospital for at least 48 to 72 hours. That will actually make things much better.
If they are at risk, more especially. Yeah. So the other thing that we see is pediatricians may be seeing these children for vaccinations, but it looks like many of them are not aware that, okay, even though there is a neonatal history, at least to do developmental surveillance for these babies, or for that matter any baby. So Vijay Kumar sir can probably answer. Do you think pediatricians are aware of this being an important cause of neurological problems? Pediatricians, because they have a lot of other things to look at. We know they're burdened with a lot of other problems.
Once mother says there is an issue, then typically we are taught the long case where the developmental history, that 4 spheres, we are onto that mode. That should somehow change, sir.
But during vaccination visits, do you think there is a developmental screening going on?
Not really.
Not really. So I think that is something which, whenever we interact with pediatricians, we need to emphasize that they are failing in their duty if they are not doing developmental screening at vaccination visits. I think at our own individual level, we should keep on emphasizing this. Not just for this, but in general, isn't it? Or is it too much to ask? Okay, last, I think we will not go into the pediatric neurological problems, because this whole conclave has been about neurological problems in NHBE. So just, I think maybe all of you can message which are the areas of research which can actually help us understand better or give better care. So I'm skipping this part and coming to the last point of the discussion, the legal imperative. Okay, whether you prick now or get yourself pricked later. So lot of medical legal disputes are going to come up in future. I'm sure, Mohan Rao Garu is a Delhi Supreme Court advocate. You are practicing in Delhi Supreme Court and is also a parent. So what is the implication future? Do you think these litigations are going to go up?
Unfortunately, yes. First of all, despite the Supreme Court repeatedly trying to say that, provide guidelines under which actually, doctors are not gods and there is a limitation. You cannot attribute every, something happens that doctor is responsible and negligent. But most of the time that what is happening is genuine cases are not actually coming to the courts. Whatever are coming are actually not genuine, have people having, who can come and having a, unwarranted grievance. They are the people who are coming to the courts actually, and unfortunately, sometimes, because what the problem is, very few people, very few advocates and even lesser number of judges have any understanding of technical things. When it comes to technical things, their mind completely
you mean
shut.
medical things?
For example, something like cardiac tamponade, something very difficult. And in the same breath, if you say cardiac tamponade or something like periplaneta americana, they don't understand. They say both are same. Something. It is something like that. So it gets very difficult to make a judge understand what is actually the problem. And I have my own share of medical cases. And I really feel even today, one case that I have done and where I lost, I have done for a doctor is, a patient who was suffering from menorrhagia was detected in some remote corner of Andhra Pradesh. So somebody asked me to do that matter in Supreme Court. He diagnosed it as menorrhagia and he treated, and ultimately it turned out to be cervical cancer and the patient died. The matter reached all the way up to Supreme Court. See, the thing is, he has done a speculum test and came to the conclusion. The court held, why hasn't he got done all the tests? The simple answer is, they are about 150 kilometers from the nearest diagnostic center. So obviously he said that they can't do it, they are poor and all that. The doctor was charging 300 rupees or something, and the court has imposed 15 lakhs. So, I mean, I did that matter, I felt bad, but at the same time, there are so many cases. But the main problem is this, that inability of the advocates and the judges understand the complications, and easy to blame. So,
and the intricacies of
that is why
medical
I said I am not blaming the doctor. In my case, in fact, at that time I was doing quite a large number of medical negligence matters, but I never blamed anybody. But people are, they do come and make this, and this registry is going to create a huge problem.
Huge problem? Okay. Problem for whom?
I'm sorry, you have to do this.
Yeah.
It is necessary for actually what you are doing is good and it is necessary, it may create some problems. But one has to be, have to find a, way of getting out of it.
Yeah. I think for lack of time, I'm not going to the rest of the questions, but I think Mohan Rao Garu has kindly agreed to help with anything related to like at a policy level or at a legal level to help us in terms of any rights of individuals with disabilities.
Anything.
Thank you.
Anything, any stage, if you want, please, you can get in touch with me.
I think this is their son. Do we have audio? I think that's the last slide.
Actually want to say thank you to
कि वो उसको नहीं दिखता है वैसे भाई की बात ही थोड़ा डॉक्टर रोगी संगम पर तो सर मिली तो एक फ्रेंड की तरह एक ब्रदर की बड़ी ब्रदर की तरह है उनने जो जर्नी मेरे को बहुत हेल्प किया उनने मुझे और 500 उसी से नहीं देखा मुझे ऐसे नहीं देखा कि वो उसको नहीं दिखता है वैसे भाई की बात ही छोटा भाई होता है वैसे बड़े भाई की तरह मुझे प्रेर किया और संभाला मेरे को इतना और थैंक यू डॉक्टर लोकेश सर थैंक यू सो मच फॉर हेल्पिंग मी ऑन दिस जर्नी आपकी वजह से मैं यहाँ पे हूँ थैंक यू सो मच
I'm proud. See, whatever he suffered, visually is, I mean, every, balance movement is not there. Fine motor issues are there. And, vision is the main problem. And, apart from that, but his determination and dedication. His determination and dedication has led, he tries to learn. He has got many challenges. Now he does Paytm with whatever vision, without talkback. He has used all, he knows the apps also, the Lazarillo apps, he knows for the Google Maps, alternative Lazarillo apps are there. And apart from these apps, you know how to identify the money app is there. And he learned many things. It's very difficult to do Paytm with whatever vision he has got, only 20%. I can say less than 20. But he does Paytm without talkback. And he has got acceptance. He has only one question. Please, you people help him in, regarding the employment. And, he want guidance. He's asking, Amma, any research has come so that any chip, even the brain cells have damaged. It is not receiving the message. The backside of the brain has been damaged. The occipital region is damaged. He's asking you to help and research. And please, why don't you include the parent like me and others in your committee so that we will help as a guidelines to the future parents also. And not only that, we will also benefit. And apart from us, the other parents will also benefit. And thank you, Lokesh Garu. Only I can say thank you. Whatever you have done. Small word. Thank you.
I'm thankful to everybody, and I know that you're all doing really to do something for the children. And I think definitely doing much, much more than we advocates do for anybody. And thankful. Thanks.
Thank you. Yeah. Yeah, he's speaking quite fluent Hindi despite being born in a Telugu family. Wonderful. Thank you all the panelists. So this is just to provoke thoughts and to generate more questions which we should try to answer as a group of pediatric neurologists and pediatricians. Thank you all. Thank you. I'm sure most of you are going into hypoglycemia. So yeah. Thank you.
It's a musical night. We have a wonderful singer. I think people who can just get, because food is not allowed inside the auditorium. If you're this one, I think we can come back quickly, or we can start off because he's been waiting. He has a child with musical night will start off because he has his challenges. The boy singer has a challenges. He cannot wait for long. So we'll start it off, and then whoever can join, keep it. Yeah, we'll.
బ్యాగ్ వస్తాం.
ఇప్పుడు
Hello everyone. So we will start with our musical night. So I request Mr. Diptiman to introduce Devansh. So Devansh is from Delhi and he has been diagnosed with autistic spectrum disorder, and he is the perfect example. And hi Devansh, please come here. So he is the perfect example where parents should focus on the ability what every child has, and I request Diptiman to just give again detail about him, and then I ask Devansh's mother to come along with him and just share a few words, and then we'll start with our musical night.
Good evening. I'm sure a lot of knowledge, but the time has come for a musical evening with Devansh. Devansh, as Dr. Prashant said, is with ASD, but his major recognition is his talent with singing. So, where is he? उसको कौन सा माइक देना है?
कैसे स्टार्ट करेंगे? अभी
Hello. Good evening, everyone. He's Devans. He's on Spectrum, and we are here to showcase the ability neurodiversity can cultivate. We are representing Devans here,
Yes,
and we are supported by Diptiman sir from VIFA Lac Science, and he's coming here from Art for Autism. And we start. Music, please.
तेरी कायनात मेरे खाली हाथ और तार तार सपने गए जख्म जाग मेरे सीने आगे लगे सांस सांस तपने तेरी कायनात मेरे खाली हाथ और तार तार सपने दर्दों से चूर गम का गुरूर कहूँ क्या मैं हाल अपने आवारा आवारा अंगारा रातों में डूबा अंबर का बंजारा जाने टूटा क्यों मैं शीशा तारा तेरी कायनात मेरे खाली हाथ और तार तार सपने गए जख्म जाग मेरे सीने आगे लगे सांस सांस तपने प्यास का ये सफर खत्म हो जाएगा कुछ अधूरा सा जो था पूरा हो जाएगा आसमां दो जहां हर तरफ है मिलन कल हो ये दिल बन जाए पत्थर का, न इसमें कोई हलचल हो। सनम पे हा इश्क पे हा मिटा दूं लुटा दूं मैं अपनी खुदी कसम से हा लुटा दूं मिटा दूं मैं ये हंसती आली रहम आली याली यार पे कुर्बा है सभी याली मदद आली याली ये मेरी जाए हो गया था। ओके मुझको इतना बताए कोई कैसे तुझसे है ना लगाए कोई अब्रह्मे निलचयदानिके थनास्थि मोताने कलछे पेटोतादे अंडालानी थोड़ा से केसरिया तेरा इश्क है पिया रंग जाऊं जो मैं हाथ लगाऊं बीते वर्षा नैया वेदुई लागा केसरिया तेरा इश्क है पिया रंग जाऊं जो मैं हाथ लगाऊं दिन बीते सारा तेरी फिक्र में नैन सारी तेरी याद मनाऊं मगा मगा सरीगा केसरिया तेरा इश्क है पिया रंग जाऊं जो मैं हाथ तुमसे मिलके ऐसा लगा तुमसे मिलके जैसे पर्वत पे घटा झुकती है जैसे सागर से लहर उठती है ऐसे किसी चेहरे पे निगाह रुकती है जैसे पर्वत पे घटा झुकती है जैसे सागर से लहर उठती है ऐसे किसी चेहरे पे निगाह रुकती है रोक नहीं सकती नजरों को जो बस में, हो ना कुछ तेरे बस में चूली, ना कुछ मेरे बस में। दिल क्या करे जब किसी से किसी को प्यार हो जाए, जाने कहा कब किसी को किसी से प्यार हो जाए। ऊंची ऊंची दीवारों सी इस दुनिया की रस्में, हो ना कुछ तेरे बस में जूली, ना कुछ मेरे बस में। दिल क्या करे जब किसी से किसी को प्यार हो जाए, जाने कहा जब किसी को किसी से प्यार हो जाए। मौसम मौसम ओके। हीरे मोती मैं ना चाहूं, मैं तो चाहूं संगम तेरा, मैं तो तेरी सैया, तू है वे
Thank you, Devansh. So we request Veena Kalra ma'am, Rekha Mittal ma'am, Dr. Prashant and Lokesh sir, just to present a token of affection from our side, whatever we can do it to Devansh. I request Devansh to come here.
Varsha Vaidya is going to sing the last song of the day.
This is an extempore. Let's. No, not this one. This one. Con tujhe. I'll have to see this. This is connected, no? This mobile is connected, no? This is not. You can connect this one with Bluetooth. Let's see. I'll try. You can start your karaoke. I'll see. So मैं यहाँ पे देखूँगी आप वहाँ पे चलाओ. Let's start from the first.
आता है सीने में जब जब सांसें भरती हूँ तेरे दिल की गलियों से मैं हर रोज गुजरती हूँ हवा के जैसे चलता है तू मैं रेत जैसी उड़ती हूँ नजर का सफर तुझ पे ही आके रुके कहने को बाकी है क्या पहना था जो कह चुके मेरी निगाहें है तेरी निगाहों तुझे खबर क्या बेखबर मैं तुझसे ही छुप छुप कर तेरी आहें भरती हूँ कौन तुझे यूं प्यार करेगा जैसे मैं करती
Sure. Which song you want?
Hello, hello. याद न जाए बीते दिनों की, जाके न आई जो दिल क्यों भुलाए, दिल क्यों भुलाए, याद न जाए बीते दिनों जाके न आए जो दिल क्यों भुलाए, दिल क्यों भुलाए। दिन जो पखेरू होते रख लेते, दिन जो पखेरू होते रख लेते, पालता उनको जतन से, पालता उनको जतन से, सीने से रहता याद न जाए